The exclusion criteria was type 1 diabetes, patient who went through bariatric surgery because bariatric surgery is proven to decrease induced remission, and patients who were not giving consent, duration of diabetes taken more than 4 years, then it was not newly diagnosed, and gestational diabetes. The data collection, patients fulfilling the inclusion criteria were selected for the study. This was an observational study of cross-sectional type done in newly detected diabetes. Diagram score was used to assess the probability of remission of their diabetes. Relevant clinical data was recorded.
Result
the result was that among the 200 participants, the most represented age group was 46 to 50 years, comprising 30% of the sample. Out of 200 subjects, 103 were male and 97 were female. The ABCD score, it is seen that the higher the ABCD scores, the greater the remission was seen. And the maximum score was achieved by 5 cases, which showed complete remission probability of 77% and partial remission of 92.2%. Complete remission is HbA1c achieved less than 6 for 1 year, and partial remission less than 6.5 in 92 for 1 year. And the diagram scores were ranged from 0 to 22. The largest subgroup was seen between 3 to 7 with a remission of 66 remission probability. This diagram, the lower the score, the higher the remission. And ABCD, the higher the score, the greater the remission. Sorry.
Prospective study.
Yes, sir.
What is the meaning of prospective study?
It's a cohort study, like we give the person's medical nutritional therapy and decrease weight.
What is the meaning of a prospective, retrospective?
So prospective, we follow the patient after we give them specific meal programs and weight reduction exercises, and we follow the patient that whether HbA1c was reduced on them or not.
Prospective में primary outcome होता है क्या?
Yes sir, sorry sir.
Prospective study में primary outcome होता है क्या? या retrospective में होता है? Primary outcome किस में देखते हैं?
Sir, primary outcome retrospective.
ठीक, चलो. Second.
I am presenting the paper on comparative analysis of clinical and biochemical profiles of type 2 diabetes mellitus patient across the different BMI categories. Introduction. The body mass index BMI has been established as a key determinant in pathogenesis and progression of type 2 diabetes mellitus. Conventional understanding links obesity as a primary risk factor for type 2 diabetes mellitus, but emerging data highlights the prevalence of type 2 diabetes mellitus among the lean, normal weight individuals, particularly in Asian populations. Lean type 2 diabetes mellitus often overlooked presents unique challenges in management and in association with distinct metabolic profiles and complications risk compared to the obese type 2 patients. Methodology. It's an observational cross-sectional study was conducted at Ellen Medical College. A total 250 patients were diagnosed with type 2 diabetes mellitus according to Factors like FBS, ppbs, lipid profile, HDL, LDL, and serum creatinine and HbA1c levels were recorded. The result of the study. Total out of 250 patients, there are 52 patients which are under the lean category according to the Asian BMI index category. 115 patients are under normal category and 83 patients are under the obese category. Lean type 2 diabetes patients have significantly higher fasting blood sugar levels and HbA1c levels, indicating poor glycemic control. And the obese type 2 diabetes mellitus patient exhibits a higher prevalence of hypertension, abnormal waist and hip ratios, and positive family history of diabetes. Lean diabetics also show significant dyslipidemia. Discussion. The lean diabetics display a more aggressive glycemic profile and require more intensive glycemic control. And the obese diabetic, although having a better glycemic control, exhibiting higher rates of hypertension, dyslipidemia, abnormal waist and hip ratio. The lean type 2 diabetes mellitus patients may require early insulin therapy and closer monitoring, while the obese patient would benefit from the weight-centric management, including GLP-1 receptor agonist and SGLT2 inhibitors. Conclusion of this study is the lean diabetics, often under-recognized, represent a high-risk subgroups with poor glycemic control and increased microvascular complications. And obese diabetics, though the better control in terms of glycemia, face higher cardiovascular risk due to comorbidities like hypertension and dyslipidemia. This is the flow chart study where the distributions of the patient given. 52 patients were lean, around normal BMI category, and obese category. Here is the comparison of clinical parameters, which are like in lean the FBS is higher compared to obese. HbA1c is also high compared to obese. Hypertension prevalence is low in lean, but in obese patient it is high. Waist hip ratio is also high in obese patient, which is normal in lean, and family history is high, positive in obese patients. Infographic lean versus obese type 2 diabetes comparison. In lean patients, higher glycemic levels, earlier onset and lower insulin resistant, but the more beta cells dysfunction present. In obese patient, lower glycemic burden, more insulin resistant and higher cardiovascular risk present. Here are the references. Thank you.
Hello. So basically, what is the main inference you want to, or just one line message you want to give?
Sir, in lean patients also there is similar compared to obese also the same risk present in lean patient which are diabetic, where the microvascular change components presents like peripheral neuropathy, where the numbness like negative symptom present, like the positive symptoms include the tingling sensation, is more present in lean patient compared to obese. So we have to focus on both the category, lean patients also and obese also.
So correct. So it is basically like sometimes we feel somebody is obese, so maybe
Yes,
more
sir.
complication, more comorbid.
But it is a
Yes,
yes sir.
lean also requires
Lean also
similar
requires
or
the
maybe more
Yes, sir.
attention.
Yes sir.
Thank you.
Thank you sir.
Next.
बेटा आनंद बुलाना.
Dr. Vrindra Gowal.
Diabetic peripheral vascular disease by deep vein arterialization. India has approximately 70 million people with diabetes, making it a world diabetic capital. PVD, prevalence in individuals with type 2 diabetes mellitus, is around 30%. It has become a global health problem affecting more than 200 million people in the world. It increases the likelihood of amputation of 15 to 40 times and 1-year mortality of 22%. PVD, as peripheral vascular disease, is characterized by reduced blood flow to the lower extremities due to atherosclerotic plaque changes in the blood vessels, manifesting it as intermediate claudication, can progress to critical limb ischemia and gangrene. After coronary artery disease and cerebral vascular disease, PVD is the third major cause of atherosclerotic vascular morbidity worldwide. Management of PVD, conventionally, these patients are treated by lifestyle changes, medications, and revascularization. However, severe lower extremity vascular disease with no target vessel for revascularization, a novel technique called DVA is used. Now DVA, it is deep vein arterialization. It is a limb salvage technique used for patients with critical limb ischemia with no treatment options available. It is performed between posterior tibial artery or the anterior tibial artery and the corresponding deep veins to deliver oxygenated blood to the foot. Indications: severe lower extremity vascular disease with no target vessel for revascularization, or patients with breast pain or ischemic wound with Fontaine stage 3/4 or Rutherford class 5/6. Mechanism: it is a DVA bypass a diseased vessel and facilitates a retrograde blood flow to the deep veins into the ischemic tissue and stimulates a collateral formation and angiogenesis, allowing a wound healing and limb salvage. It also prevents major amputations in patients with critical limb ischemia, and it relieves breast pain. The pre-op assessment includes a clinical examination, ABPI, duplex imaging, and CT angio of lower limbs. The operative technique: an incision is made behind the medial malleolus and it's been exposed. The artery and the vein are being exposed. Here the posterior tibial artery is being exposed and been clamped from both the sides. And the distal end of the vein has been also exposed. And then finally, the side to end anastomosis between the posterior tibial artery and a deep vein is being made. And then we close the incision. Here the CT angio of the pre and the post-op. The pre-op picture we can see that is a dessert foot where no vessels are seen beyond the PTA. The second is a post-op picture, post-op CT angio of when the DVA was performed, where we can see the posterior tibial artery and deep veins showing a good blood flow to the foot. And third is a CT angio at 6 months, where we can say anastomosis patency as is seen. Our experience: DVA was performed in 10 patients, where we saw 100% major amputation-free survival at 6 months, 75% of wound healing in all patients, and 80% reduction in the vascular pain by 6 weeks in all cases. The post-op CT angiography at 6 months revealed patent AV anastomosis with development of collateral blood flow. There's a wound healing at 4 weeks, where we can see a major, the wound got healed at 4 weeks after the DVA was performed. The conclusion: deep vein arterialization is a last-ditch attempt to save dessert foot, where conventional bypass procedures do not work. It facilitates wound healing, reduces pain, and also the chances of limb amputation. Thank you.
Hello.
So actually, as a physician, I just want to know that how this anastomosis helps the whole blood flow. We have made a vein and artery, I
Yes.
think, the anastomosis. So how means this extra supply is through the veins or the arteries anyway, they are like now thrombosed.
Yes, it's through the veins. They have made an anastomosis. Through the veins, the veins,
So
the collateral
the veins
flow.
are now supplying
Yes.
the foot.
Yes.
And
What will be the long-term prognosis? Long-term prognosis. Or any data suggests that after 2 years or 3 years, what will be the prognosis in diabetic foot?
So
You mentioned the 6 month only,
yes,
but the diabetic is a chronic.
yes.
It is not reversible at that moment. So after 2 years or 3 years, what will be happen with this graft or arterialization?
So I would say it would prevent the amputation, diabetic foot. Like if blood flow is through this anastomosis, it can, in longer term, it can prevent amputations. It can also prevent sepsis and all these things.
Any data for the long-term prognosis?
As of now, I do not have it, but my
It is
guide might have.
Only in 10 patients, I think it will not tell. So it may help,
Yes.
but there is no data, I think.
Yeah, as of now, I'm not aware of it, but I'm sure my guide must have know it.
Yeah, it may prevent acute condition,
Yeah,
but
it
maybe
may be prevent the
long-term,
acute
It
condition.
is just
Ma'am, I want to say.
Brinda, have you done anything regarding HbA1c correlation with this?
No.
No. You have not seen, like when you were taking patient, HbA1c was seen of those patients, or it was not seen?
No, it wasn't.
It wasn't seen.
No.
Okay, thank you.
Thank you.
Any other candidate? Next.
In case of a cardiac contusion. So, a 77-year-old female presented to us with chest pain and a referral slip from the government hospital to our medical college. The referral slip mentioned a history of severe chest pain with shortness of breath since 3 days. They did the ECG over there, which showed ST elevations from V1 to V5 in the anterior lead, and the treatment they given was on the cardiac lines, like they give the cardiac loading dose as well as they given the heparin. They didn't thrombolize the patient because the chest pain was of 3 days, it was out of the window period. She had no relief in chest pain and the patient took discharge from there. When we received the patient, she had retrosternal chest pain and it was ongoing since 3 days. Patient was a known case of hypertension since 5 years. There was a history of CVA 5 years back. She had no lifestyle risk factors. The patient's vitals on admissions were blood pressure of 140 by 80 millimeters of mercury BP, pulse was 110 per minute, and these were the respiratory rate and saturation. On auscultation of the cardiovascular and respiratory system were normal. On physical examination, local tenderness was there on mild chest pain. This was the ECG showing the elevations. She had history of road traffic accident 3 days back, and for further probing, she told that she fell on her chest on the dashboard of the car. So X-ray was normal. We couldn't find anything. Surgery and orthopedicians were also called. They couldn't find any rib fracture. The blood work was, her troponin was 46,000 and CKMB was 270. So these were the troponin reports. So we planned HRCT thorax because the chest pain was something different. She was not getting relief, and this was a HRCT. You can see a very well transverse fracture of the manubrium of the sternum over there. So this was a transfer fracture of the body of the sternum with lung contusion. There was minimal hemothorax and minimal pericardial effusion. So this was the transverse fracture of the sternum. So surgery team was called, and her ST elevation settled after 4 days without any progression, like there were no T wave inversion nor Q waves. So we should always remember ST elevation denotes cardiac injury, any kind of injury. It can be contusion also, not necessarily always a ischemia. And this is the progression of the ECG in case of MI. But this, it is not seen in case of contusion. This evolving ECG pattern is not seen in case of cardiac contusion. So this patient luckily wasn't thrombolized because she had a history of 3 days. So the government hospital people didn't thrombolize her on the basis of the day of duration. So the causes of rest troponins are many, and in this case, it was a case of cardiac contusion, which raised to raised troponin levels. So this is the sternum. So always we should take the history is very, very important, and just the examination is important. So there is coup and counter coup type of injury to the heart. This patient has a coup injury. So myocardial contusion, it is reversible. Changes will be seen. There is no coronary occlusion, and whereas the regional wall abnormality will be reversible. Thank you.
What was the treatment for that patient?
Sir, she was taken up for with the cardiothoracic surgeon. She took her for wiring and plating of the sternum.
You did the wiring?
Sir,
or plating only?
Sir, plating was done.
So what about the indication for the plating?
Sir, actually the patient in our hospital it was not there. So if we transfer it to another. If sternum fracture is displaced, and what we say is the age of the patient, if she is not able to move and she is critical, then we need to, sir, plate.
I think it is a new thing which are doing the CTBS surgeon regularly. Most of the center doesn't have the facility, and CTBS surgeons also do not this type of the procedure. But nowadays the flail chest or more than 2 ribs are fractured, the patient should be taken for the surgery. Yes. And also data are coming that if you are doing early, the prognosis was very good.
Yes, sir.
So more than 2 fracture in yes, continuous rib fracture, it should yes, be taken. Just also a indication for that.
Okay. Yes, sir.
Any question?
I would just like to see your. It's so fast, we will not able to see. Okay, so it's not that typical of MI also in
yes,
the CCG,
yes,
right?
Yes, ma'am.
Hannah, there are no reciprocal changes
no
also.
No reciprocal changes, yes, ma'am.
So we could suspect something else yes, with this ECG, I
yes,
would say. Yes,
like in inferior leads, there are no reciprocal changes.
No
also.
reciprocal changes, and the ST elevation is also not like 2 mm. It's yes, not more than 2
yes,
mm, I would say.
Yes,
okay, so we could suspect something else for the cause
yes,
of
yes, ma'am.
Okay.
Yes, ma'am. Yes, thank you.
Glycemic variability on outcomes of patient with sepsis in ICU. Introduction. Glycemic variability encompasses the dynamic fluctuation in blood glucose levels that occur throughout the day, accounts for the variation in blood glucose level that happens at the same time from one day to another. Recent studies have identified glycemic variability as a third component of sepsis-induced dysglycemia alongside hyper and hypoglycemia. Aim of a study to evaluate the relationship between glycemic variability and clinical outcome in patient with sepsis admitted to ICU. Objective to determine the effect of glycemic variability assessed by the standard deviation of each patient's mean glucose level on outcomes in adult patient admitted in ICU with the diagnosis of sepsis. Material and methods. Study design, prospective observational study. Duration of study was 1.5 year and sample size was 180 patients. In ICU patients with random blood glucose more than 180 mg per dl on 2 consecutive reading, start insulin infusion as per EL protocol. Mean blood glucose level, standard deviation of mean glucose level and coefficient of variation of glucose has been calculated for each patient, severity of sepsis is graded using SOFA score. Inclusion criteria. All patients aged above 18 years admitted in ICU with the diagnosis of sepsis, both known patient of diabetes mellitus as well as non-diabetes. Exclusion is less than 18 years patient and patient with a period of hospitalization less than 48 hours. In my study, there is 63% of male patients and 37% of female patient and SOFA स्कोर से ग्रेडिंग किए थे पेशेंट की, इनमें 4 to 10 जो इनका स्कोर आया था SOFA स्कोर वाले वो अराउंड 40 पेशेंट्स थे एंड स्कोर 11 to 16 पेशेंट वाज 70 के अराउंड थे और 75 जो 17 to 24 थे. Association of glycemic variability with outcome. If there is high glycemic variability, there is a higher chance of mortality and discharge rate was low discharge rate, and if there was no variability, then discharge rate was high. Association of glycemic variability with outcome in patient with mechanical ventilator. In high glycemic variability patient, there is a high chance of patient going to mechanical ventilation. Association of glycemic variability.
Kindly conclude.
So, discussion, significant association between glycemic variability and patient outcome. High glycemic variability patient में sir higher mortality rate and lower discharge rate रहता है, and patient who died have worse glycemic matrix including higher HbA1c levels.
How do you measure that glycemic variability in all patients?
सर ग्लाइसेमिक वेरिएबिलिटी सर एक ही पेशेंट में सेम टाइम में मतलब हाई ग्लूकोज लेवल भी आ सकता है और लो ग्लूकोज लेवल भी आ सकता है सेप्सिस में मेनली सर इसके लिए अपन इसमें कोफिशिएंट ऑफ वेरिएशन जो मीन ब्लड ग्लूकोज लेवल उसका निकाला था सर.
No. See, when you
हाँ सर every 7 point charting every 3 to 4 hourly.
मतलब CGM device was not used. We wanted to ask that. CGM was used or not used? Continuous glucose monitoring system was there or not?
Yes, ma'am. In ICU patient was there.
ICU patient? It is recommended or not?
Sir, no.
But then why do you say that you are using the CGM in ICU patient? And it is not recommended that in ICU, if you are doing the 3 to 4 hours blood sugar, it is only hourly measurement. Then you will tell some glycemic variability, I think.
And what about comorbidities, whether they won't have any, whether the patients were having similar comorbidities? When you want to see the outcome, we have to see the comorbidities also associated.
Sir, comorbidity वाले patient नहीं लिए थे sir.
And how was their HbA1c, the blood sugar levels prior to hospitalization?
Sir, HbA1c levels जिनका इसमें दोनों patient लिए थे sir, diabetic,
because the
non-diabetic.
baseline should almost be the same.
Yes.
If you take somebody who was already sick or not doing well with multiple comorbidities, definitely the end result may vary.
Sir, this is a study about the glycemic variability on sepsis patients, sir. Diabetes, non-diabetes का वो
नहीं, यदि तुम्हारी स्टडी में 40 पेशेंट HbA1c 7 के हैं, 40 पेशेंट HbA1c 9 के at the time of admission, is there any difference in the result?
Yes, sir.
So
High HbA1c levels में sir high chances of developing adverse reaction and mortality rate was high.
It will affect the outcome at the or short term outcome.
Affect outcomes.
And okay.
That is the most important thing. And to show glycemic variability as an independent factor, you should make sure that they all have a controlled glycemia or they are all at the same HbA1c. If you're showing glycemic variability with a person having an HbA1c of 9 and glycemic variability with a person having an HbA1c of 6.5, it doesn't become significant. So you will compare one independent factor provided other factors remain the same. And ventilator has its own dynamics, including ventilator and non-ventilator as a mixture, I think does not make sense. You should have a very focused target group of patients, and sepsis also has to be designed. Was a procalcitonin high? What were the parameters of sepsis? That has also got to be correlated.
Next.
पीपीटी फॉर्म में दे सकता हूँ। हाँ है, हाँ है ना। मोबाइल में होगा, लाना पड़ेगा। देखो ये पीपीटी फॉर्म आप पीडीएफ
You can just go through the main this thing. Introduction is not required.
Yes, sir. A very good morning to each and everyone present here, sir. My study was to study the cardiac changes in chronic kidney diseases using ECG and echocardiology, sir. This study was conducted, sir, in my own, sir, hospital, sir. It included, sir, 218 patients, in which my inclusion criteria was diagnosed cases of CKD and patients with age group above 18 years, and exclusion was patients below 18 years and who were known case of RSD or some myocardial infarction, sir. Sir, the results were
First conclude it. Conclusion.
Okay, sir. Sir, this study demonstrated a high prevalence of cardiac abnormality, structural, functional and electrical among patients with chronic kidney disease, especially in those with advanced stage renal dysfunction, sir. ECG findings revealed a significant incidence of left ventricular hypertrophy, left bundle branch block, STD changes with echocardiography, which confirmed LVH, diastolic dysfunction and systolic dysfunction, sir. These findings underscore the critical interrelationship between kidney and cardiac health. Early detection of cardiac complications through routine use of ECG and echocardiography can guide timely and effective interventions, given the impact of cardiovascular disease on morbidity and mortality in CKD patients. Incorporating regular cardiac assessment into CKD management protocol is essential, sir.
What is your mean duration of diabetes in this study?
Sorry, sir.
Mean duration of study? Mean duration of diabetes.
Sir, in this study, sir, there wasn't. It was a yes or no study whether patient had diabetes or not, sir. A mean duration of diabetes wasn't taken into account, sir.
No, see, all these, you have to take the comorbidities also, duration of diabetes also into account. The other confounding factors also should be taken, because see, this is like a cross-sectional study.
Yes,
what I think that, but still we have to see the duration of diabetes, as Dr. Promise said, and other comorbidities also, because those will definitely affect the overall means the including the CKD also of patient. So I think
diabetes, hypertension, sir, known case of thyroid disorders were taken into account, sir, along with this.
Suppose you have a patient of the duration of diabetes 1 year or 6 years. What will be the difference between these cardiac findings?
Sir,
or it depends on the EGFR?
Sir, gradually, sir, if it will lead to, sir, eventually it will lead to greater incidence of, sir, diabetic nephropathy with greater intensity. And as the disease progresses, as the diabetes duration increases, the EGFR will continuously decrease, sir.
Can you tell the ECG triad which is commonly observed in CKD patients?
Sir, hyperkalemia, sir. Sir, tall tented T waves can be seen, sir. Sir, eventually, sir, it will if hyperkalemia. Sir, hyperkalemia, sir. Sir, eventually, sir, sir, U waves can be seen, sir, and sir, ST prolong. Hypo, sir. Sir, prolongation can be seen, sir. QT prolongation can be seen, sir. Sir. Okay, sir. Yes. LVH pattern, yes.
Have you seen the CKD staging of the patient you have done?
Yes, ma'am.
What stage CKD was there, and
Yes, ma'am.
in whom you got this? How many years of CKD was there? Patient was on hemodialysis or just on the...
Ma'am, mostly patients were of CKD stage 4 and 5, ma'am. And it was also taken into account, ma'am, how many patients were on regular hemodialysis.
Does the ECG findings came out more in that
Yes,
patients
ma'am.
or what?
Yes.
You want to say what is the final insight?
Ma'am, all the changes which are seen in this study, it is found more in patients with CKD stage 4 and 5, ma'am, like LBB and ma'am LVH.
तो 18 साल वाले को LVH नहीं होगा ना?
Yes, sir.
मतलब यदि 1 साल की ड्यूरेशन है तो why do you include that?
Sir. Thanks.
आकाश सिंह सर कहाँ पर है? आज तो इसका करा दो, मैं श्री राम अग्रवाल के हाँ. So quickly we'll move on with the first session for today. Dr. Shriram Agrawal, I would like to cordially invite you. And for this, the chairpersons are Dr. Akhilesh Pratap Singh sir and Dr. R.P. Patel sir. Please come to the dais.
So, can I start, sir? So, good morning to everyone present here. The topic of presentation is cardiovascular risk assessment, right from our clinics to cath lab. So, this is, you can see the patient coming to our clinic and we can take her till the cath lab for the cardiovascular risk assessment. So we all know CVD remains the leading cause of morbidity and mortality. And these are the various spectrum of the heart diseases ranging from coronary artery disease to cardiomyopathies to arrhythmias to peripheral vascular disease. And so majority of death are due to heart attack and strokes, as we all know. So what are the various risk factors we would be seeing in a different subgroup of the population, be it hypertension, diabetes, dyslipidemia, sedentary lifestyle, and recent we have come up with air pollution and stress. So we all know diabetes do have an increased cardiovascular risk as assessed by various case control studies, and the mechanism may include oxidative stress, endothelial dysfunctions, and accelerated progression of CAD. Hypertension, if long-standing and uncontrolled, may lead to various target organ damage. And dyslipidemia, we all know in spite of significant LDL reduction, there does remain a CV risk profile, and which has been tried to reduce with icosapentile ethyl, reduction of the triglycerides, the recent PCSK9 inhibitors. There is a role of genetic as well, as we can see with the early mortality, those with a high risk score in familial hypertriglyceridemia patients. Also, other risk factors are chronic kidney disease and obesity, which is coming up in an alarming population. And weight loss of 5 to 10% does improve BP, glucose, lipid parameters, and also causing a significant cardiovascular risk reduction. Coming up new in the list are smoking, air pollution, and CV risk. Air pollution now has been linked to increased CV mortality as proven by various studies. The alarming population of psychosocial stress is causing increase in cardiovascular risk as assessed by sleeping less than 6 hours. Many of our the patients of this, then it is linked to 20 to 30% higher CV risk. Also, work stress and social isolation are independent CV risk factors. Now, pregnancy itself has been defined as a risk factor for risk enhancer since 2019 in ACC guidelines. Also, being present in India, being born in India, and having a South Asian ancestry is an independent risk factor for CV mortality. So early identification helps clinicians to identify asymptomatic high-risk individuals. We can initiate preventive therapies in those who are needed and optimize resource allocation, avoiding unnecessary testing. Also, delay or prevent progression to major adverse cardiovascular event. Suppose this is an example that we have young adult with multiple metabolic risk factors, and which is termed as low profile in usual clinic without inculcating the risk factor. There can be a delayed diagnosis which may lead to early MI in his 30s or 40s. Similarly, we can have an elderly patient with atypical symptoms and normal ECG, which may be missed angina and which may cause ultimately leading to cardiac dysfunction and late referral. Similarly, there are consequences of overestimating risk, like we have mild risk patients sent prematurely for invasive angiography, which may lead to unnecessary procedures, radiation exposure, as well as risk for renal injury. Overuse of statins in low risk or lower age group patients may lead to unnecessary side effects or dysglycemia. So clinical balancing is the key. Risk stratification is not about labeling patients. It's about guiding timely and appropriate cares. So why use risk scores? Because they are objective and evidence-based risk reduction. Coming on to first, the age-old Framingham risk score. It didn't had many of the South Asian population, and that is why it underestimates risk in South Asian by 30 to 40%. It's primarily validated more in white American population. It's limiting its generalizability. So these are the scoring based on score high, intermediate. High is more than 20, intermediate is 10 to 19, and low is less than 10. We can initiate appropriate therapy. Coming on to this famous ASCVD risk estimator, which estimates 10-year risk, and statins are primarily indicated for more than 7.5% in the 10-year risk. But it also had certain limitation. It is not undertaking the newer risk markers which has come up, like lipoprotein A, coronary artery calcium, CRP, which are important risk classifiers. So this is the calculator, which they have their own separate app. SCORE2 and QRISK are basically European models, and almost 13 million Europeans this score was validated. It is not validated in Indian cohorts. QRISK score includes migraine, SLE, mental illness. These are the conditions which are not commonly grouped to be cardiac risk factor, but they have taken into account. SCORE2, it includes CKD and age region calibration. So these obviously then migraine also a risk factor for CV cardiac risk factor and CV mortality. So these are the details of score 2 and Q risk 3. We have to independently tick all of the risk factors and it will calculate the score. So there are others like Reynolds, which are not commonly applicable in India. So choosing the right score, it is match score to region and population type, consider availability of the parameters. So why risk markers were developed when we have so many scores, why they were developed? Because traditional risk scores, as I already alluded in the previous slides, they have various limitations. And advanced biomarkers in imaging tool provide deeper insights into subclinical atherosclerosis, the process which is undertaking but the patient is not aware of. So risk scores estimate probability, but risk markers actually may reveal hidden pathology. So we all know we have in our bucket various risk markers like coronary artery calcium, hsCRP, which indicate inflammatory activity, lipoproteinase, a genetically marker more than 50 said to be high risk factor, apolipoprotein B because it is indicative more of all the atherogenic particle will be having ApoB in their core. Carotid intima media thickness, ankle brachial index less than 0.9 and other genetic risk scores. So these slides highlight each individual beat hsCRP, which is more than 2. They are telling it to be a risk marker. Beyond LDL, we have already seen in one of the slides that non-HDL is a better risk predictor when triglycerides are more than 200. And ApoB in the coming years, we will see they will be soon incorporated in the guidelines, and ApoB will be the best marker as what we are having LDL today. If NT-proBNP and troponin are elevated in a normal asymptomatic individual, that is predicting a future HF and CV events. The upcoming markers which are coming are GDF15, ILS6 and myeloperoxidase. So now coming on from lab, we have imaging transition. So we have a plethora of investigations like stress ECG, TMT, echocardiography, stress echocardiography, what we call dobutamine echocardiography. Then we have CT modalities including calcium scoring and CT angiography. So why there is a need? Because there is evidence that there is a progression of subclinical atherosclerosis which lead to subclinical to clinical presentations. Then we have various atypical presentations, and based on ASCVD risk scoring, we have intermediate patients where the score lying between 5 to 10, they need further testing whether to initiate a statin therapy. So there is the chart depicting each of our non-invasive tests, be it TMT, which indicates exercise-induced ischemia, resting or stress echocardiography. It is done with dobutamine at a lower dose and increase, and we see for the presence of wall motion abnormalities. Then along with, if the patient is undergoing CT angiography or CT coronary calcium scoring, we should always order for calcium scoring if the patient falls in intermediate risk group. Carotid intermediate thickness more than 0.9 and ABI ankle brachial index less than 0.9. That is how you should remember. Both have the same scoring, but it is one is more than 0.9. As you can see in the cartoon that there is intima media thickness and ankle brachial. We have to measure the blood pressure in both ankle and the dorsalis pedis, and if it is less than 0.9, it is specificity for peripheral artery disease, which is linked to 2 to 3 times higher CV mortality. Now calcium scoring, as we will be also seeing the images of them. The 2018 ACC guidelines have clearly recommended calcium scoring to be incorporated in the medium risk patient, those lying between 5 to 10%, and those who are having apprehension of whether to start any statin therapy. They need more proof. So around the cost is around 3,000 to 7,000. It depends, varies on center. So you can see the clear pictures. These are Houston scorings, and they may range from 0 to 300 plus. And it is also advocated that a score of 0 is actually a warranty that you may not have any of the ASCVD event for the next 10 years. So this is a very good scoring system, and more than 300, it is obviously increased risk for heart disease. Also 100 to 299, it has moderately increased risk. So clinical integration should be done when ASCVD risk is borderline or the patient is reluctant about long-term statin therapy. Stress echo, whenever the patient is unable to do his TMT, we ask for stress echo, where we give the stress to the patient in the form of dobutamine therapy, which is firstly in the low dose and then starting on to the higher dose. So non-invasive imaging bridges the gap between statistical risk, which is obtained by various risk scoring, what has been alluded in the previous slides, and anatomical reality, where there may be subclinical atherosclerosis, where the clinical scores are uncertain. Despite all this, there is a limitation of all this, and despite the scoring and the imaging, we may sometimes misclassify the lower risk patient as higher risk patients. So from imaging to cath lab, non-invasive imaging identified patient at high likelihood of coronary artery disease. However, not all positive imaging warrants immediate intervention. We should be careful about the selection of the patients for invasive testing. The move from imaging to cath lab should be evidence-based, balancing benefit and procedural risk. So as we have already seen in the previous slide, apart from the TMT and CT angio, we also have myocardial perfusion, the SPECT imaging, where it identifies the abnormal, that is perfusion defects, not the normal. Whereas the cardiac MRI, it is done for assessing the myocardial viability. We have certain patients with LV dysfunction where we need to assess the role of this modality, whether to revascularize the patient or not. So these are the various imaging modalities. As I already told you, the nuclear imaging assesses the myocardial viability, whereas cardiac MRI assesses the function. So risk assessment in cath labs, patients with ACS and no prior assessment often show high CAC. IFR, FFR is also done in borderline lesions, and IVAS OCT provide detailed plaque morphology for complex CAD. So now the latest coming up is the subclinical CAD. We have metabolic signature, where such instruments will, coupled with chromatography, are the main analytical technique. Metabolics will redefine the whole procedure, how we do and how we assess the risk factors in our patients, and inaccurate stratification using current model is a challenge, and that is why they have come into the picture. So the main limitations of these modalities are underutilization because of a busy OPD practice, and lack of uniformity there are no proper guidelines when to refer to the cath lab. There are disparities by the clinics, gender, and the socioeconomic status. Two slides about last few slides. 2 slides about artificial intelligence. We already have these softwares. You can download Prompt and CAT-RATS, where they take into multiple variables along with the data of imaging, and they can give a very well predicted risk models. As I already told you, they are also being incorporated into coronary artery calcium scoring, and we have variables, Apple Watch, where the patient is bringing into the ECG. So the clinical is to combine these risk assessment into our clinical practice, combining all the clinical, biochemical, imaging.
Dr. Sriram, kindly sum up the...
Yeah. So this is a stepwise approach, how we should first, as I already told, history is very important, then coming on to labs, non-invasive, invasive imaging, and finally we should undergo lifestyle modification and certain pharmacological interventions in the form of statins, SGL2 and GLP to reduce the risk. So thank you very much.
We can take only one question.
According to the calcium score and the plaque, type of plaque, in which plaque or to this your calcium study we can go for the cardiac intervention, and where we cannot go?
Sir, firstly, calcium scoring is mostly recommended in the asymptomatic intermediate group of the patients, where the ACC 10-year score is coming between 5 to 10%. Suppose we have a young 34-year-old patient who is having dyslipidemia, but who is apprehensive of starting statin therapy, maybe because of dysglycemia in the future. So that calcium scoring coming. Coming on to your second question of plaque morphology, sir, that is better visualized in IVAS or OCT when the patient is taken into the cath labs, because the calcium scoring alone may not give us any idea about the plaque morphology, whether it is a calcified, whether it is fibrous, atheroma, or there is lipohyalinosis. We will not be aware just on the basis of CT coronary or calcium scoring. Better tools, that is why they have come into, is IVAS and OCT when the patient is undergoing the procedure.
What do you mean by the stable plaque and
Sir, that depends on the morphology, how we obtain in the IVIS. Basically, the stable plaques are, they usually do not, they have a low risk of embolization or developing, causing major lesion more than 70% in the large arteries. They usually, that depends on the morphology or how we obtain in the IVIS or OCT, sir. Sir, that will also be determined based on the lesion size, sir. That will also be dependent on the lesion size, sir, and based on the morphology, and also depending on the comorbidities.
Pankaj Verma, sir, Dr. Sushil Kelly, sir, to please come up on the stage. Dr. Pankaj Verma, sir, Dr. Sushil Kelly, sir.
Thank you very much. I am very grateful to Dr. Abhishek Srivastava and the entire team of Indocon and CCDS MP chapter for calling me here. Today I'll be talking about sarcopenia in adults with diabetes. Now you know there is a rising burden of diabetes, and we always talk about micro and macrovascular complications of diabetes. However, sarcopenia is a very less talked about entity, and it is very, very important. Now this is the diagram of the skeletal muscle, and you know that the skeletal muscle, basically there is a bone, which is tendon is attached to the bone, then the muscle, then the muscle fibers, myofibrils, and myofilaments. These myofilaments contract, relax, and the movements of the body occur. The body has several types of muscle fibers. You must remember two muscle fibers. Type 1 muscle fiber, which are the slow-acting muscle fibers, which are responsible for the aerobic activity, and they predominantly are involved in lipid beta oxidation of lipids. And type 2B fibers are the fast-twitch fibers, which basically you can make sudden movements. So the type 2B fibers are most important, and you age, you lose type 2 fibers. They may be converted to type 1, or they may be lost entirely, replaced by fibrous tissue. And it is our endeavor to preserve these type 2B fibers as we age. Now this is a unit basically. You have the nerve which is innervating the muscle fiber. These nerves may be affected by central nervous system disease like stroke, dementia, degeneration. The anti-horn cells may decrease with aging. The neuromuscular junction integrity and the neuromuscular chemicals may be decreased, and although these may lead to loss of integrity of the neuromuscular junction, which can cause muscle to sort of decrease, muscle fibers to decrease and die. You have the muscle stem cells, which may decrease with age. You can have fibroblast, adipose, progenitor cells, which can differentiate to fibroblast, adipose tissues, and even myocytes. And you, unless you have the right strategies, these will differentiate into fibroblast and adipose tissues, which will cause sarcopenia. And then you have innervation of the blood supply to the muscles, which is also very, very important to preserve the muscle tissue. Now you see that these are two people. This is a marathon runner, a legend basically, and this is a sarcopenic individual. A marathon runner also has a very low amount of muscle basically. So does this mean that he has sarcopenia? No, he does not have sarcopenia, because sarcopenia is not only defined by muscle mass, it is defined by muscle strength and low muscle performance. So muscle strength and low muscle performance are the primary requisites of sarcopenia, not the muscle mass. You can have several drugs which can increase the muscle mass, but the muscle power and function will not improve. It is 2 to 3 times higher in diabetics, It is a covert entity, gradually progresses to a clinically important thing. It is masked by obesity in several cases and underdiagnosed because it is less well known. Now this is the sarcopenic obesity, this is the sarcopenic obese person, and this is the obese person who is not sarcopenic. So you have to differentiate with muscle power, muscle function. More than 30% fat in men, more than 40% in women, sarcopenic obesity. You can also have a normal weight obesity also, and as you become obese, your physical activity declines, your BMR decreases, insulin resistance, inflammation increases, and that leads to sarcopenia. India, in the general population, younger population, around 18%, one of the highest incidence of sarcopenia. In adults, almost 39.2% incidence of sarcopenia. And you must remember that sarcopenia is always associated with osteoporosis and osteopenia. So these are common entities. Now this is how the muscle is gradually lost with aging. The muscle strength declines with aging. After 40, there is 0.5 to 1% loss of muscle mass every year, and this accelerates after the age of 60 to 70s. The ectopic fat, visceral fat, and the muscle fat increases with the loss of muscle fiber. So the factors responsible for loss of sarcopenia are inflammation, chronic inflammation, very important, chronic conditions which you will see, neurological disorders, we have seen bad genetics, old age, poor diet and gut dysbiosis, physical inactivity, disability like stroke and all, abdominal obesity and mitochondrial dysfunction, and the decreasing hormones like testosterone, growth hormone, which occur with age. The mitochondrial biogenetics is adversely affected. You have less number of decreasing number of mitochondria, decreased protein content is also becomes suboptimal, and you have the autophagy is also lost basically, and this leads to accumulation of the sick mitochondria leading to sarcopenia. The risk factors: age, gender, physical activity, diabetes, malnutrition, smoking, extreme sleep deprivation, chronic diseases, and these are the chronic diseases. And you can see diabetes is one of the very major cause of osteopenia, apart from other chronic diseases. And diabetes basically by way of insulin resistance, inflammation, increased fat mass, aging, increased reticular activity system, poor lifestyle, all leads to sarcopenia. The physical activity is also very, very common in diabetic individuals. Age more than 45 years and more than 2 oral hypoglycemic rates are risk factors for sarcopenia. And sarcopenia leads to reduced physical activity strength, mobility disorders, reduced independence, bone fractures, osteopenia, all cause mortality increase, reduced body fat reserves, fat protein reserves, stress incontinence, nutritional status is bad, macrovascular diseases, dementia, Alzheimer's disease, insulin resistance, type 2 diabetes. So everything is basically higher in patients with sarcopenia. To diagnose, you should have the diagnosis of muscle strength. You can have hand grip basically, which should be more than 20.7 kg in men and more than 16 kg in women. You have BMA and bioimpedance, basically DEXA and bioimpedance, to see the muscle the muscle percentage. However, muscle percentage does not translate into muscle power and muscle function. So test of muscle power and muscle function are most important, and for showing the physical activity, physical function, you have to go for chair sit-up test. You also have to go for the speed test. There are several tests designed. If you cannot do DEXA, then you have to see the bilateral calf circumference, which should be more than 34 in men and 33 in women. So these are the viral tests. There is also a questionnaire, which is a SARC-F questionnaire, which is administered to know the chances of sarcopenia. So any diabetic which is, any person which is more than 60 years of age, or if he has any risk factors of sarcopenia, should be screened for sarcopenia. And we have probable sarcopenia, which is low muscle strength, confirmed sarcopenia, low muscle mass with low muscle strength, and severe sarcopenia, and when all the 3 parameters are affected. Coming to the management, aerobic exercise increases mitochondrial numbers, increases beta oxidation, and it is good for cardiorespiratory fitness, but muscle gains are very, very minimal with aerobic exercise. HIIT is a better modality for deriving the metabolic benefits, and it has good benefits in addressing sarcopenia. The most important modality to use is resistance training, which improves the muscle mitochondrial protein content basically, and improves your muscle mass basically. So resistance training is very, very important. You can see that these are patients who are running marathon, they don't have muscles, but this person which HIIT has better muscles. So HIIT is a better thing. Resistance training translates into a better muscle mass and muscle power. Now there are two types of resistance training: concentric, where you basically flex the this thing. It is good for improving muscle mass, but in adults we have more chances of fractures and falls while the patient is going down, and there this modality does not help. What helps is eccentric training basically, where you basically lower the arm with the weights, or you lower your body against gravity, leading to improvement in those muscles which are useful in climbing down, and this is a better modality for as adults. Apart from the flexibility exercise and balance exercise, also very important. Combined modality, multi-modality exercise is most important to have overall benefits basically. Therefore, the guidelines say that every day you should have 30 to 60 minutes of aerobic activity and at least 2 times resistance training per week to have a good muscle improvement. And these muscles are not permanent. You have to do exercise at least alternate days. If a person is lying in the bed for 10 days, he loses 500 grams to 1 kg of muscle in these 10 days. So it is that fast. Now, regarding the protein intake, we should debunk the myth. The protein intake is around 2 grams per kg basically, which is postulated. Younger people can do away with 1 to 1.5 gram protein per day, but elderly require around 2 to 2.4 grams per day because of anabolic resistance. Leucine and essential amino acids, very, very important. HMB, a substitute for leucine, surrogate for leucine, also important. Vitamin D is also very important to address the vitamin D deficiency and the inflammation. Omega-3 acids address the inflammation and improve sarcopenia. Creatine supplement is very, very important basically, and we should go for a balanced intake of proteins, creatine and leucine and the essential amino acids as well as trace elements to derive the maximum benefit in our patients. The protein should be divided into 4 times, 30 to 40 grams, taken 4 times, not as a whole entity. Antioxidants also very important. Collagen, polyphenols, is also very important. Sleep is very important. Around 7 to 8 hours is important. Less sleep and more sleep is detrimental. Maintaining your circadian rhythm, sleeping the night is very, very important. Otherwise, you lose your muscles. Smoking, alcohol to be avoided. Stress and cortisol to be avoided. Stress related is more cortisol. And again, there is a role of gut dysbiosis. You have to go for anti-inflammatory diets, healthy diets to promote your muscle growth. Coming to the role of medications, metformin has mixed results, but it is proved to be beneficial. Should always be combined with resistance training and exercise. Sulfonylurea decreases muscle mass. Insulin is anabolic, provided your blood sugars remain controlled. DPP-4 and thiazolidines are good for muscles. With the SGLT2 inhibitors and GLP-1 analogs and tirzepatide, you have to go for resistance training to prevent your muscle mass. Coming to the therapy with hormones and other drugs, testosterone only to be given in patients who have low testosterone levels, not good for those who have normal testosterone level. These are the selective androgen receptors which replicate the effect of testosterone without causing the side effects of testosterone. Also recommended in hypogonadal deficiency, growth hormone, IGF, and ghrelin, which acts by increasing the growth hormone and IGF, again useful in deficiency states. ACE inhibitors, beta-2 agonists, and metformin are also shown to be beneficial, and studies are underway. Coming to the emerging drugs, there are 2 main class of drugs, myostatin inhibitors and the activin inhibitors, which are under phase 2, phase 3 trials. They are known to increase the muscle mass. However, whether they improve the muscle function or muscle strength is being tested, and these drugs are still not approved basically. Peptide therapies and senolytics and sarcopenia therapies are also under trial basically for this thing. Neuromuscular electrical stimulation is another modality, and gene therapy and myostatin editing is another therapy is trying. So to summarize, sarcopenia is a progressive loss of skeletal muscle mass, strength and function. Prevalence around 17.5 in adults, 39.2 in elderly population. The prevalence is higher in the elderly and diabetics. type 2 diabetes accelerates muscle loss and strength. Sarcopenic obesity and the normal weight obesity is very common in diabetics. Risk factors: aging, diabetes, inactivity, malnutrition, gut diabetes. Symptoms are often recognized, leading to frailty, falls, and early mortality. The diagnosis is by diagnosing the muscle mass, strength, and physical performance. Exercise, combined exercise boosts your chances of prevention of sarcopenia, and there are the protein and leucine, branch chain amino acids, creatine, and other trace management supplement does wonders basically for your muscles. There are a lot of research, basically this is a key area of research, and in next decade you will see many therapies coming out for sarcopenia. We unfortunately do not have a good diagnostic criteria for sarcopenia because these criteria vary from country to country, and we do not have age-specific criteria for sarcopenia. Thank you.
Hello. Thank you very much for a very comprehensive talk. And see, I've got 2-3 questions, short questions. One is about the fatty liver and the genetics and mitochondrial effect on the.
See, mitochondria is key to all the metabolic diseases. So the entire research is now on mitochondria only. So what aerobic exercise does is increases the number of mitochondria, moves the mitochondria towards the muscle myofibril membrane. So the intake of the glucose is very much improved by the GLUT4. The GLUT4 density also increases. So basically the numbers, density, and your function of the mitochondria improves. Also there is an insulin independent intake of the sugar in the muscles basically. So that is another modality of improvement in the glycemia with this. What resistance training does is improves the mitochondrial protein content. It is not shown to improve the mitochondrial numbers basically. But because the content improves, the mitochondrial function improves, and you have a more of mitochondrial flexibility and better mitochondrial functioning basically, which also leads to improvement in your sarcopenia basically. Another thing is that the blood supply to the, when you start exercising, initially the stroke volume increases, and by way of stroke volume your improvement in the muscle blood supply is there, but subsequently as you go on exercising, there is an increase in the capillary density supplying the muscles, and that leads to further improvement in the blood supply, and that preserves the muscles and allows it to grow. But for it to grow, we need these supplements also, which have to be taken. See, type 1 diabetes, if diabetes is not well controlled, you are having excess risk of sarcopenia. I have not taken it in my talk because it was for adults basically, but in diabetes, in type 1, it is very clear that you have to have a very good control of sugars. Insulin is an anabolic hormone, so it is not going to cause sarcopenia. But if sugars are not controlled, then you are going to definitely lose your muscles by way of protein loss. So that is basically the differentiating feature. Otherwise, if the patient is well controlled and sugars are controlled, then he has no sarcopenia in addition to the type, as compared to type 2 diabetes.
Thank you. Is there any question?
Nice, excellent presentation, sir. My query is, as you said, we require protein 1.5 to 2 milligrams around, but
2 grams,
2 grams, sorry, for per day. So it becomes very difficult, sir, for vegetarian, elderly. So should we take protein powders? Should you recommend like taking protein powders for elderly, because it becomes very difficult, because digestion issues are also there if we take very high protein diets in elderly specifically.
So actually, we all take the requisite amount of protein. So what we do is that 30 grams of whey proteins along with creatine, branch chain, they are ready-made powders available. So they are.
Do you think we should usually recommend this to the people to avoid their muscle loss?
Yes, we should definitely. Then this yogurt, these machines to convert yogurt to Greek yogurt. Yeah. These Greek yogurt also has very high content of proteins, which is very good for. And thirdly, if the patient is taking eggs, one egg has around 9 grams of protein. So 3 to 4x, again we can supplement around 30 grams of proteins. And then we have sprouts and
all those things has very low amount of protein, I would say. Sprouts, if you take pulses also.
Tofu, but we have to...
Non-vegetarian diet people, if they give full efforts, they will take like 60 grams. It becomes very difficult to go to that
Absolutely. I fully agree, because vegetarian diet, we have great difficulty in supplementary proteins.
Very difficult.
Excuse me, sir. Sir, one more question. Sorry. Sir, we discuss cardio-kidney metabolic syndromes, but we often overlook sarcopenic obesity in that definition. Mostly metabolic syndromes, BMI fails to identify sarcopenic obesity. So shouldn't we include sarcopenic obesity in cardio-kidney metabolic syndromes?
I fully agree. I also am of the opinion that even the MASLD should be included in cardio-kidney metabolic syndrome, because that is a very, very good marker of sarcopenic obesity and all of these complications. So MASLD and the testing of sarcopenia, these all should be included. And we are too much focused on weight loss, fat loss, but what we should be focused on muscle gain. If we are focused to muscle gain, even if the patient is having higher BMI, he will do well, his health will remain well, and his longevity, muscle is directly related to longevity.
Lean and thin patients often are overlooked. They are not being identified, but they are landing in a sarcopenic obesity, often poor glycemic control, and often that worsens cardio-kidney metabolic outcomes. So should we screen?
No, definitely, because lean and thin people, some of them are having good muscle strength and good physical performance, but many of them are having increased visceral and ectopic fat, and therefore we should look with at least the basic scanning like ultrasound and fibroscan and all those things should be done. And because DEXA is very difficult basically. A surrogate marker of DEXA is the calf circumference. So if the calf circumference is less than 34 in males and less than 33 in females, then you should specifically look for. And the test, there is a simple questionnaire, this is SARC-F questionnaire, and the muscle strength, those you can have in the clinic. And look, there is a BIA machine also, which is also very cheap actually, which is little not that accurate, but definitely will give a good idea.
Thank you, sir.
Sir, Dr. Ved Prakash Lilhare sir, to please be on stage. I request all you to please come up on the stage.
Okay, we welcome Dr. Neeraj Jain, sir.
Okay, so a very good morning to all of you. Today I would be discussing few interesting case scenarios which are very useful, I think, for general practitioners or for the physicians because they often deal with many complications of diabetes and CKD, and I think a useful insight to these scenarios will be rewarding for them. So the first case scenario, that is disappearing insulin need. A 62-year-old man with type 2 diabetes developed CKD5 and now he experiences frequent hypoglycemia despite reduced insulin dose. This we know that this is a very common scenario in our day-to-day practice. So what is the reason behind it? The most common reason is decreased gluconeogenesis, Kidney contributes to 25% of gluconeogenesis. Then impaired insulin clearance by the kidney. Again, 25% of the insulin probably is cleared by the kidneys. Then impaired counter-regulatory hormone response because of underlying autonomic neuropathy secondary to diabetes and other comorbidities. Then nutritional deprivation. Often the CKD, as the CKD advances, patients do develop anorexia. Then insulin resistance and impaired beta cell function. So top 4 reasons are the reasons which contributes to hypoglycemia, but in some patients we have seen with the advancing CKD, patient actually develops hyperglycemia. So insulin resistance because of uremic milieu and impaired beta cell secretion is the reason for development of hyperglycemia. So hypoglycemia though is common, but hyperglycemia can be seen in some of the patients. How to tackle this recurrent hypoglycemia? That is, we can use short-acting OHs like ripaglinide and glipizide, DPP-4 inhibitors which are predominantly not cleared by kidneys like linagliptin, and imigliptin is a very useful addition in such scenarios. You can use linagliptin and imigliptin combination avoiding secretogogues, and if there is postprandial hyperglycemia, you can still add ripaglinide and glipizide. Short-acting insulins and small frequent diets. We should ask our patient to take small frequent diets so that hypoglycemia can be avoided and patient can have a better life. Then masked hypoglycemia in dialysis patients, again the same reasons. Because of autonomic neuropathy, we have seen that patients undergoing dialysis, especially elderly diabetic males, not male or female, but this is a 70-year-old diabetic male on dialysis. He actually presents with seizures post-dialysis and he has not shown any of the features of hypoglycemia before the onset of seizures. Because of blunted autonomic neural response, this can happen. In such case scenarios, you need to have a better glucose monitoring during the dialysis. Ask the patient to eat more of sugar-rich food during dialysis, or at least at the end of the dialysis, I would say. I always frequently advise my patient to eat chene ka rasgulla, or for that matter, which are rich in protein as well as sugars. Now coming on to the post-transplant diabetes scenario with graft dysfunction, a diabetic patient undergoes transplant and now he has a worsening glycemia and allograft function. You should always think of tacrolimus toxicity, which is now leading to either new onset diabetes after transplant or exacerbation of diabetes or uncontrolled diabetes after the transplant because of beta cell dysfunction secondary to tacrolimus. Now second case scenario, another case scenario is metformin dilemma, when to start and stop. I know we all know much about it, but just to cover up, a 54-year-old diabetic male now continues to have GFR decline, and now he is at the risk of lactic acidosis. So what are the guidelines? We all know that metformin associated lactic acidosis is rare but very serious complication. The event is almost less, the incidence is almost less than 10 events per 1 lakh patient years of metformin exposure, though the incidence is very, very low, but still the mortality is in the range of 30 to 50%. So what are the eGFR cutoff for metformin use? It should never be initiated in a GFR of less than 45. It safely can be used at a GFR of more than 45, but if initiated, it can be used till GFR of 30, and it is contraindicated by almost all the guidelines at a GFR of less than 30. Though we have seen many patients continuing metformin at a creatinine of 4 or 5 with a GFR of 15 or 10, and still they do not develop any lactic acidosis. But though incidence is very rare, I want to emphasize that mortality is very high, so you should be very cautious. With the advent of imigliptin, I safely feel most of the patient can be switched from metformin to imigliptin with almost similar efficacy. Now coming on to the diabetic nephropathy or something else, there is always a dilemma in the physician's mind that whether we are dealing with in a given diabetic case, because it is a very common scenario in our country that a patient who has been diagnosed with diabetes now, on the first visit only, he has some features of diabetic nephropathy, some proteinuria or rise in creatinine, or baseline creatinine is just 2. You'd never know whether it is diabetes with diabetic nephropathy or it is diabetes with non-diabetic kidney disease. So how to differentiate that? This is a real case scenario I have presented. Dr. Dhingra sir is here? No. So she is a 45-year-old female with 3 years of diabetes, treated by Dr. Ashish Dhingra sir, and now she is developing worsening renal function in last 6 months. In last 6 months, she has a creeping rise of creatinine, 1.2, then 1.3, then 1.7, 1.9, 1.98, and then I remember it was 2.8 somewhere around when she visited me. So it was not very peculiar for diabetes to have such a gradual, creeping rise of creatinine now over a short duration of time. So her BP sugar were well controlled. There was no significant retinopathy. So it is very important for us to look for retinopathy whenever we are thinking of diabetic nephropathy. She was not taking any NSAIDs or alternate medicines at present. And when I got her urine routine done, they were showing active sediments. So I straight away took her for renal biopsy, and renal biopsy turned out to be class 3 lupus nephritis. A 45-year-old female, first time getting diagnosed with lupus nephritis with no significant extra-renal manifestations. No arthritis, no skin rashes, nothing. So what are the red flags for diabetic nephropathy? That is, when should you consider the possibility of non-diabetic kidney disease? First, there is sudden increase in creatinine, or there is a creeping rise of creatinine over a short period of time. Then there is sudden increase in proteinuria. Say you are monitoring a patient with diabetic nephropathy and her UACR, that is urinary albumin creatinine ratio, was in the range of 300 to 500. And suddenly from that range, it has shifted to in the range of nephrotic range, say 3 grams, 4 grams. So it is not possible for diabetic nephropathy to have sudden shifts of proteinuria in such huge amounts. So you should always consider non-diabetic kidney disease in such patients. You should consider proteinuric disease like FSGS, MGN, or other diseases for that matter. You should always examine the patients for diabetic retinopathy, and urine routine plays a very important role. I'm telling you, very, very, very important role. So a properly done urine routine examination is very crucial in diagnosing non-diabetic kidney disease in a given patient. You should always try to exclude microscopic or macroscopic hematuria in your given patient. And nephropathy within 5 years of onset of type 1 diabetes, this we all know that nephropathy at least take more than 5 years in type 1 diabetes, because in type 1 diabetes we can actually demarcate when the diabetes has started, which is not possible in type 2 diabetes. So third case scenario, that is recurrent UTI and glycosuria. Physicians are often confused, and whenever I write dapagliflozin or empagliflozin for that matter, and patient is referred back to me that patient has pus cell in your urine, pus cell in the urine, and why you have prescribed dapagliflozin. So I would highlight this feature that asymptomatic bacteriuria doesn't preclude the use of DAPA or empagliflozin for that matter. You should be more cautious in such patients. You should frequently monitor. It should be a shared decision between you and the patient. You should tell that now you can have some increased incidence of UTI, or you might have clinical UTI, and you should report immediately, but simply presence of pus cell in the urine does not preclude the use of dapagliflozin in given case scenarios. And you should always try to modify all other risk factors, like you can have a post-void residual urine in males to rule out benign prostatic hyperplasia, or you can always have PVRU, that is post-void residual urine in a female, to know the bladder function in such patients to rule out diabetic cystopathies. So you can reduce the post-void residual urine in your patient and reduce the incidence of UTI. Now coming on to the anemia and diabetic CKDs, we all know that this is a common scenario. Every diabetic patient with nephropathy develops some anemia during their lifetime with the advancing CKD stages. So a patient with CKD with anemia, and now every one of us know the erythropoietin is the backbone of CKD management, advanced this advanced anemia management with CKD. So everyone writes erythropoietin, but what happens when patient doesn't respond to your usual doses of erythropoietin? So you should first rule out vitamin B12, folate and iron deficiency. And now I want to highlight that folate and B12s are okay, but they have the range in a given patient with normal population. But iron deficiency is, the interpretation of iron profile is very different in CKD patient. So in normal patients, we say transferrin saturation of 10 to 50 is okay. But in CKD patient, you should always try to maintain transferrin saturation in the range of 30 to 50%, not less than 30%. Because there is CKD is a pro-inflammatory state, and ferritin is obviously raised in such patients. So you cannot monitor iron stores by ferritin, and transferrin saturation is a more reliable marker, and you should try to maintain transferrin saturation in such patients above the range of 30%. And you should know the role of inflammation in hepcidin because of advent of desidustat. I would be coming, this is hepcidin role. Sorry, I will be cutting short of this slide. Hepcidin causes locked in state iron. Iron which is available in the body is not available for the bone marrows for the production of RBCs. Then parenteral versus iron, we all know that advantages and disadvantages of parenteral versus iron. Now with the advent of newer molecules like ferric carboxymaltose, this disadvantage is largely given off. Oral iron therapy, we have significant side effects, and with the studies now we have available, we know that IV iron, this meta-analysis suggests that in a advanced CKD stage, IV iron therapy is more good than oral iron therapy. Oral iron is frequently not absorbed in advanced CKD patients. So we should not try to attempt say in a patient with advanced anemia, you should not try to attempt oral iron therapy, you should straight switch to IV iron therapy. Desidustat, again, it has a very important role. Now your erythropoietin is not responding, you know hepcidin has gone up and inflammation is there. IV iron, with the advent of IV iron, if patient is not improving, then you should try to add desidustat, which has shown that erythropoietin hyporesponsiveness can be covered with desidustat. It is a proryl hydroxylase enzyme inhibitor which causes enhanced erythropoietin life, endogenously produced erythropoietin. It has got hepcidin lowering capacity also, that is it reduces the inflammation also in different studies. This one head-to-head trial is given. I will not discuss this animal model, but with oxemia which is available in the market, or Rssearch which is available in the market, desidustat can be given to the patient with advanced anemia if who is not responding to IV iron or erythropoietin. And in patients who are not preferring erythropoietin, you can still start afresh these patients with anemia on desidustat. But it is more in early CKD stages, stage 3 and 4, desidustat will still respond, but I frequently combine desidustat with erythropoietin in advanced stages of CKD. I am skipping CKD MBD. It is another we have discussed, because we know CKD has an increased phosphate level and there is a skeletal resistance to PTH which causes vitamin D lowering and lowered calcium, which ultimately causes secondary hyperparathyroidism. There is progressive rise of vitamin D deficiency in CKD. I'll skip all these slides, I'm sorry. So treatment of CKD MBD, less phosphate diet, vitamin D, calcium mimetics, that is cinacalcet to lower hyperparathyroid level, calcium, and if you have diagnosed the patient as osteoporotic, then denosumab Rankel inhibitor is also a very good choice. When to refer to a nephrologist in a given case scenario, GFR should be, if GFR is less than 30 or proteinuria is more than 300, rapidly worsening renal function, there are active sediments in the urine, RBCs in the urine, patient's blood pressure is not controlled, ADPKD or any other hereditary disorder, if there is persistent anemia, hyperkalemia or recurrent extensive nephrolithiasis. So this is the KDIGO guidelines for referral to a nephrologist. Thank you. I'll stop this presentation over here only.
Thank you, sir. Very nice and case-based talk. Now the session is open for the discussion.
Sir.
Patient, diabetic CKD patient. So, you say, is it a GLT2 induced or there is something else? What about the urine nitrite values and leukosteres gives some clue for that infection? May not be DAPA induced, but diabetic induced UTI.
Sir, I am not able to gather your question. You are asking about the use of urine nitrites.
No, urine में जो finding आती है नाइट्राइट के ल्यूकोज, आप बोलते हैं कि भाई अगर डापा इंड्यूस है इस मीन्स बैक्टीरिया है या एसिम्प्टोमेटिक और सिम्प्टोमेटिक.
Sir, clear है इसमें, there are only 3 indications to treat asymptomatic bacteriuria. First is patient is pregnant, you are planning any instrumentation or patient is transplant recipient. Otherwise, there is no other indication to treat asymptomatic bacteriuria. It is frequently, we all have seen diabetic patients. Most of the patients, I would say, more than 30 to 50% of the patient will have some bacteriuria. You should not treat it. आप कितना भी chase करें, कितना भी treat करें, वो कुछ समय pus cell suppress होंगे और वापस rise हो जाएंगे. So, अगर symptoms नहीं है, patient को dysuria नहीं है, patient को burning micturition नहीं है, patient को fever नहीं है, patient को hypogastrium pain नहीं है, तो आपको treat करना ही नहीं है. आपको उस साइड देखना ही नहीं है. पस सेल के नंबर से मत घबराइए, 40 है, 50 है, 55 है, 60 है, 100 है, उससे कोई मतलब नहीं है. इट डजेंट होल्ड एनी सिग्निफिकेंस. आपको डापा चल रहा है, डापा चलने दीजिए, उसको रोकना भी नहीं है जब तक क्लिनिकल यूटीआई ना हो रहा हो. अगर क्लिनिकल यूटीआई भी अनकॉम्प्लिकेटेड है, अनकॉम्प्लिकेटेड मतलब पाइलो नहीं डेवलप हुआ है, पेशेंट को ऑब्स्ट्रक्टिव यूरोपैथी नहीं है, पेशेंट को स्टोन का नाइडस नहीं है, तो आप बिल्कुल डापा को यूटीआई ट्रीट करने के बाद रिकंसिडर कर सकते हैं. लेकिन पेशेंट को अगर कोई स्ट्रक्चरल एबनॉर्मलिटी से सिस्टोपैथी है या बीपीएच है, सिग्निफिकेंट पोस्ट वाइड रेसिडुअल यूरिन और पेशेंट ऑपरेट भी नहीं करा रहा है, तो ऐसे पेशेंट्स को नहीं देना है, क्योंकि उनमें तो होना ही होना है फिर तो ये शेयर्ड रिस्पॉन्सिबिलिटी है आपकी और पेशेंट की. आपको बताना है कि भाई आपको चांसेस बहुत हाई हैं, आपको यूटीआई हो चुका है, अब मैं नहीं देना चाहता, तो या तो हम आपका ये जो एबनॉर्मलिटीज़ हैं ये करेक्ट करके फिर डापा दें. आपको कार्डियोरीनल बेनिफिट समझाना है पेशेंट को. अगर वो मान जाता है तो ठीक है, नहीं मानता है तो बेटर टू ओमिट इट rather than putting the patient at risk.
अच्छा, सेकंड क्वेश्चन ये है कि आपने बोला कि सीकेडी जैसे अपन डायग्नोज करते हैं, रेटिनोपैथी और नेफ्रोपैथी आप देखते हो. रेटिनोपैथी तो बहुत पहले आ जाती बिफोर द डेवलपमेंट डायबिटीज इन इंडियन सिनेरियो. तो अपन मान लीजिए तो उसमें उसका सिग्निफिकेंट रेटिनोपैथी एडवांस है, नेफ्रोपैथी.
तो सर इसका ये है कि दैट इज ट्रू, रेटिनोपैथी, अर्ली रेटिनोपैथी कम्स बिफोर द नेफ्रोपैथी इन सम ऑफ द स्टडीज हैव शोन, बट द कोरिलेशन इज 60 to 70%. इन सम केसेस देयर इज नो रेटिनोपैथी बट स्टिल नेफ्रोपैथी. तो ये जो कोरिलेशन है 100% नहीं है. किसी को रेटिनोपैथी बहुत अच्छी रहेगी और नेफ्रोपैथी नहीं रहेगी, किसी को नेफ्रोपैथी बहुत ज़्यादा रहेगी और रेटिनोपैथी नहीं रहेगी. तो 60 to 70% तो अच्छा कोरिलेट करता है, 30% एक ब्लैंक एरिया है. तो हम ये मानते हैं कि किसी को एडवांस नेफ्रोपैथी है, सपोज क्रिएटिनिन 3 हो गया है या प्रोटीन यूरिया नेफ्रोटिक रेंज में, तो हम कुछ रेटिनोपैथी तो एक्सपेक्ट करते हैं. अगर मिल जाती है एडवांस रेटिनोपैथी तो हम मान लेते हैं कि यार ये ग्लाइसीमिया ही है जिसने यहाँ भी मचाया है, यहाँ भी मचाया है. लेकिन अगर मान लो कि किसी को नेफ्रोपैथी अकेला रेटिनोपैथी बिल्कुल नहीं है, तो आपको फिर बायोप्सी करनी है उस पेशेंट की. या किसी को नेफ्रोपैथी बहुत एडवांस्ड है और रेटिनोपैथी नहीं है या वाइस वर्सा है, तो देन यू हैव टू थिंक ऑफ ऑल्टरनेटिव कॉजेज ऑल्सो. तो ऐसे पेशेंट्स में रेटिनोपैथी इसलिए देखना है कि नेफ्रोपैथी डायबिटिक है कि नहीं है, एक निडल डालनी है कि नहीं डालनी है. अगर आपको लगता है कि नहीं ये प्रोबेबली डायबिटीज से रिलेटेड नहीं है. सपोज देयर इज नो रेटिनोपैथी बट किडनी में तो बहुत बुरा हाल है, 5 क्रिएटिनिन हो गया, प्रोटीन यूरिया आ रहा है, तो आप कैसे मान सकते हैं कि ये सारा डायबिटीज का किया धरा है? तो तब तो आपको बायोप्सी करनी है ऐसे पेशेंट्स में टू रूल आउट नॉन डायबिटिक किडनी डिसीज. स्टिल टू माय सरप्राइज आपको मैं बता रहा हूँ 30% में डायबिटिक किडनी डिसीज निकलती है. नोडुलर ग्लोमेरुलोस्क्लेरोसिस मिलता है. अभी एक लेटेस्ट बायोप्सी मैंने किया था, उसमें माइल्ड एनपीडीआर था बट प्रोटीन यूरिया वाज इन द रेंज ऑफ 10 ग्राम्स एंड क्रिएटिनिन वाज 2.4. डायबिटीज अनकंट्रोल्ड था बट माइल्ड एनपीडीआर था और किडनी की तो बैंड बजी पड़ी थी. उसमें बायोप्सी किया तो बायोप्सी में कुछ नहीं निकला, उसको आर्टीरियल नेफ्रोस्क्लेरोसिस निकला, मतलब आर्टीरियोस्क्लेरोसिस निकला और नोडुलर ग्लोमेरुलोस्क्लेरोसिस निकला. मतलब सारा मचाया हुआ डायबिटीज का था और कुछ भी नहीं था. नो नॉन डायबिटिक किडनी डिसीज एज सच, हाइपरटेंशन और शुगर के ही चेंजेस थे.
अच्छा, एक जो आपने डेंगरा साहब का केस बताया है ऑटोइम्यून डिजीज का, तो ऑटोइम्यून डिजीज का कंट्रीब्यूशन इन टाइप 1 एंड टाइप 2 में क्या डिफरेंस है और व्हाट इज द परसेंटेज ऑफ ऑटोल्यूपस इन टाइप 1 एंड टाइप 2 डायबिटीज?
सर लूपस का डायबिटीज से बहुत अच्छा कोरिलेशन तो मुझे नहीं पता है. एक आशीष सर का पेशेंट था चांदनी करके, आई एम सॉरी टू कमिट द नेम, बट एक 45 ईयर फीमेल थी एंड शी वाज विजिटिंग आशीष सर रेगुलरली, वेरी रेगुलरली. और मेरा आशीष सर का उस पर डिस्कशन भी हुआ था एंड एवरी पैरामीटर्स फॉर वेल कंट्रोल्ड. शुगर बहुत अच्छा चल रहा था. वैसे भी क्या होता है, क्रिएटिनिन राइज होता है ना तो एंडोक्राइनोलॉजिस्ट के लिए बहुत अच्छा हो जाता है. क्रिएटिनिन जैसी राइज होता है, शुगर तो सरदर्द रहता ही नहीं है. तो उसका क्रिएटिनिन धड़ाधड़ हर विजिट पर राइज हो रहा था और वो उस समय ट्रीट होना शुरू हुई थी तो वो मंथली विजिट पर आ रही थी. उसका 6 महीने में ही क्रिएटिनिन 1.2 से 2 के ऊपर चला गया था, जो कि डायबिटिक नेफ्रोपैथी के लिए पॉसिबल नहीं है. बट समहाउ वो पेशेंट को पता नहीं क्रिएटिनिन से एंजाइटी हुई तो उसने मुझे विजिट कर लिया. जस्ट मेरा क्लिनिक बाजू में ही है सर के, तो मैंने उसका यूरिन रूटीन और यूपीसीआर कराया तो उसमें प्रोटीन यूरिया भी था और यूरिन रूटीन में एक्टिव सेडिमेंट्स थे. बायोप्सी किया तो लूपस निकला. तो ये मतलब ऐसा नहीं था कि वेरी वेल थॉट.
अच्छा सुनिए, लास्ट है कि एसएलई अगर नोन केस है अपने पास और एडवांस स्टेज में नेचुरली वो उसमें लैंड करेगा
सर
काय में आपके नेफ्रो किडनी इन्वॉल्व होगी तो ऑटोइम्यून डिजीज मतलब कितने?
सर मेरे को लूपस का और टाइप 1 डायबिटीज का कोरिलेशन का आइडिया नहीं है सर.
नहीं बट नोन हमारे पास पेशेंट है जिसको एसएलई ऑलरेडी हम ट्रीट कर रहे हैं एज ए जनरल प्रैक्टिशनर. वी नो कि एसएलई पूरा उसके बोनी पेन वेन एवरीथिंग वाज लॉन्ग स्टैंडिंग एसएलई, सिस्टमिक लूपस एरिथ्रोमेटोसिस, जॉइंट डिजीज. ठीक, उसके बाद अल्टीमेटली
सर तो ऐसे केसेस में हम क्या करते हैं, यूरिन रूटीन और क्रिएटिनिन हर 3 मंथ्स से 6 मंथ्स में एवेलुएट करते रहते हैं. इफ देयर इज एनी हेमेचूरिया और प्रोटीन यूरिया और राइज इन क्रिएटिनिन हम बायोप्सी करते हैं. फिर वो स्टेजेस ऑफ एसएलई हैं तो उसके हिसाब से ट्रीट करते हैं. वो डिफाइंड गाइडलाइंस हैं उसके लिए सर. तो हम अगर किसी को नेफ्रोपैथी शुरू से नहीं है तो हम कुछ नहीं करते हैं उसमें.
अच्छा सुनिए, एसएलई में जब भी एक्सेसरवेशन होता है, maybe it lupus due to SLE, then steroid is the sheet anchor of the treatment.
Sir,
so what is your opinion being a kidney involvement, steroid का आप कैसे यूज?
सर किडनी के लिए तो स्टीरॉइड्स वरदान है. अधिकतर बीमारियों में तो हम स्टीरॉइड्स ही दे रहे हैं. तो किडनी में स्टीरॉइड से तो कोई प्रॉब्लम नहीं है. मतलब हमको तो लगता है कि जितना हाई डोज में पेशेंट स्टीरॉइड्स पर है किडनी का इन्वॉल्वमेंट रिलेटिवली कम ही होगा. तो स्टीरॉइड्स एज सच डोंट हैव एनी अनड्यू एडवर्स इफेक्ट इन द किडनीज एटलीस्ट.
थैंक यू सर.
We are actually running short
Thank
of
you,
time,
sir,
so it's a
for
request
such a
to all
nice
the speakers to
presentation.
please stick to the time. In fact, कुछ कम time ले लें तो और we would be very thankful. No?
Right. Respected Dr. Ramesh Bhargava sir to please be on stage. Our chairpersons Dr. Gangesh Tandia sir, Dr. Sanjay Nema sir, Dr. Nitin Chaudhary sir to please come up on the stage. I request all of you to please come up.
me for inviting me for this presentation. These are the real cases. Shall I start?
Okay.
This is first case, Mr. Amir, male, 26-year male. On examination, patient came to the OPD, pulse 110, blood pressure 120/80, X-ray chest clear, abdominal system did not reveal any abnormality, lungs clear, and CNS NAD. This is the ECG of the patient. Little sinus tachycardia is there. This is blood picture. Nothing significant is there. This is X-ray chest of the patient showing bilateral mediastinal hedge. This is X-ray chest of the patient showing this mediastinal hedge. Any clue this time? What next investigation we have to do? No, I did this echo. Showing left atrial myxoma. Patient was operated at Bhopal Memorial Hospital. He is comfortable now. Case 2. This is just to compare this. This is left atrial mass. This is left atrial thrombus. So you can differentiate between left LA myxoma and left atrial thrombus. Case 2, 12 years male, referred to me for patient of hypertension. Age is 12 years. WBC, RFT, blood sugar, USG, nothing significant. ECG shows mild left ventricular hypertrophy. This is blood investigation, except WBC count low, rest of the picture is normal. Urea creatinine normal, protein normal, albumin normal, globin in uric acid also normal. This is blood sugar, urea creatinine normal. This is X-ray chest of the patient. Little left ventricular hypertrophy is there. This is ultrasound of the patient. Kidney is almost normal. So I did echo of this patient. Little left ventricular hypertrophy is there, but otherwise echo is normal. This time again we have examined the patient and I find the lower limb blood pulse is absent. So I did suprasternal view. Now you see the gradient. Any clue this time? Anybody? Yes. So I did this thoracic abdominal aorta angiography supporting the coarctation of aorta. This is coarctation of aorta. Patient was subjected to show this, and this valvuloplasty is done. He is comfortable now. 65 years old male came to OPD with breathlessness, no exhaustion. Echo was done. Any clue? Anybody? Anybody?
Can you show RV effects? Yeah, please. Hello. Sir, I am here. Can you show RV effects of that? I will picture of RV effects also because are indirected. To see macular side.
Only one picture is there. So this is Epstein anomaly. Clear? Any doubt?
Sir, can you go back on that case?
Epstein anomaly is there.
Yeah,
Heart is
little
flat,
back on the
part
picture.
of tricuspid valve is abnormal.
On that picture, can you go Epstein? I mean, arterialization of ventricle is there and ventricle size is quite good. Almost RA enlarged more than 75 to 80% in the Epstein anomaly. And what about the other feature of Epstein? Have you noted that?
Pardon?
You go that echo picture. Sir, in Epstein, what I am telling, RV size quite good, not totally this arterialized.
But RB is small actually.
This is small, but complete or nearly complete arterialization of ventricle, that's very peculiar. And otherwise, the low pressure TR, have you demonstrated low pressure TR in this patient? There is a quite good tricuspid regurgitation, but that is a low pressure, that's a very important. In the JT, if you see there high regurgitation is there, but pressure is low. So low pressure TR is very important in the Epstein anomaly. Thank you.
This is patient of mild hypertension having echo. Any clue? Yes. This is patient. Any clue? Spot case. Pardon? What is this structure?
So
This
this
is
is
RV,
probably
this is
RA,
this
and
is LA, this is LV.
so it
This
is
is RA. Eustachian wall. Eustachian wall is direct OTD blood from towards the foramen wall and away from the tricuspid valve during the fetal development. Any comments?
It is reversal of hepatic.
Any comment of this? This is calcified aortic stenosis, high-pitched musical sounds. I'm sorry, sound is not there, but you can see the zebra strip sign. This is in calcified aortic stenosis. This is zebra strip sign.
What was maximum gradient in
150 only.
aortic stenosis in gradient is 10 mmHg.
Calcified stenosis. Calcified. You can come with 1.5 also.
That is only possible only with low flow, low gradient, severe aortic stenosis. But LV pumping is looking good. LV pumping, what you have done, if low flow, low gradient, severe aortic stenosis is there, ejection fraction is lower, that's why gradient is low. But your LV is looking contraction is good. Ejection fraction low. So, I mean, when we want to demonstrate aortic stenosis, we should show maximum gradient. Your tip is touching baseline and might some more gradient will be there. So this is my suggestion. Thank you, sir.
Any comments on this? This is RV, RA, TR is there, this is LV, LA, MR is there. Any clue? This is cushion defect. Thank you. This is last for my presentation. Any question and comments?
Thank you very much for nice presentation. And as we are running short of time, there is no question answer session.
Thank you. Thank you.
And the speaker for the session will be Dr. B.K. Singh. Requesting the speaker and chairpersons to be on the dais. Thank you.
Can I start?
Hello. Yeah. Dr. V.K. Singh, sir. Good morning, everyone. Please continue, start the session.
Thank you, Chairperson. At the outset, I thank the organizing team of CCDSI and the Indo Dialogue 4 team, especially Dr. Abhishek Srivastava, for giving me opportunity to speak on this prestigious platform. My topic is the role of gut microbiota in the pathogenesis and management of type 2 diabetes mellitus. You all know that diabetes is a multifactorial disease. It is a metabolic disease having involved many functions, and there are many pathophysiological mechanisms which is related with the diabetes mellitus. My topic is microbiota and diabetes. You all know that the microbiota is a collection of microorganisms inhabiting in the specific environment such as gut or skin. It includes diverse community of bacteria, viruses, and other small microorganisms. And the microbiome is the term used for the collective genetic makeup of organisms, including their genome, the environment they inhabit, and their interaction with the host. And the genetic material from the collection of microbes is metagenome. If we can look at the history of microbiota and disease, the link between gut microbiota and overall health is recognized long-term back. The early research focused on the identifying difference in gut microbiome composition between diabetic and non-diabetic patient. But microbiota and particularly type 2 diabetes has gained significance over the last 20 years. And the one landmark study by Larson et al. In 2010 demonstrated that the individual with type 2 diabetes have lower level of certain bacterial groups like Firmicutes and the Clostridia compared to the non-diabetic or controlled patient. This is a one landmark data that correlates with the microbiota and diabetes. What is microbiome? More than 2,000 different bacterial species are present in your gut. And 90% of the gut microbacteria belongs to the bacteroids and the Firmicutes. What is the role? Why? There is a synergistic relationship between the microbiome and the host, and they provide beneficial effects like resistance to the infection, promotion of epithelial cells differentiation, promotion of gut lymphoid tissue differentiation, and energy harvest from the gut, from the non-digestible fiber, which is the plant fiber. If this microbiome is composition and function of this microbiota disturbed, this is called dysbiogenesis and had been linked with the emergence of type 2 diabetes mellitus and the related complication. The metabolic action of gut microbiota, if you can see the vast majority represents the Firmicutes, that is the gram-positive bacteria, it is 60 to 80%, and the bacteria, the gram-negative, it is 20 to 30%. A high number of bacterial species in the microbacteria has shown to be the protective against many metabolic disease. And the gut microbiota is also involved in the production of secondary bile acids, and the gut microbiota also make intestinal plant fermentation in the colon, leading to the short chain fatty acid. And gut microbiota preserve the intestinal wall integrity by upregulating the tight junction and by the reducing the lipopolysaccharide production. So these are the function of the gut microbiota. You can see that it is the control of inflammation and the immune response, integrity of the wall, intestinal wall integrity, the drug metabolism, the bile acid metabolism, and the vitamin and protein production. If you can see the intestinal barrier, which is very important for the pathogenesis of the type 2 diabetes mellitus, in eubiosis, the bacteria and vulgarities and bacteroids preserve the intestinal wall integrity by upregulating the tight junction by reducing the lipopolysaccharide production. And the gram-negative bacteria are the major source of LPS production, particularly the E. coli. And dysbiosis contribute to increased intestinal permeability, leading to the translocation of bacterial LPS into the bloodstream, that is the metabolic endotoxemia. And this metabolic endotoxemia creates inflammation, immune response, and leading to the different metabolic diseases. The inflammation and immune response, as I said, the gut microbiome play a crucial role in shaping the immunity and the development of inflammatory process. They create innate immune response and the microbial response to the inflammation and immunity. And this dysbiosis can disrupt the delicate balance between the immune inflammation and the immune tolerance. If the bacteria living in your intestine, that creates an immune tolerance. And if there is a difference, that can create the immune reactions. The gut microbiome and immunity have deeply intervened and is a critical role in maintaining the health and inflammation. The bile acid metabolism, I said, the microbiome has significant impact on the bile acid metabolism. And the gut microbiome, particularly colon, can modify the chemical structure and signaling property of the bile acids. And this bile acid can influence the composition of the microbiota, and disruption of bile acid metabolism and dysbiosis has been linked to the development of obesity, type 2 diabetes mellitus, and IBS. There is vitamin and protein production. This microbiota is also responsible for the different vitamins production, like the vitamin B12, biotin, folates, nicotinic acid, pantothenolic acid, pyridoxine, riboflavin, and thymine, and so on, and the vitamin K. The microbiota ferments dietary protein, producing various metabolites, including the amino acid and the short chain fatty acid, and the GMX, possible intestinal plant fiber fermentation, leading to the production of short chain fatty acids. And so these short chain fatty acids, such as butyrate, propanate, and acetates, and this butyrate producing species are responsible for the onset and development of diabetes mellitus. The drug metabolism, metformin, has been shown to influence the composition and function of the gut microbiome. If we can use the intravenous metformin and the oral metformin is more effective in controlling the diabetes mellitus than the intravenous. This shows that the the gut microbiome had effect on the metformin, and that is the active metabolite, which is very responsible. The gut microbiota and obesity and diabetes, we have already said. And if you can see the therapeutic response, and these are the all lifestyle modification, the anti-diabetic drugs, these are all have impact on the gut microbiota. The lifestyle modification, I have said, the lifestyle choices significantly impact on the gut microbiome, like diet, exercise, stress, and sleep. These are the 4 components of lifestyle modification, and which is very important. And if you can go a healthy diet, and if you can regular exercise, if you have less stress, or if you have adequate sleep, that can possibly is responsive for the maintaining the gut microbiota in your intestine. And if this lifestyle is deranged, that may lead to the development of the other metabolic diseases like type 2 diabetes mellitus and obesity. The prebiotic and probiotics. The probiotics like yogurt, dahi are life beneficial microbes that add to the microbial population, and the prebiotics like garlic, onion, banana, and whole grains are non-digestible fiber that stimulates the growth of beneficial gut microbiota. So this prebiotic and probiotic improve gut microbiome. The type 2 diabetes mellitus is associated with dysbiosis, and the probiotic and prebiotics helps to restore the balance of gut microbiome. It also reduces inflammation. If the inflammation is reduced, that decrease insulin resistance, and if it improves glucose control, enhance insulin sensitivity, and it also been effective in modulating metabolic process by influencing production of the short chain fatty acid. There is one term is the fecal microbiota transplantation, and the fetal microbiota transplantation is primarily used to treat the recurrent or refractory Clostridial difficile infection, and it shows promise as a potential treatment of diabetes, particularly type 2 diabetes mellitus. The FMT is one of the means by which we can promote the gut microbiota, or you can restore the gut microbiota. And this FMT means the transfer of fecal microbiota from the healthy donor to the recipient. It acts by restoring gut microbiome balance, improve insulin sensitivity and reduce insulin resistance, stabilizing beta cell function, particularly the type 1 diabetes mellitus, improve glycemic control. The gut microbiota fecal material is processed and been transplanted into gut by various mechanisms. So to conclude, the role of intestinal ecology in the metabolic syndrome has been recently postulated for the connection between the gut microbiota and inflammation, hyperinsulinemia, metabolic associated fatty liver disease, and diabetes. This gut-liver axis modulation in diabetes is an important discovery in recent times, and there are several trials ongoing in the therapeutic efficacy of probiotic administration in diabetic and its complication. The gut microbiota is a novel prognostic biomarker in diabetes and need further studies to confirm therapeutic role of gut microbiota modulation and prebiotic and probiotic in diabetes and MAFLD. Thank you very much for your patient hearing. Just 1 second.
So we are running with the time, short of time. So I request to chairperson and speakers come on the facilitation desk. Now I request to our next speaker, Dr. Umesh Matan sir, kindly come and give them. And the chairperson for the next session is the Dr. Santosh Menon, Dr. Santosh Nema and me. Okay. A very great and large work on the diabetic foot. So I request to start, sir.
Thank you, Chairpersons, and thank you, Dr. Abhishek and team for having me here today. And we had a talk on diabetic neuropathy yesterday. So we will go one step ahead and we will discuss rare causes of neuropathy beyond diabetes. But before we do that, we must understand that 95% of the neuropathy which we are talking about is DPN. So diabetic neuropathy affects up to 50% of patients with diabetes and refers to a heterogeneous group of disorders which affect the nervous system, leading to a range of clinical presentations. And the most prevalent form is diabetic peripheral neuropathy, which is a symmetrical, distal, length-dependent, sensory-motor polyneuropathy. So by default, when we talk about diabetic neuropathy or any neuropathy, non-diabetic neuropathy, we are talking about this entirety, which is 95% of the time DPN or DSPN. All the rarer causes which we'll be discussing in the next slides, non-diabetic and rarer forms of diabetic neuropathy and non-diabetic causes of neuropathy are just about 5%. So by default, the most prevalent form of diabetic neuropathy is DPN, which is symmetrical, length-dependent, sensory-motor polyneuropathy. So we will discuss a few slides on diabetic neuropathy before going into the rare causes, the non-diabetic causes. So we all know the prevalence of peripheral neuropathy and associated pain in patients with diabetes is about 88% patients have painful symptoms, Overall prevalence of DPN is 28.85, about 30% in most of the studies in India, and it depends on the duration of diabetes, poor glycemic control, and presence of diabetic nephropathy, as we have heard from Dr. Neeraj Jain earlier. So what happens because of diabetic neuropathy? We all know peripheral neuropathy, autonomic neuropathy, and motor neuropathy, along with vascular disease, along with necrosis, trauma. Ultimately, they all lead to foot ulceration. So whether there is DPN, non-DPN, other rarer causes, ultimately the neuropathy will lead to ulcers. But unfortunately, most 77% with diabetic have never heard words like nerve damage, DFU, footwear advice, and foot care in their lifetime. So ulcers are very common. 35% are neuropathic, 50% are neuroischemic, and 15% are ischemic. And out of this 35%, these neuropathic ulcers, there may be rarer causes and other causes apart from diabetes. So, but we should exclude diabetes first. Diabetic neuropathy is actually a diagnosis of exclusion. So in any case, we have to go for a differential diagnosis, rare causes of neuropathy, before we arrive to a diagnosis of diabetic neuropathy. Up to 50% of diabetic peripheral neuropathies may be asymptomatic. DSPN is the most common form, 95% by default. When we talk about neuropathy, it is DSPN. Rarer causes are just about 5%. If not recognized and if preventive footwear is not implemented, patients are at risk for injuries to their loss of protective sensation is there, and the feet are not sensible. So this is the basic anatomy of a neuron and what goes wrong to the neuron and nerve structure in neuropathy we'll see. So this is a nerve structure. There is a stacking like telephone wires of axon, epineurium, spinal nerves, and vasa nervosa. And this is the vasa nervosa, which gets affected in neuropathy because it is a microangiopathy. So vasculature gets involved most of the time in a neuropathy. And what is the pathological process of developing a neuropathy? The most important is Wallerian degeneration, which is the response to axonal interruption, axonal degeneration or axonopathy, primary neuronal degeneration or neuronopathy, and segmental demyelination. These all processes are due to metabolic, microcirculatory, compressive, and autoimmune etiologies leading to the spectrum of neuropathy. Axonal degeneration is the most common pathological reaction of the peripheral nerve. It is caused by systemic metabolic disorders like diabetes, but other than diabetes, the rarer causes are toxin exposures, inherited neuropathies, and other rarer causes which we will discuss. It is also called dying back or length-dependent neuropathy. The myelin sheath breaks down along with the axon in a process that starts at the most distal part of the nerve fiber and progresses towards the nerve cell body. So this is axonal degeneration. We all know there are motor, sensory, and autonomic nerves, and they are also classified into myelinated, thinly myelinated, and unmyelinated, large and small, alpha, beta, delta, and C fibers, and they are responsible for muscle control, touch, vibration, position, and perception, cold perception pain, and warm perception pain. Autonomic is responsible for heart rate, blood pressure, sweating, and gut functions. So what is the etiopathogenesis of a neuropathy? Glucotoxicity, lipotoxicity, and vasculopathy. You can see there is a microvascular damage in the peripheral neuropathy. The axonal damage, you can see the difference between the normal and the abnormal damaged, disrupted nerve. And clinically, it's very simple to diagnose and look for signs of peripheral neuropathy. As the patient walks in to your clinic, you can see dry, cracked skin, dystrophic nails, callus formation, and claw toes, bunions, and all the deformities which are precursors of ulcers. Clinical examination, very simple inspection will let you know presence of autonomic neuropathy, dry skin, hairless, distended veins, edema, cold, web spacing infections, insensate foods, repeated minor trauma causing ulcerations. And we just need a 10-gram monofilament, a tuning fork, and a hammer in our clinic to diagnose simple peripheral neuropathy. Classification we know is symmetrical neuropathy. 95% of the times it is symmetrical distal polyneuropathy plus or minus autonomic neuropathy. There may be rarer causes like hyperglycemic neuropathy, acute painful sensory variants, and we have focal and multifocal neuropathies, cranial, focal limb neuropathies, radiculopathies, lumbosacral radiculopathies. So these are all varieties of neuropathies. This is a typical presentation we all know, the stocking and glow presentation of the peripheral neuropathy. So this we are talking about today. the rarer causes apart from diabetes and associated with diabetes. We need to take a targeted history, assess for DPN symptoms, test for clinical signs of DPN, absence of vibration, perception, and sensations, and then arrive to a differential diagnosis. If all the first three figures are there, then assess for factors which are listed in 1, 2, 3, and then see whether it is a DPN or there is something else. So if it is not fitting into a classical bilateral symmetrical DPN sort of picture, then there may be some rarer cause, and treat underlying conditions and refer to a specialty care. Here we may have to take the help of a neurologist and do a nerve conduction velocity and other tests also if we are looking for something apart from diabetic neuropathy. So this is what we are talking about today, the rarer causes and the causes apart from diabetes. They can be metabolic diseases like thyroid and renal disease, systemic diseases like vasculitis, paraproteinemias, amyloidosis, HIV, hepatitis and B and Lyme's disease, inflammatory disease, CIDP, chronic inflammatory demyelinating polyradiculopathy, nutritional deficiencies, industrial agents, organophosphorus, drugs like alcohol, amiodarone, chemotherapy, arsenic, mercury poisonings, and there are some inherited genetic neuropathies. And here what we mistake for a diabetic neuropathy, and these are claudication, neuromas, osteoarthritis, radiculopathy, Charcot's is a neuroarthropathy, plantar fasciitis, fibromyalgia. These are all painful syndromes, but they are not actually diabetic neuropathy. These have to be differentiated from the diabetic peripheral neuropathy, tarsal tunnel syndromes. And here we need to involve a neurologist when we are missing something. And why? If there is a pronounced asymmetry of neurological deficit, predominant motor deficit, rapid development of progression, DPN is a slow progressive disease. So if there is a rapid development, there is something else. Despite optimal glycemic control, there is worsening of neuropathy. Symptoms arising in upper limb more than lower limb, proximal weakness, sensory ataxia, more autonomic symptoms. There is a family history of non-diabetic neuropathy and pain that is very difficult to manage, limiting the patient's lifestyle. There may be something else, some radicular causes. So coming to the treatment, painful neuropathy, whether diabetic or non-diabetic, treatment remains the same. Glycemic control, alcohol excess is to be avoided, B12 deficiency, folate has to be treated, uremia, simple analgesics may be sufficient, but we have tricyclic antidepressants, dualoxetine, and other anticonvulsants, pregabalin and gabapentin. These are the drugs which are used commonly. They are non-pharmacological treatment which lack evidence, but psychological treatment, acupuncture, there are dietary supplements, GLA, ALA, resveratrol, so many things, but they lack evidence. So this is all about the rarer causes, which I have covered maybe because short of time, very fast, I think.
Very comprehensive talk, sir. And as we are running short of time, so we will not take any questions.
Thank you. Thank you very much.
Thank you.
Good morning all. Now we have Dr. Priyanka Kukarele. She'll be speaking on subclinical Cushing syndrome. Priyanka's name is known to everyone, one of the very prominent physicians of the town.
Thank you, ma'am. Thank you. I'll move forward because of the shortness of time. Good morning, everyone. And when I was given this topic, it was very different topic, and I'll be speaking on rare disease, I would say, which is a silent endocrine disorder, that is subclinical Cushing syndrome. So moving on, my content will be on the basics of the subclinical Cushing syndrome. Coming to the introduction part, it is a mild form of Cushing's. It has an autonomous cortisol secretion without overt signs. So the sign and symptom which we get in Cushing syndrome will not be present in this subclinical Cushing's patients. They will be often discovered during imaging for unrelated conditions. And another name which is given is preclinical Cushing syndrome. Now coming to first of the discoveries of subclinical Cushing syndrome, we are not known to this name, but it was initially first discovered by Charbonnel and colleague in 1981. It refers to a condition where there is autonomous cortisol secretion occurs, but the patient doesn't exhibit the typical overt sign and symptoms of Cushing. This means that while the hormone levels may be elevated, the individual doesn't present with classical features like supraclavicular fat and all the typical features of the Cushing syndrome. Now coming to history, we all must be knowing where is the history of this. This is one of the wonder of the world. So history comes, and most of the research paper in subclinical Cushing are being published from Italy. So first systematically described in 2000 through a large Italian study of greater than 1,000 patients with adrenal incidentomas. Now coming to the definition per se which has been given for subclinical Cushing, it is commonly used to define a condition which is characterized by subtle cortisol hypersecretion from adrenal tumor without sign and symptoms of overt Cushing. So this is the main thing. So whom we want to label as subclinical Cushing, the three criteria has to be fulfilled. There should be adrenal adenomas. It should not present as a clear Cushing's phenotype, and it will have autonomous cortisol secretion which will cause secondarily ACTH suppression. Coming to adrenal incidentaloma and Cushing syndrome, an adrenal incidentaloma is an adrenal mass which is found incidentally during the imaging. The patient complains of recurrent abdominal pain or any trauma, and we are not having any sign and symptoms of Cushing, and incidentally we go for the CT scan of the abdomen and then it was detected. So that is adrenal incidentaloma. This masses are detected in up to 7% of adults, so it is not that uncommon, undergoing abdominal imaging. Coming to epidemiology, it is the most common hormonal abnormality seen in patients with adrenal incidentaloma, prevalence seen to be 1 to 29%. There is one of the important factor why we need to diagnose subclinical Cushing, because in most of the studies it has been seen there is increased prevalence of cardiovascular disease risk if the patient is having subclinical Cushing. The proportion of patient which progresses from subclinical Cushing to proper Cushing is low. Only 1.7% will progress, and that too who are having more than 3 centimeter or larger adrenal mass, they will progress. Now coming to progression to overt is controversial, and spontaneous normalization has been seen in around 50% of the cases. Common in women and older adults, and frequently it is undiagnosed. Coming to prevalence, we have seen there are many different studies and the prevalence rate vary from study to study, but as such if we talk about prevalence of subclinical Cushing is estimated to be 2%. If 10,000 patients we are going to screen, 200 people will be having subclinical Cushings out of them. Now what is the difference between Cushing's and the subclinical? It is a well recognized entity. We all know the signs and symptoms of Cushing. It has typical cortisol, higher secretion from adrenal adenoma. It is managed by adrenalectomy, surgical removal. Coming to subclinical, it lacks that typical features. It is diagnosed biochemically with a higher cortisol level. Potential long-term metabolic and cardiovascular risk is there even without the classical Cushing's features in this patient. Pathophysiology, there will be adrenal adenoma which will secrete cortisol autonomously. ACTH suppression will be there because of the secondary regulation. Partial glucocorticoid effect without full-blown symptoms. Now coming to clinical feature, no classic features of Cushing will be seen. Common issues, there will be hypertension, central obesity, type 2, osteopenia and dyslipidemia, we told you. So this were number of patients who were having adrenal incidentaloma when they were followed for this much of duration, and you can see out of like this many patients, only 1 came out to be Cushing in this study, 5 in this, and out of this regression also seen in most of them. Only this one of them study shows that out of 5, 4 were transform. So out of that, if we see that out of 22% who are having subclinical Cushing, 0.7% will transform into overt Cushing, and regression will be seen in 1.3% of the patients. Complications, there are many multinational institutional study, and they have shown, most of them have shown these three complications: hypertension seen in 41%, diabetes in 10%, obesity seen in 28%. And these were the characteristics of the metabolic syndrome which were described. So mainly these are the parameters which are to be taken care in subclinical Cushing. Systolic diastolic hypertension will be seen, hyperinsulinemia, insulin resistance also can be seen, low HDL, elevated triglyceride, elevated fibrogen, hypercoagulability, and accelerated atherosclerosis risk has been seen in the studies. How to diagnose? No consensus in gold standard for diagnosis of subclinical Cushing still yet. The tests are similar, and this is the main: cortisol level greater than 1.8 microgram per deciliter will suggest subclinical Cushing syndrome. So if we talk about no cortisol excess subclinical Cushing, usually it will be in reference range. Only this is the parameter which will help us with the diagnosis. Now these are the different studies, and they have tested with different tests, and the final result. Why we need to diagnose subclinical Cushing? The rationale for screening is because we can early prevent the disease, that is subclinical, and we can prevent the cardiovascular risk and the dyslipidemia and all those issues. Secondarily, subclinical Cushing must be ruled out in every patient with adrenal incidentoma, because if it is unilateral, adrenalectomy will be done, because a post-operative patient will go into adrenal crisis if we do without knowing the cortisol level of those adrenal adenoma patient. Coming to differential diagnosis, three common are non-functional adrenal incidentoma, pseudo-Cushing, which is commonly seen in alcohol and depression patient, and the overt Cushing syndrome. Management: mild asymptomatic cases, you don't have to worry about much. Adrenalectomy for the patient who are having metabolic issues, like if we talked about obesity, hypertension, and diabetes, we can consider in them. Risk of adrenal insufficiency post-op to be considered. Post-op they can require glucocorticoid replacement. Now coming to clinical outcome of subclinical Cushing after surgical and conservative treatment. 2 minutes I'll be finishing. So coming to this, so this were the studies in which they have operated half of the patient, and they have not operated half of the patient. So what they have seen, the number of cardiovascular risk factors in subclinical Cushing patients significantly reduced with improvement in hypertension, dyslipidemia, IGT, diabetes in operative group. So post-operatively, the patient hypertension, dyslipidemia, diabetes was better controlled as compared to other who were not operated. Now these are the logarithm. My time is left. Yes. So subclinical Cushing, if greater than 70 years, follow up the patient, nothing to be done. 50 to 70 years, consider comorbidities, and then accordingly decide we have to consider adrenalectomy. If recent onset worsening symptoms and cardiovascular risk is high, you can consider adrenalectomy. If less than 50 years, you should consider adrenalectomy. Surgery to be done in patients who are younger age, less than 50 years of age, in those with cardiovascular disease risk factor or bone disease who are associated with hypercortisolemia. Prognosis: increased cardiovascular risk, we have talked about. Surgery is required to improve the metabolic outcome. It requires a long-term follow-up. Controversies over this topic is no consensus on diagnosis of treatment threshold. Debate over surgery in asymptomatic patient is an issue. Varying follow-up strategies. Now let's make it less complicated. Come to take-home message. Subtle but clinically significant condition it is. Cardiovascular risk, hypertension, diabetes, and dyslipidemia to be frequently seen in this patient. Detected during the workup of adrenal incidentoma. It requires multidisciplinary approach. Thank you. The eye sees only what the mind is prepared to comprehend. So unless and until we know about these diseases, we will not be able to work on these diseases. Thank you very much.
Thank you, Priyanka, for a very nice presentation. Well said that early diagnosis can prevent later complications. So if there are any questions, I would...
for this wonderful conference. We received multiple paper and poster presentation, and they were evaluated by a team of jury. So we will have a prize distribution ceremony after this session. After maybe another 15 minutes, we will have a prize distribution ceremony. So requesting all the postgraduate and all the dignitaries to be present in the hall. After 15 minutes, we will have. For the next session, I invite Dr. Sajid Ansari, who will be speaking on arrhythmia and hypertension, how to manage. And for this session, I invite Dr. Dinesh Thakur and Dr. A.M. Verma as chairpersons. The chairpersons to please join on the dais. Dr. Sajid to please take over for the next session. Thank you.
Thank you, sir. I was just waiting for your permission here. I think still it is good morning before 12. सभी को प्यार भरा नमस्कार, आदाब from city of Tehzeeb, Lucknow. I am from Lucknow. Our topic allotted to me by my dear friends, arrhythmia and hypertension. Our friends, you know, maybe we are managing hypertension since very long. What happened here? Okay. What is new in our Pandora? I mean, just to, this is established that hypertension and diabetes is not just disease of magic number and blood sugar. So when you diagnose the diabetes, we have in every CME, everywhere we are telling that this is the vascular problem. But when we are getting patient of hypertension, how many of us in the era of HFpEF, hypertension is supposed to cause a 40 to 50% cases of HFpEF, going to calculate ASCVD, going to calculate H2FPF score, what a risk for development of arrhythmia, going to calculate charge score. So this is the important. So this is a complex pathogenesis, how this hypertension act with severe risk and so many things is there. So hypertension is important risk factor for this all cause of disease, ischemic heart disease, cardiovascular disease, stroke and CKD. Coming to our part, arrhythmia. Hypertension can cause any type of arrhythmia from ventricular tachycardia, ventricular ectopics and supraventricular arrhythmia, but predominantly supraventricular arrhythmia, and among the supraventricular atrial fibrillation is the most common. If you see the literature of the hypertensive patient have lone atrial fibrillation where there is no vascular problem, around 20% of patients having atrial fibrillation. So how to overcome it in our problem, how to pre-decided our patient is going to develop atrial fibrillation in future and who is the high risk patient, that is the more important. So this is a complex pathogenesis, overactivation, RAS, sympathetic nervous system and aldosterone axis, and this lead to 2-3 things before development of complex picture of hypertensive heart disease, that is left ventricular hypertrophy. This is the important. You see the LA stretch, LA size is the important. When the pressure increases, that is reflected on the atrium rather than to going directly on the ventricle. Left ventricular hypertrophy is a little bit delayed events, but the LA size is important. That's why whenever you are getting picture of echocardiography in your clinical practice, don't only see for the left ventricular hypertrophy. Important is to see the LA size, LA index volume, LV diastolic pressure, and what is the index volume. That is important in the hypertensive patient. This is the pathogenesis, but 2-3 things are important. In the hypertensive patient, when BP is uncontrolled at atrial level, there is a shortening of active refractory period. So what happened? Atria become chaotic, and chaotic rhythm started in form of either supraventricular arrhythmia, in form of atrial ectopic or atrial fibrillation. On the same time, because of myocyte hypertrophy and myofibration, there should be increase in the LA volume and the development of LV mass. And one more thing mentioned here, this marker is not working. Reduce LA strain and LV strain, that's very important. When you see the diagnosis of HFpEF, because I am talking about this hypertension, it is important to demonstrate hypertensive heart disease, LVH, elevated hypertrophy, increase LA volume, index volume, increase PCWP and left ventricular diastolic pressure. But only 40 to 50% are meeting. But if you see the strain of the same patient, GLS is reduced and LA strain, the very important part, especially ANP, always you are talking of the BNP, but ANP early release from this LA, and this causes stretching of these fibers. So coming to treatment part, we know ASARB and a beta block, the wonderful treatment for the reduction in the hypertrophy and the reduction in the filling pressures. But the important is when you are getting hypertensive patient and you are planning for prescribing some NOAC type of for prevention of atrial fibrillation, you calculate CHATS-2, I think our audience know, patient with CHF, hypertensive, age and diabetes and stroke and having some vascular problem. So, and if it is there, on the same time you calculate has bleed score also if you are planning for this. So, blood pressure control should be A, B, C, D, but if you see in terms of reduction of LVH, ACE and ARB is better than the calcium channel. I am here mentioning blanket statement, not individual component. If you are having concomitant atrial ectopic or atrial fibrillation, combination of beta blocker is better as compared to other group of medicine. If you want to reduce the filling pressure, what I am telling, LA size and LA stretch, you use diuretic to reduce the index volume and the filling pressures. So how to prevent primary prevention? It means we should stratify the patient. Suppose I am making clinically, one 40-year male patient came without any comorbidity, just hypertensive BP 160 by 80. Okay, we should be treat the patient after taking ECG, creatinine, all things normal. But at the same time, one 65-year-old male patient came to us with 160 by 90. Might their ECG is looking normal, creatinine looking normal. That is not absolutely normal. When you get the echo, ejection fractions looking normal, but you see the LA morphology, that's very important. LA size increase, stretch increase, index volume increase. So that is one notorious candidate in the future for the development of atrial fibrillation. And here this need to calculate charge AF score. You see their waist type ratio, BMI, systolic, diastolic pressure, and other comorbid condition in the past. So, as mentioned, beta blocker is supposed to be wonderful. Focus one thing, when you are getting patient of this atrial fibrillation, always should rule out primary hyperaldosteronism. And very easy in your clinical practice. When your patient BP is not controlled well, here our nephrologist, Dr. Mrityunjay, is sitting here, and you are getting hypokalemia in the lab finding, be cautious. Because in our practice, in my practice, I am not going to calculate this plasma renin activity routinely. But if you are getting hypokalemia, be cautious somewhere for the primary hypertension. If it is not controlled well, then you go for this plasma renin activity. So hypokalemia, low PRA plasma renin activity and high aldosterone level. If it is more than 50, it is clear cut. 10 to 50, it is in between, and up to 5 to low risk. This is the working chart for this. I will come. But not go for this, diagnosis of this Cohen syndrome. Important is as a clinician to rule out primary aldosteronism when you are getting patient of especially atrial fibrillation. Because this presentation of the Cohen syndrome is tachycardia, atrial fibrillation, flush, and increased BP like this. So this is one important aspect. So many things is there here. Algorithm for this, I will skip some slide, that is the better one. So when you are getting the hypertensive patient, you go to categorize age more than the 50, 65 year and having high severe risk patient. So categorize this patient. If it is atrial fibrillation is clear, you go and start this NOAC. There is a debate which NOAC, if renal failure is there, someone apexabar is a little bit better than the other one. But if it is not well established, then you go for the ELA electronic loop record, and it is not, and if it is there, F is there in the same time, there is indication for this ICD devices also if patient having the frequency of ventricular ectopic in the poor LV functions. So if F detected, issue become very simple, but if it is not detected, the thing should be make it clear those who is the high risk patient, who is high risk patient, even ECG is looking normal, but their filling pressure is high, PR interval is prolonged, QRS widening is there, high age is there, BP is not well controlled, LSI is in class, might be relative wall thickness on 0.4 to 0.43 like this, might to develop LVH in the future. This is the high risk patient in the future for the development of atrial fibrillation. Be cautious about these kind of patients. So health issue is the always problem. So this I will go with this one slide. When you are going to prescribe this NOAC or VK, in the era of NOAC, we are prescribing NOAC. Anyway, SAM2 score is that age and what the treatment history, what the ratio tobacco is. If the SAM meet T2 score less than the 2, go for the VK, more than 2, go for the NOAC. So I think I will summarize it in my words. So in my words, when you are treating the hypertension, don't think this is a magic number disease. Day 1, you calculate a CVD score and make a plan. My patient is simple hypertensive or having some comorbid condition. This patient might develop in future of complex hypertensive disease in form of increased filling pressure. We know in practice what happens. Patient coming with shortness of breath and chest pain, getting angio is normal. Because of LVH and increased LA pressure, risk factor for ischemia. So on the time, and if it is high risk, you should be frequently follow for the dead patients. This is by gentlemen, music and rhythm find their way into their sacred place of souls. So I justify my topic in the 12 minutes. So thank you. And this is from APCH, this is the International Conference for Asia Pacific Congress Hypertension in Lucknow, 27 to 29 November. Welcome those over who are interested. As our 9th Secretary, I am inviting all of you. Thank you, all from my side.
No question answer? Any question? We are running short of time, so we close session here only. It is a selection of proper antihypertensive that will serve many of the problem of arrhythmia.
So, sir, that's why the main emphasis with antihypertensive. Future planning is the important. What's supposed to be go our patient in the future? 75-year Baba hai, so that is the high risk patient. 35-year wala hai, so that is no problem. So this should be important. And once develop atrial fibrillation stroke, we know how much is the cost-effective problem is there. Thank you, sir.
So thank you very much, sir. I request the speaker and the chairpersons to reach to the felicitation desk. Now we have a very important session of this conference. That is the prize distribution for the research papers and the posters which has come for the competition. For distributing these prizes, I request the organizing team, including Dr. Abhishek Srivastav, Dr. Parimal Swami sir, Dr. Ritu Srivastav, Dr. Mayur Agrawal, Dr. Promise Jain, Dr. Priyanka Kukrele, and Dr. Pushpraj Patel to be on the dais. The very purpose of this conference is also to promote the research. Research is one such neglected domain which have been lagging behind in this particular area. And now, with the more and more students coming for doing research in the relevant areas, particularly in the field of non-communicable diseases, is something which we can appreciate. So these prizes are not just for grading the student, they are kind of appreciation. So in this conference, we are giving them certificates, appreciation certificate to all of them, and cash prizes to couple of students. It was very difficult for us to judge, but then the judgment has to be made. I am requesting Dr. Anumati Jain to be on the dais. Dr. Anumati Jain. So I must congratulate all the students who have come from different medical college for taking participation in this particular workshop. And I thank them all. Requesting Mr. Ashish to come on the dais. Can I have a hand mic, please? तो बहुत मुश्किल था prizes को select करना, but then the expert of the team has actually decided it was a very difficult selection. You can appreciate कि prize देने के लिए हम लोगों को कई जगह पे दो had been a tie. The third prize is given to two participants, Dr. Yash. Dr. Yash is for third prize. Please come on the dais. Oral paper presentation. From RD Medical College under the guidance of Sir, Dr. Vijay Garg Sir. The next third prize is to Dr. Apurva Gupta for oral paper presentation from Allen Medical College. Dr. Apurva Gupta, third prize. Can we have lights on the screen? Yes, certificate, Dr. Apurva. Dr. Apurva. The second prize for oral paper presentation is to Dr. Alkesh Biani from Allen Medical College, Bhopal. Dr.
Hello.
Alkesh Biani.
Hello.
Second
Hello.
prize. Congratulations.
Hello. Hello. Hello.
Cash prize also to Dr. Alkesh Biani. This is a certificate. Yeah. And the first prize is to Dr. Vrinda Agrawal for oral paper presentation along with a cash prize. Dr. Vrinda Agrawal. Somebody else can collect his prize. Dr. Vrinda Agrawal, first prize. If she is not there, so we will send it home. Thank you, ma'am. So now the prizes for poster presentation. The third prize goes to Dr. Hemant Singh. Dr. Hemant Singh, third prize. This is for third prize. Congratulations. The second prize of poster presentation is to Dr. Sai Sweta. Dr. Sai Sweta, please come on the dais. Congratulations. Please receive your certificate and cash prize. Cash prize to this girl. And the final first prize for the poster presentation goes to Dr. Saurabh Dhakar. Dr. Saurabh Dhakar, first prize for poster presentation. Please come on the dais. Congratulations to you. He is from Gwalior. And we request all of you to continue your work in this field of research. Second prize is from Sagar. This is the cash prize, sir. Cash prize also. Light बंद कर दिया. Requesting esteemed guest, respected Dr. Rajesh Agrawal sir, whom we missed in yesterday's inaugural ceremony for Lifetime Achievement Award. Respected Dr. Rajesh Agrawal sir, जिनकी कल flight cancel हो गई थी. Please give a big round of applause. Dr. Rajesh Agrawal sir, please come on the dais. Sir. आइए sir. Thank you, sir. So because we had number of papers and posters, the other participant who has participated in the workshop, who has not got prize, don't be disheartened. You can please collect your certificates from the felicitation desk. Requesting all of the participants who has not come to the stage to collect the certificate from the felicitation desk. Thank you.
Dr. Vijay Garg sir to please come on dais. I request our chairpersons, Dr. Arun Kedia sir, Dr. Rajkumar Jain sir, Dr. Atul Patel sir to please come up on the stage.
in the ECG, especially non-cardiac diseases. But before that, I want to start with that thing, how Jabalpur is famous. Bargi Dam, lifeline of MP, High Court, MPB, Railway Zone, and IMA headquarter. These are the big things in Jabalpur. And what are the big luminaries of Jabalpur? First MP CM, Subhash Chandra Bose, land of Osho, Mahesh Yogi, Sanskar Dhani, and all these things. So I salute Jabalpur before starting my lecture. I start the lecture with, I salute these two people, Anton and Weller, who investigated the ECG. And today, 1.5 crore people doing ECG annually in this hour. I am presenting my experience of 40 years, which ECG played a great role in diagnosis of medical diseases. First case, presented with sudden quadriplegia, and this was ECG, and shown that patients having hypokalemia. Same thing with the patient operated for laparotomy, and he was on IV Cipro. So prominent U wave, flattened T wave, suggestive of hypokalemia, which clinched my diagnosis. About potassium level, we are not knowing about which potassium level causes these things. In patients who are having potassium less than 2.5, prominent view, prolonged QT prolongation. This is the ECG of Yadav, who presented in 2025, having peak tall QRS widening, lengthening of PR interval and flat P wave, suggestive of hyperkalemia. Or in the same way, these are the Sino wave in which potassium reflect that potassium is more than 6.5. And by this we can know which type of potassium is there. In case of early days, we get only tall T's. In case of terminal, we get a Scion wave. The V wave warns the sine wave alarm the ECG reflections of hyperkalemia. Means only U wave suggestive of hypokalemia and sine wave suggestive of hyperkalemia, we should be on the front. And this is the ECG of uremia showing T-wave alternance, well, is these things. And this is the ECG of having patients having a chronic cough presented with the chest pain. This was the ECG showing patients having a pneumothorax. This patient was brought from Bhaitpur to me, showing that Dr. Sahab, isko heart attack ho gaya. When I saw the ECG, मैंने कहा Rssearch करा लो and we'll get the diagnosis of pneumothorax. In the same way, if patients having COPD and P-wave axis is more than 85, this patient needs admission. And these are the feature. Another important feature, respiratory, Solfunky, patient admitted with the patients having profession with the patient admitted in the Ujjain Heart Hospital with the history of acute onset of dyspnea, palpitation, heart rate was 130, respiratory rate was 30, chest was clear. So if any patient having hypotension, tachycardia, no chest sign, sudden onset, think of pulmonary embolism, and this was the ECG. Tachycardia, S1 key 3-2 pattern, and V1 T inversion. And these are the various ECG finding in pulmonary embolism. And this is important ECG, but to me, having low voltage in V5, V6, I told the chest problem is there, and it has come out with the pleural effusion. So low voltage, usually low voltage is high in V5, 6, but if we get this V5, V6 low voltage, think of pleural effusion. This is the ECG of thyrotoxicosis, patients present with tachycardia, atrial fibrillation. And this is the ECG of myxedema showing low voltage and patients having a low voltage in chest and augmented lead also. And these are the infiltrative disease, amyloidosis, sarcoidosis, in which patients having low voltage along with AV conduction abnormality, think of amyloidosis. And this is sarcoidosis, in which Q is present is like this thing. And this is aluminum phosphate poisoning. We all having sulfose poisoning. Patient is fully conscious, but patient die of myocarditis because of ST depression. Even pseudo-ST elevation is there in aluminum phosphate poisoning. And this is very important ECG of patients having aconite poisoning of homeopathic medicine. So if you see the bizarre pattern of arrhythmia, any young patient always ask homeopathic medicine. And this is the ECG of TCA poisoning showing terminal QRS, white QRS. And this is very important ECG of bhang, which is very fond of poisoning in our Ujjain, and patient presented with sudden syncope and palpitation. This was the tachycardia. You will be surprised to know 628 kilo bhang is consuming in India daily. More than even opium, ATS, and hashish heroin. This was the data yesterday in Times of India. And these are the things of poisoning, tricyclic, aconite, digoxin, and theophylline. And very important ECG of spike helmet sign. If you find any critical patients with this type of ECG, patient's prognosis is very poor, whether it is a septicemia, whether it is a pulmonary embolism, or whether then this is the ECG of syncopal, in which Q2 is prolonged. So whenever the patient present with syncopal, always take the ECG and having these type of things, bradycardia and Adam stroke. And always our RMO used to say, Dr. Sahab, isko to unconsciousness ke saath ischemic heart disease bhi hai. Don't put patients on ischemic heart disease. T-wave inversion is common in all acute CV inversion. And please remember, when you take the ECG and patient's artifact and Parkinsonism in your day-to-day practice. And this is very important ECG nowadays, because we are doing ECG, computerized ECG. And if you see the linked ECG, tachyarrhythmia, but always see for broad ECG, baseline ECG for patient depicting arrhythmia. So upper zone shows tachyarrhythmia, atrial fibrillation, bottom shows normal. So always see for arrhythmia in raw ECG in cases of computerized ECG. And always, because so many times now technicians are taking the ECG, please take care of the first P and T inversion Our second lead shows low voltage. This is the lead placement, otherwise you will do the mistake. And this is the ECG of a dying heart. And this is the future things, recent technology. We all are having mobile watches, Holter monitoring. So these are the few things which detect the patients having arrhythmia and in non-cardiac diseases also. So ECGs are very fruitful, are having the correct diagnosis. Clinical correlation is very, very important. So most thing is clinical judgment in which all things are flow. Thank you very much. Yoga was the yesterday days. So patients, if you want to lessen the diabetes, do the yoga daily. And I congratulate you all on Happy Doctors Day, 1st July. Thank you very much.
Our topic for workshop is current perspectives in managing diabetes emergencies. I would like to request Dr. Niklesh Jain sir, Dr. Promise Jain sir, Dr. Ashish Mandloi sir and Dr. Vishal Gupta sir to please come on dais. I request all of you to please join us.
To everyone. We're running slightly late and the workshop is supposed to have some more time. So, looks a very dated topic when we think about it, Diabetic emergencies. So diabetic emergencies is actually a very dated topic, People think about it, what is there to new to learn in terms of, wait a minute, I'll just remove this. What is there to learn in terms of diabetic emergencies? So over the course of next half an hour or so, I'll probably try to touch upon certain new things, not all of it because the session becomes very long if I try to do everything. And let's see if I can, make everyone a little bit more wiser about managing these common emergencies. So, yeah. This is just my CV slide. Okay, so we start off with two case vignettes, These two case vignettes seem to be pretty simple and most of you can identify with what it looks like, 32-year-old woman, known history of type 1 DM, presents to ER, complaining of nausea, vomiting, abdominal pain for past 24 hours. She's got polyuria, polydipsia for past few days, admits to having missed her insulin injections owing to financial constraints. Appears dehydrated, dry mucous membranes, tachycardia and hypotension, blood glucose of 450 milligram per deciliter. Arterial ABG analysis reveals a pH of 7.2, bicarb of 12 and ketones in urine. This is the second one. 45-year-old man, type 2 diabetes, presents with complaints of weakness, fatigue, and increased urination over the past week. He's also experienced weight loss despite an increased appetite. Tachypneic, lethargic, BP of 140 by 90 mm mercury, heart rate of 110 BPM, respiratory rate of 30 breaths per minute. You do labs, it tells you blood glucose of 500, pH of 7.1, bicarb 10 milliequivalent per liter, and positive urine ketones. Till now, it is fairly simple what we are talking about, DKA looks very fairly likely. So next we enter into the domain of certain questions, okay? So,
Yes.
First question, what do you think can be any precipitating factors in a patient of type 1 or type 2 DM having possible DKA?
So precipitating factors in DKA, I mean the infection, sepsis, UTI is the most common cause of DKA. Ischemia, any patient may have myocardial infarction or any other CVA or any other ischemic factors. Then omission of insulin, as you told in the case, the patient omits the insulin, so it is one of the major cause of DKA. Then DKA may also present for the first time in type 1 diabetes as the initial presentation, and intoxication. That is the certain anticyclic drugs, clozapine, olanzapine, or any drug abuse. So there are 5 I's: infection, ischemia, intoxication, and initial presentation of diabetes, and omission of insulin. The 5 I's are the main presenting factors of DKA.
One more point I mentioned, sir. Nowadays, most of the patient of type 1 diabetic getting the SGLT2 inhibitors. It can be used in the type 1 diabetes also. So the blood sugar level has come down with the insulin, and the patients obviously stop the insulin, taking in the insulin. So the absolute there is the insulin deficiency. So SGLT2 inhibitor is a big factor for the precipitating the the DKA, and it will cause the euglycemic DKA. So it is the one of the most important precipitating factor we should remember, and the side effect after, because the SGLT2 inhibitor is a cause of the UTI also, which is also lead to the precipitating factors.
Okay, so I'll just go over this. First thing is obviously good, inadequate treatment or compliance, new onset diabetes as you told earlier, illness, infections, MI, stroke, TIA, acute pancreatitis, but a big category is drugs. Drugs we need to know about, some of them are very common. How many of us use olanzapine? I mean, it's a fairly common drug to be prescribed nowadays. So clozapine, olanzapine, obviously cocaine doesn't factor in, lithium, SGLT2 inhibitors, it is written right, left and center nowadays. Terbutaline, not too much. So, how do they present clinically?
Patient may present with the various symptoms, as you said in the 2 cases, polyuria, polydipsia, loss of weight is in the long term, recent weight loss is also, and patient may have the symptoms of the UTI or the sepsis. These are the most, and the most important clinical symptom is the nausea and vomiting. Due to the ketone bodies, they stimulate the vomiting centers and the receptors in the gastric. So they will lead to the all these the GI symptoms.
Sir, okay. I will like to add, in that case, pancreatitis patient may present with in case of DKA.
Yes.
And along with that, in later stage of the disease, patient might go in mental disturbance and comatose state.
And I saw the few cases, 2 or 3 cases, absolute abdominal pain only, no vomiting and nausea. They can also have the abdominal pain superior most of the time patient.
So do you feel abdominal pain is more common with DKA rather than HHS?
In both, but HSS has the most common symptoms of that pain in abdomen.
Okay. So rapid evolution is the first key, less than 24 hours, polyuria, polydipsia, weight loss. You can get neurologic symptoms including lethargy, focal size obtundation. Later stages, progression to coma can happen. Now, just remember this point, mental obtundation is known to occur in those subsets who have got lesser degrees of hyperosmolality, when severe acidosis exists. Nausea, vomiting, abdominal pain, yes, and abdominal pain, one important point to remember this, the more severe the abdominal pain, the more severe is the metabolic acidosis whenever you are doing an assessment of patients with DKA. So, physical examination findings would be decreased skin turgor, dry axilla and oral mucosa, low JVP, tachycardia, and if it is severe, hypotension can happen. Obviously, once the equilibration happens, so this equilibration has to happen across CSF. So once your acidosis intervenes, if it is severe enough, first it goes into the blood, then it goes into the CSF. Once it goes into the CSF, that's when you start getting Kussmaul breathing, or what you call as a compensatory hyperventilation. You can get these patients tachypneic and very difficult to manage. A lot of these patients get inadvertently put on non-invasive ventilation because people tend to think that that will control their tachypnea. That doesn't happen in actuality, because the stimuli for that would be acidosis, and it is compensatory hyperventilation. When we talk in terms of labs, lab tests.
Basic labs will include serum glucose level monitoring. It should be more than 300, in between 300 to 600 in case of DKA. And if we are talking about HHS state, it should be around 600 to 1200. And along with that, complete blood count is important to look for sepsis or infection. And along with that, renal function test and liver function test is also important. And if urine ketone is positive, then we have to go for serum beta hydroxybutyrate analysis if the urine ketone is positive. And ABG, regular ABG, like every 1 hourly, 2 hourly is needed. And electrolytes is also important because we have to manage with insulin and normal saline. So sodium and potassium is needed. Bicarbonate level we need. ABG may we have to look for anion gap, whether it is a high, because it will be a high anionic state. So that we have to see ki high anionic content is there or not.
Okay. So what I'm going to do is, I'm going to run it slightly fast, this particular slide. Most of it is known, but something that is unusual, you should know about, monitoring your plasma osmolalities, one, and other tests like cultures of urine, sputum and blood serum, serum lipase, chest radiograph, they may need to be performed depending upon case to case. Rest of it was covered by Dr. Vishal. So how do you grade the severity?
The grading severity, as we know, the blood sugar is more than 250 milligram per deciliter. But the arterial pH, it is less than 7.3. As the severity increases, the pH decreases. In the severe DKA, when the patient is unconscious and comatose, the pH is maybe less than 7. And then the bicarbonate level are generally less than 18. In the moderate, it is 10 to 15, and in severe decay, it may be less than 10 millicrons per liter.
Okay.
And anion gap is more than 10 in mild decay, and it may be more than 12 in moderate, and it may increase further in severe decay.
So ABG and the neurological symptoms can differentiate mild, moderate, and severe.
Okay. So I'll again go into this. These are the various things that come around. Now certain things that you all need to remember, as I told you, serum osmolality is one, and serum ketones, which is typically done by a nitroprusside reaction. So you also need to have an enzymatic assay of beta hydroxybutyrate if you want to really manage your patient well and grade your patient well. So what is the importance of absolute glucose values when you're managing decay?
Anybody can idea regarding this absolute glucose from the audience? Any PG students can comment on that?
Anybody is free to comment. What do you mean by absolute
This
glucose
should be
value?
the interactive actually, and the comment should be from the audience. In particular, this term, absolute glucose value. So I think sir will explain thoroughly for that particular slide.
So usually we say generally less than 800 milligram per deciliter, and often in the range of 350 to 500 milligram per deciliter when it comes to diagnosing a diabetic ketoacidosis. We say that euglycemic decay has been described particularly in patients with poor oral intake, treatment with insulin prior to their arrival in emergency room, pregnant women typically, along with patients who are on SGLT2 inhibitors. SGLT2 inhibitors mechanism is given. What they do is they basically block SGL2, and the leading glycosuria can minimize or prevent development of hyperglycemia, despite the fact that the patient may be having intrinsically low insulin levels, which leads to development of ketoacidosis. So this is what we mean in terms of absolute glucose values. It was simple. I mean, that's not very tough. Maybe the word interpretation got misled.
This is a very important slide, actually, the measurement of errors for the glucometer.
Now, most of us rely on glucometer in most of the settings. What really happens? Do you know how do you actually what are the things you should look for when you are measuring these things through a glucometer?
Any comment from audience? Okay. I think Dr. Vishnu.
Sir, measurement error for glucometer, we have to look for external factors as well as intrinsic factors in the glucometer per se. Extrinsic factors includes like temperature variations and the way the staff or a doctor is taking the sample, whether the finger is wet or not, whether it is infected or not. Along with that, glucometer strips is working properly, whether it is compatible with the device or not, whether the enzymatic activity of the strip and the meter is compatible with each other or not. These are the factors which affect the glucometer reading. And as well as there is a correction factor of 90 to 100% when we are checking sugar with a glucometer. So that if we want to control it very tightly, then the chances of error is more. And if the sugar is more than 100 or 200, then the chances of getting error is less. So it totally depends on how much tight control we want with the help of glucometer. So we'll suggest central lab measurement of the glucose is important in that case if we want to measure tight control.
And the ABG tell the hematocrit. So you should see that hematocrit in the always decay, and hematocrit correction of the glucose level is much more important thing.
So basically what we mean is arterial blood is probably much better than any other sample.
Yeah.
Okay. So basically there is a significant concentration difference between plasma and whole blood. Concentration is higher wherever water content is higher. If you've got higher hemoglobin values, they will lead to lower concentration of RBC glucose concentration. So it has got an inverse proportion with protein concentration. Whole blood glucose, what you see, is equal to plasma glucose plus RBC glucose. And there's something called as a hematocrit adjustment which you should apply to it. This is the equation. I'm not going to go into too much of details of it. Anybody is interested, they can connect with me on the same. What about measuring it in plasma? The lab tests.
Yes, sir. So measuring plasma, generally the blood sugar glucose is more dissolved in the plasma. So the RBC has less amount of glucose. So when the blood sugar is measured in the plasma, it is a higher concentration as compared to the whole blood. So it is around 10 to 15% more than the whole blood. So the glucometers generally measure the whole blood glucose. So, but nowadays some glucometers, many glucometers have come which give the interpretation as the plasma glucose by giving the correction factor. So about 1.1 times of correction factor is required for converting from whole blood glucose to plasma glucose.
Okay, Vishal, you want to say something?
Yes, I want to add one more thing in that. Basically, if the hematocrit is high, then the sugar content in that sample will be low. So अगर patient का hemoglobin और RBC content ज़्यादा है तो sugar कम आने वाला है. That's why we advise for the central lab measurement. One thing. Second, जो भी हम glucometer use कर रहे हैं, that is mostly standard for 30% to 50% of the hematocrit value. So suppose a patient is diseased with high RBCs or low RBCs, at that time we have to calibrate the glucometer itself for the repeated readings.
Correct. So, plasma measurements are independent of RBC mass, and that is why they are superior along with hematocrit, and they roughly range around 11% higher than the whole blood. Ideally, sugar measurement in serum is not recommended as values tend to dip during collection times. You need to apply a correction constant of 1.11. It is very difficult to assess which of these would be true whole blood glucose, which of this would be, how much of this quantum would be converting to plasma glucose. There's no standardized guideline or a nomogram which tells you of this. However, it is recommended to report all your glucose values as plasma equivalent rather than absolute values. So what are the variables which are complicating therapeutic strategies?
There are many variables regarding the what we decided to give the dehydration or hemoconcentration is the one more important thing. We should correct that, and low GVP, IVC measurement of fluid therapy. These are the most common variables, I think. And the acidosis correction and the plasma osmolality is the one more important variable which should be taken care for for treatment purpose.
Okay. So I'll just rush through this. So what are the variables which complicate your therapeutic strategies? One is of course severity of illness, concurrent medications, whatever that patient may be getting. In case of a critically ill patient, it may be something as simple as NORAD and adrenaline infusions, unpredictable diet, patients getting frequent breaks for certain tests and procedures, nutritional status and prevailing glucose levels, anticipated length of stay, history of diabetes, and what was this particular patient's regimen before getting hospitalized. And of course, HbA1c of your patients in cases where you get a recent onset hyperglycemia. That becomes important. What are the finer points of ketone testing? Most of us tend to, do it with a urine strip, but what are the finer points?
Sir, there are three types of ketone bodies present in the body. One is acetoacetate, second is acetone, and third is beta-hydroxybutyrate. Acetone is formed by decarboxylation of the acetoacetate and reduction say beta-hydroxybutyrate. So what we are doing in a urine strip test is the nitroprusside testing, which will come only positive for the acetone. So if in early phase of decay, generally we will not able to see that much of ketone bodies, or if we are treating the patient and patient is recovering at that time also, in the urine ketone test is not that much of significance. That's why beta-hydroxybutyrate in blood level, which should be generally less than 0.6 millimole per liter, it might be high in that case. Beta-hydroxybutyrate should be more than 3 millimole per liter.
I'll go into this. So basically we are talking about three ketone bodies, One is acetoacetic acid, another one is beta-hydroxybutyric acid, and third is of course the acetone per se, which is derived from decarboxylation of acetoacetic acid. Acetone is a true ketone, not an acid, and testing for serum ketones is generally performed only if urine testing is positive. Now urine ketone bodies, as Vishal said, is detected with nitroprusside tests, whereas serum ketones can be detected with either nitroprusside test or direct assay of beta-hydroxybutyrate levels. Why we talk about beta-hydroxybutyrate levels? Now remember that once a urine strip for ketone comes out positive, it may remain positive for 5 to 7 days. तो ये कहना कि इसका ketone test positive है और इसको लगातार treat करते रहना, ये गलत होगा, because even if it comes out positive once, it will remain positive for 5 to 7 days. But if you got a direct assay of beta-hydroxybutyrate, you can actually have a quantitative measure, and they are preferable for monitoring your response to therapy and actually assessing कि patient कितना बेहतर हुआ है. There are some more points. In acute diabetic ketoacidosis, you get a typical ketone body ratio of 3 beta-hydroxybutyrate to acetoacetate, which rises from normal, that is 1:1, to as high as 10:1. Once you've given insulin therapy, 3 beta-hydroxybutyrate levels again decrease long before acetoacetate levels do, and nitroprusside test will only detect acetoacetate in blood and urine. A semi-quantitative assessment of ketone levels is done at times, and it is actually associated with false positive results. So probably you should start asking your pathologist to do more of beta-hydroxybutyrate levels whenever it comes to monitoring your DKA patients. How do I interpret electrolytes? I think voice.
Electrolytes, we have to measure the serum potassium must be measured. Even before initiating an insulin, serum potassium must be measured. If serum potassium is less than 3.3 or equal to 3.3, potassium supplementation should be done first, then only insulin should be administered. Because it will cause hypokalemia because of the intracellular shift of the potassium from extracellular to intracellular fluid. And the serum sodium, it is falsely low in hyperglycemia. As the blood sugar rises, the measured serum sodium is less. So we have to add about 1.6 milliequivalent for every 100 milligram per deciliter rise of sodium.
Okay, I'll just finish this.
I think we should finish in 2 minutes, sir.
Okay. So serum sodium in the lab report is falsely low in diabetic ketoacidosis. It is corrected by adding 1.6 milliequivalent to the measured serum sodium for each 100 milligram per deciliter of glucose above 100 milligram per deciliter. Serum potassium is usually elevated. Why it happens is because of a shift of potassium from intracellular to extracellular space, which is caused by acidosis along with insulin deficiency. Total body potassium may be depleted or may quickly become depleted with insulin administration. Magnesium is often low, often ignored, and it also requires replacement. How to give fluids? I'll take this myself. It will be going relatively fast. So isotonic fluids have been used traditionally with normal saline as a fluid of choice. Crystalloids are non-inferior to colloids. In large volume resuscitations, you can actually switch over from normal saline to ringer lactate or relatively balanced salt solutions if your chloride levels are more than 100. Remember that. Infusion of 15 to 20 mils per kg body weight in first 1 hour is typical, or what you can do is something easier to follow. Give 1 liter per hour for 4 hours as appropriate. If you are dealing with adult subsets, the risk of cerebral edema is minimal. When it comes to maintenance IV fluids, depend on hemodynamics, state of hydration, serum electrolytes, and urine output. Subsets with high serum sodium level, you use half NS or 0.45% sodium chloride infused at 4 to 14 mils per kg per hour, or roughly put 250 to 500 ml per hour is appropriate. If you've got a patient with hyponatremia, NS can be given at a similar rate. If you've got a hyperchloremic metabolic acidosis, that is chloride levels are going more than 100, try switching over to ringer lactate. How to give insulin? This is simple. Shall I move?
You continue, sir, because the time constraint is there.
Okay. So treatment protocols have recommended the administration of an initial bolus of 0.1 units per kg. You continue with an infusion of 0.1 unit per kg per hour. If you've got a plasma glucose level reaching 200 to 250, and if the patient still has an anion gap, remember you have to do an ABG, then dextrose containing fluid should be initiated and the insulin infusion rate may need to be reduced. Uncomplicated mild DKA can be treated with subcutaneous insulin Lispro hourly, and insulin aspart has also been used in this type of setting successfully. So how long do I give insulin? You give insulin till resolution of DKA. Resolution कब मानते हैं? Blood glucose is less than 200 and you have 2 or more of the following criteria. Serum bicarbonate more than or equal to 15, venous pH more than 7.3, or having a calculated anion gap which is equal or less than 12 milligrams per liter. Transition to subcute insulin when DKA is resolved and they are able to eat. Insulin naive people should receive a regimen beginning at a dose of 0.5 to 0.8 unit per kg per day. Do remember, whenever you are making a switch over, continue your infusion for 2 hours after starting subcute insulin and then check your blood sugar and then stop it. Use long-acting, if you use long-acting insulin analogs during initial management of DKA itself, it can actually facilitate your transition faster. Another question that is asked, do I replace bicarbonate? No major benefits, can be used in patients with severe acidemia, pH less than 7.1. Therapeutic problems will include paradoxical CSF acidosis, hypokalemia, large sodium bolus, and cerebral edema. There are just 2 ABGs I brought. This is...
Sir,
yeah.
Time constraint is there, sir. Please.
2 minutes more. I'll not showing it in detail. Basically, we have a series of 12 patients in last 2 years which have had euglycemic decay because of DAPA, and that is a major problem now. This is a differentiation of HHS versus DKA. It is no longer called as HONC, it is HHS. So depending on, rather than that, this is something you would be all knowing. How do you label a case as HHS? HHS is defined by sugars more than 600, effective osmolality more than 320, and absence of significant ketoacidosis. Glucose values between 600 to 1200. Higher the level of glucose, greater the osmolarity, and higher the degree of dehydration. And these are the common fluid principles. ABC, secure airway, GCS less than 8, potassium replacement for value between 4 to 4.5. Keep your sugar levels around 300. And this is an algorithm to manage osmolarity. Anybody can calculate. I'll finish off on this, This remains a point of contention, A lot of us tend to think that these disorders tend to exist in isolation. There is a significant degree of overlap. And now it is a well-recognized entity that both DKA and HHS can coexist. And this is as per the JBDS guidelines for JBDS-IP guidelines for DKA. So you have 4 different categories. One is pure DKA, another one is mixed DKA bar HHS. Then you have ketosis but not in DKA. And then you have HHS, ketonemia along with no acidosis. Thank you so much.
to please move forward for felicitation. Now next, I would like to request Dr. Mayur Agrawal sir for speaker. For chairperson, I would like to request Dr. Aditya Parihar sir, Dr. B.M. Sharnagat sir to please come on stage. Dr.
Yeah, good morning everyone. Should I start? Yes. नहीं ठीक है. Done तो हो रहा है ना. छोड़ दो यार. अरे छोड़ दो यार. इतना में ही चला लेंगे आप. Let it. Good morning everyone. At the outset I would like to thank the organizer. This is the symposium, metabolic symposium. As a disclaimer, you cannot take photos. This is a Lilly sponsored talk. Photos are not allowed. So what I am going to talk about is tirzepatide. How many of you have actually used it? Raise your hands. Just one person? It's a newer molecule. Has anybody heard about it? Raise your hands. Okay, at least few of them have heard. So what is the basic mechanism? It's a dual agonist, GLP-1, GIP-1 agonist. So very simple question. Can anybody tell me the full form of GLP, GIP? This is to bring attention to the talk. Very basic question. Anybody? My talk is just to sensitize you regarding the molecule. We are not going to discuss much of data, where to use, which kind of patient to use, what's the guideline. That is what I am going to talk. So we are running already out of time. Can anybody tell me? Let it be wrong, no issues. Somebody from the back? I can see few of the people holding their mobile. Don't search, just answer. What's the full form of GLP-1? Okay. Glucagon? Okay. And? Yes. And what's the full form of GIP? No. Anybody? Because see, we are going to use a molecule, how it is acting. If we don't know that, where are we going to prescribe? So that would be dealt. So let us talk about this and whether it is more of GLP or it is more of GIP. That's even a tougher question. Can anybody say that? Very good. So it's more of GIP. It resembles more of GIP. Okay. So this is GIP. Okay. Glucose dependent insulinotropic polypeptide. That is what is the full form of GIP. Okay. So basically it releases insulin dependent on your blood glucose. So that's an advantage. When you have higher blood glucose, more of insulin is released. When you have low of your glucose, less is released. And not only that, this will also act on the glucagon. So if you are going low, glucagon increases, brings your sugar back to normal. So it's like balancing act. Okay, that's what this drug is doing. And it is not just acting on the pancreas and the CNS, on the adipocyte and the vasculature. Okay, so pancreas I have already told you, it counterbalances both the things. It acts on both the things. That's insulin plus glucagon. It acts on the CNS, increases your satiety, decreases your appetite. It acts on the adipocyte. So adipocyte is something where your GLP will not act, but your GIP will act. So under fasting state, it acts on more on the adipocyte, causes release of the lipid. Vice versa, in fed state, it increases the uptake of the lipid on adipocytes. So it's a dual mechanism, opposite mechanism, it's counterbalancing, right? A very simple example is like, let's say somebody is having fever. If he takes paracetamol, the temperature goes down. If the patient does not have fever, takes paracetamol, does not go down, right? It balances itself, right? Something like that you can understand. So this is more of GIP and it works for 5 days, no dose adjustment with moderate renal and hepatic impairment. So let's talk about more about this. So this is a dual agonist. It acts on both the receptor. It reduces appetite. It decreases your craving. It regulates glucose uptake. It modulates the lipid and this lowers the body weight, and we have data for that. The approved indication is diabetes and without diabetes also obesity, but that obesity indication is somebody with a BMI of 30 or somebody with a BMI of 27 with comorbid condition like your hypertension, dyslipidemia, OSA or cardiovascular disease. So that's an indication. ऐसा नहीं है कि मरीज बोल रहा है मेरा 60 किलो है मेरे को 50 करना है. It's not like that, right? It's an approved indication where you can prescribe, where you cannot prescribe. You should not be going off label, right? So that's an indication for drug. It's not कि आज अभी मेरे को 1 महीने में weight कम करना है, मेरी शादी है, ये sort of these drugs are not meant like that. Okay. So we have 2 trials for this, Surpass trial and the Surmount trial. How many of you have heard the name at least? Raise your hands. Anybody? Yeah. So Surpass is basically for the obesity outcome. Surmount, O is for obesity. Okay. So O is for obesity, that is Surmount, and Surpass is for diabetes. Okay, so we have here surpass 1 against your placebo, 2 for against semaglutide, 3 and 4 against insulin, that's Degludec, Glargine, and 5 is those patients on insulin against placebo. So both the arms were on insulin. So we are not discussing this data, what we are discussing is this data. Surmount, okay, so this is for obesity, and this is 1, 2, 3, 4. What I will be discussing is 1 and 4. 1 is against your placebo, and 4 is a very big question that is answered here, कि क्या होगा जब मैं दवाई बंद कर दूँ, right? So that is your Surmount 4 trial, and Surmount 5 is against your semaglutide, which the next speaker would be discussing. So let's discuss the Surmount 1 trial. The dose what we start is with 2.5. India we have 2.5 and 5 mg. You start with a low dose. Every month you have to increase it by 2.5. The maximum dose is 15 mg. It has to be given subcute like you give your insulin the same way. Okay, so that's over 20 weeks you have to increase to 15 mg tirzepatide. You have to start with lower dose, and if you see the data, this is for obesity, right? So this is phase 3 multi-centric randomized control trial, almost 2,500 patients, and what they want is to see weight loss. Here they have enrolled those patients who have a BMI more than 30 or more than 26/7 with a comorbidity. So this is what is the data. In placebo, it was just 2.5% somewhere you can consider, and with 15 mg, 22% weight loss is there, and with 5 mg, it is 16%. But this is median data, right? Some patients, even with 5 mg, will lose somewhere 25%, and some patients, even with maximum dose, may not lose 20%. This is median data, right? So here what we are seeing in like 2 months of our practice, where I have almost close to 60 patients on this drug, patients are losing much more, but that's not the data, right? That's just a practical experience, but we need more data for that. And we don't have any subgroup analysis here for Indian patients. Okay, so here data was for India patients were enrolled in this, but we don't have any subgroup analysis. Maybe it is acting more, we don't know now. So this is the weight loss. Again, we'll go very fast. We are with just 2 minutes. Yeah, one more big question is whether giving this drug will the patient lose muscles. So we have data. They have even included the DEXA scan, which is the most relevant thing to know the fat mass and the lean body mass. So you can see the patient are losing mainly the fat mass, not the lean body mass. So this is your Surmount 1. And here you see the blood pressure reduction is there, the bad cholesterol decreases, the good cholesterol increases with this drug. Now let's discuss the Surmount 4, which will answer that when the patient stops this drug, whether the patient regains. यही क्वेश्चन होता है, कब तक लेना है, हम अब बंद कर देंगे तो क्या होगा. So that's the answer here. So what they did it for 36 weeks, both the arms were given tirzepatide to the maximum tolerated dose, then the one arm was given 10 or 15, and the other arm was switched to placebo. So you see here, this is important. When both the people were given drugs, almost 21% weight loss in 36 weeks. One arm who continued the drug, the weight loss to the tune of 26%, and this is the data for 88 weeks, and this is the biggest, longest data what we have for tirzepatide at present. And those patients who stopped the drug, they got rebound, but still it is lower, almost 10%. That means they will have some regain, but they will not bounce back to square one. Okay? That's an important answer here. Adverse event, everybody of us know, the GLP, GIP, it's mainly the GI side effects. We are running late. And tirzepatide decreases weight, and 16% with 5 mg and 22% with 15 mg, but this is median weight, right? Every patient is different. Some patient may lose 25% with 5 mg, and some patient may not lose 10% with 15 mg, right? That is in practice what you will see, and because there would be confidence interval for every data, right? But probably more patients are losing more weight here. We don't have any subgroup analysis. Blood pressure, waist circumference, triglyceride, everything improves. Mainly it's the GI side effects. Thank you. I was well within time of 10 minutes. So we can have the next speaker, and then we can have discussion. We'll have discussion after the Surmount 5.
Thank you, sir, for the wonderful session.
He is chairman of API. I would request him to start his deliberation because we have short of time.
Thank you, chairpersons. And I'll try to sum up in next 10 minutes because of the request by the organizers. So before I begin, I thank Dr. Abhishek to invite me. And I'll straightforward move to my topic, that is tirzepatide versus semaglutide. And we will see the head-to-head trials because these are the two molecules which have come into the market almost parallelly, and they are going to be the future in management of diabetes. And so we need to see what are the differences between these two molecules. So this is my disclaimer, and I've been sponsored by Eli Lilly for this talk. So GIP has already been explained by Dr. Mayur. I would not go into the details, and Mayur has already explained the difference between GIP and GLP. So we look at this example of a lady who comes to you with obesity without type 2 diabetes, and this is very common nowadays that people start consulting you only for obesity. So most of the time the patients will tell you that I have failed on all the attempts of lifestyle interventions and now I am fed up, so I need a drug, and that is where you need to discuss with them about the GIP, GLP agonists. So the question arises, which drug to begin with, whether to go for tirzepatide or semaglutide. And so we have this SURMOUNT-5 head-to-head trial between these two molecules, where tirzepatide maximum tolerated dose was compared with semaglutide maximum tolerated dose. And this was a trial exclusively for patients who are obese without type 2 diabetes. So this was the design of the trial. The patients were randomized into two groups, tirzepatide maximum tolerated dose versus semaglutide. And you can see that the maximum tolerated dose was either 15 or 10 milligram for tirzepatide and 1.7 or 2.4 milligram for semaglutide. So these 750 patients were followed up, and the primary endpoint was to look for the percentage change in body weight from baseline to week 72. And you can see the difference. So there was a significant difference between the weight loss induced by semaglutide, that was 15.4%, versus 21.6% with tirzepatide at the end of 72 weeks. And this difference was quite significant. And if you see the number of people who actually had weight loss beyond 25%, you can again see that tirzepatide scored over semaglutide. So across all the weight loss categories, you can see the percentage of patients who had success was better with tirzepatide compared to semaglutide. And if you see the loss in terms of waist circumference, further you can see that there was almost 6 centimeter difference in the inch loss, abdominal circumference loss compared to semaglutide. The tirzepatide was better. Then you have another subgroup of patients who have type 2 diabetes, and they may or may not have obesity, and you need to see what is the data for tirzepatide. So this was another trial, that is SURPASS-2 trial, where you had comparison of tirzepatide against semaglutide 1 milligram. And this was again a head-to-head trial of almost 1,900 patients with BMI of 34. There was a follow-up of 8 points. There was a mean duration of type 2 diabetes of 8.6 years. Average HbA1c was 8.3%, and there were 4 groups of patients. One started with 2.5 milligram of tirzepatide and escalated to 5 milligram and continued up to 5 milligram only. Second group continued on 10 milligram. The third group continued on 15 milligram. And the fourth group was started with semaglutide 0.25 milligram and escalated up to 1 milligram. And these patients were followed up for 40 weeks. And you can see the HbA1c reduction. You can see the maximum HbA1c reduction was seen with 15 milligrams tirzepatide. And even if you compare 5 milligram tirzepatide versus 1 milligram semaglutide, you can see that tirzepatide showed a better HbA1c reduction compared to 1 milligram of semaglutide. So that was the difference in this head-to-head trial. And you can further see that the percentage of patients who actually achieved HbA1c less than 7%, less than 6.5%, and less than 5.7%. Again, you can see the percentage of patients in tirzepatide group and the higher dose of tirzepatide group to be far better than patients on semaglutide group. And when it comes to weight loss in these patients, again, you can see that the weight loss was highest in tirzepatide 15 milligram group versus only 6.2 kg reduction in the semaglutide group. So even in semaglutide 1 milligram versus Mounjaro 5 milligram, you can see that the weight loss was better with tirzepatide compared to semaglutide. And again, you can see that almost 3 times more the number of patients achieved HbA1c reduction and the primary endpoint compared to semaglutide 1 milligram. So that was definitely significant difference. So adverse events with all these drugs, we all know, are the most important limiting adverse effects are gastrointestinal adverse effects. And if you see the comparison, you can see that the nausea, vomiting and all are almost comparable in both the groups, though theoretically we know that tirzepatide causes lesser nausea and vomiting compared to the semaglutide group. And these GI side effects were the only reason for drug discontinuation in most of the patients. Adverse events leading to death were 0 in all the groups, so serious adverse events were very few, and treatment discontinuation, you can see, was almost comparable in all the 3 groups of patients. So discontinuation by and large was almost similar in all the groups of patients, and hypoglycemia was, again, you can see that severe hypoglycemia was almost nil in all the groups, because we know that these drugs do not cause insulin secretion, and so they are safe. So to summarize, in patients with, people with obesity, tirzepatide maximum tolerated dose, that is 10 or 15 milligrams, achieved a superior weight reduction than semaglutide maximum tolerated dose. And in people with diabetes, it's demonstrated a superior HbA1c reduction as well as weight reduction compared to all the dose versus semaglutide 1 milligram. So definitely in both the parameters, we see that tirzepatide scores above semaglutide when it comes to efficacy. Now coming to some key considerations in initiating patients on tirzepatide. So I'm sure that in this August crowd, there must be a lot of people who already have started prescribing this drug. But for those who have still not started prescribing, what we have in India is right now 2.5 milligram starting dose. So you initiate with 2.5 milligram subcutaneous weekly. After 4 weeks, you can escalate to the 5 milligram dose. We do not have, as of now, beyond 5 milligram, but in time to come, we will have 7.5, 10, and other denominations up to 15 milligram. So the maximum prescribed dose is 15 milligrams per week. But remember that we need to be slow when we go for dose escalation, because most of the GI adverse events are related to dose escalation. And then we have a lot of helpful social platforms where we can actually ask the patients to go through this literature, and we can also provide them with various literature on how to, what to expect from this drug, and what are the various adverse effects that the patients have encountered in all the trials, and how to mitigate these adverse effects. Now coming to some practical aspects, if the patient is already on metformin and SGLT2 inhibitors, you can continue tirzepatide. But if the patient is on sulfonylurea and or insulin, then we need to reduce the dose so that the patient do not come across severe hypoglycemia. We don't require any dose adjustments based on age, gender, race, ethnicity, or body weight. But this drug is not licensed for people less than 18 years of age as of today. And there is no dose adjustment required in patients with hepatic or renal impairment. But in patients with severe hepatic and severe renal impairment, we do not have much data. And as of today, it is not advisable to put these patients onto drugs. Regarding acute pancreatitis, there has to be a word of caution. But if pancreatitis is suspected, then we need to prove it and then discontinue the tirzepatide. But just based on rise of amylase and lipase, we should not stop this drug. Pregnancy, this drug is not yet studied. So as of today, pregnancy and lactation are contraindications. And for diabetic retinopathy, there is a word of caution that because these drugs are very potent drugs and there is a very rapid decline of sugar, so some patients might come, you might come across some patients who have adverse events related to worsening of retinopathy. So in patients who have proliferative retinopathy, there is a chance that the patients may deteriorate. So be a bit smarter in putting these patients on tirzepatide. And if the patient come to you with GI adverse effects, a few simple advice: ask the patient to eat smaller portions more frequently. Patient needs to be mindful to stop eating once he's full. must avoid eating whenever he is not hungry, ask the patient to remain hydrated, avoid high fat food and spicy foods, and the patient needs to limit their alcohol intake. So I think, and this last slide is if the patient misses a dose. So if the patient misses a dose and it is less than 4 days, then the patient can take the dose on the day which he remembers. But if the patient has missed the dose for more than 4 days, then you must ask the patient not to take double dose. Rather, the patient can start a new schedule again. So that is the word of caution, that whenever a patient, let not the patient take a double dose just because he has missed the previous dose. So that is what we need to preach the patients. And thank you for a patient listening. We can take questions, Mayur and myself, with regard to this molecule.
Thank you, Dr. Kedia. Any questions from the audience are welcome on this very good molecule. I think we are going to get
Sir has a
triple G agonist also, the rizaperatide.
So with tirzepatide, when you have fat loss, there is some amount of weight loss. With regard to sarcopenia also, there is some amount of sarcopenia, but if you see the quality of muscle, there is decreased fat infiltration into the muscles. So the fat is lost even from the muscles. So there is some sarcopenia, but the quality of muscle improves. So you must ask these patients to go for some resistance training when they are taking this drug so as to avoid severe sarcopenia. So when the patient loses fat, there will be some amount of muscle mass loss also. But remember that the muscle quality will improve. The skeletal muscle index improves. That is what we need to teach the patients, and we need to ask them to go for resistance training. That is important.
As a protein intake, how much protein do you advise to take, patient?
So for a normal people, we require usually 1.2 gram per kg body weight of protein when we are expecting patients to go for a weight loss.
Thank you, sir.
That is a minimum requirement. Sir? Pre-diabetic patient, you can very well use.
What are the restriction and what is to be taken care? The pre-diabetic.
So in pre-diabetes, basically what you are looking for is you want the weight loss to occur so that the patient goes into remission and he goes into a category of HbA1c less than 5.7%. That is what we are looking for. So you can always use this drug for treating pre-diabetes also. Especially if the patient has pre-diabetes associated with MASLD, this drug is wonderful.
So, if you see, go by the product monograph, what they recommend is BMI of 27 with one comorbidity or 30 or more. If the patient falls in that criteria, you can use. Regarding your question on pre-diabetes, we have some data from the SURMOUNT trial that patients who were initially they got into normoglycemia, but the trial is still continued. And we will have dedicated data for pre-diabetes from these patients only. The SURMOUNT 1 is still, the data is still being collected. So to answer whether it can actually prevent diabetes is not answerable at present, but many of those patients who were pre-diabetes, and then they are also looking at how many patients during the course of time will develop pre-diabetes who were normoglycemic right at the beginning. So all those data is going to come up. The company has already enrolled it.
In America and on those places, maybe diabetic or non-diabetic, obesity part they consider and they go ahead with the injection.
I cannot hear.
Obesity, only obesity they consider. No, either diabetic or non-diabetic. BMI they consider and they go straight away with these injections.
No, they look for one obesity-related complication also.
No, you can go without complication also if the BMI is more than 30.
What is the discontinuation rate? Because this morning, ADA, GLP-1 discontinuation rate were revealed. 1 year discontinuation for non-diabetic for weight loss purpose around 50%, 2 years 64%. So what is the discontinuation rate of this particular molecule in the study and in the real life scenario?
If you talk about this molecule, we have just 2 months of experience. I would say my patient, some 60 enrolled, 6 are dropout, mainly due to GI side effect, somewhere around 10%, but that's like after 1 or 2 shot only. But when you talk about long term, I would say in India it would be even higher as compared to the Western world. Reason being, here the patient is paying out of pocket. There that's more of an insurance sector going on. Probably here patients, one, after he achieves some weight loss what he wants, or he is not losing further, most of our patients will discontinue. We should agree on that. But that is not what is recommended. But that is how it will happen. हमारे तो एक बार एक मरीज आता है, जब तक शुगर गड़बड़ नहीं होती तो एक साल नहीं आता है. That is what happens here.
And the second thing that I would like to add, sir,
what is the cause of regaining weight when you stop the medicine in between?
So once you stop the medicine, there will be definitely a weight regain. This weight regain will be slow process, and majority of the patients would have a regain at the end of 6 months to the tune of almost 50% again. So weight regain is definitely that we have to be very clear to the patients that if you stop this drug, there will be a regain. So that has to be answered very clearly to the patients. This is not a drug for short term.
Thank you.
Very simple analogy is like any of your blood sugar medication, any of your diabetes medication, any of your dyslipidemia medication, any of your thyroid medication. दवाई लेंगे ठीक रहेगा, दवाई हटाएंगे effects are gone. Reason being the medication is acting only for 5 days, right? Once it built up, slowly it would wane off, the effect would wane off. If the patient maintains that lifestyle, he'll not regain to back to origin one, not to back to square one, but there would be obviously regain, and that has been answered even in trial.
Means how? What are the patients? They remain non-respondent in spite of all the care being taken.
Yes, so 60% of the weight is genetically driven. The body pushes back to its origin, so they will require drugs. It's not कि वो बहुत ही undisciplined हैं. Many of our patients are eating very less. They are exercising. Still, they are not losing weight. Earlier, we did not have any therapy, so we did not talk about it. Now we have therapy. It's like आज की तारीख में कोई भी रेलवे स्टेशन पे जाके टिकट नहीं कर रहा है ना. So we are moving in that way in technology, in science, in medical science also.
Are the Indian patients different in this dealing with this drug?
We don't have any subgroup analysis data at present, but probably we'll have it, and it's later launched here in India. We'll have some real world evidence as well. So that question can be like off label, and we can discuss it after because we are already running late.
Okay. Thank you.
Thank you.
Thank you, Dr. Mayur Agarwal and Dr. Kedia sir, for your excellent masterly talk. Now, in the interest of time, we close this session.
Thank you, sir.
Thank you, sir, for the knowledgeable and innovative session. I request all of you to please move for the side bias for the felicitation. Now, sir, Dr. Shriram Agrawal sir, Dr. Sunil Diwani sir. Okay.
So Dr. Nitish Arora is a cardiologist from Bhopal. You may please begin the session.
Thank you, sir. So I have already been given a time limit, so I hope I do justice to this topic. So the topic is CT coronary angiogram versus invasive coronary angiogram. That is the first question actually, and the second one is, are we overstenting? So this is a mix of two presentations. So why this question in the first place? So there is a confusion between amongst us regarding the technology of CT coronary angiogram, what is possible through it, and what is the current utility and recommendations. The second confusion is, will CT coronary angiogram replace conventional coronary angiography, and which one is better? And the third is, which patients to be selected for percutaneous coronary interventions and stenting. So let's first understand the disease. So coronary artery disease is nothing but an atheromatous plaque which causes narrowing of coronary artery and produces ischemia. The treatment can be anti-anginals and percutaneous coronary interventions which restore the blood flow and improve the symptoms. So these coronary artery diseases can have two presentations. One is acute coronary syndromes where there is a definite benefit of percutaneous coronary intervention. Second is chronic coronary syndrome where all the debate lies regarding the stenting and not stenting. So what exactly is overstenting? So overstenting is a concept which refers to performance of percutaneous coronary interventions which are deemed medically unnecessary. And according to an analysis between 2019 and 2021 in a US-based hospital registry, 22% of the procedures were medically unnecessary, and which increases the risk of restenosis, acute stent thrombosis in the patients, also increases the cost. So PCI is a dual-edged sword, a blessing for those who need it and a curse for those who don't. So coming to the first question of our presentation, what exactly is CT coronary angiogram? So it is an X-ray technology which utilizes iodinated contrast to generate highly detailed 3D images of heart and its vascular network. Preparation includes fasting for 4 to 6 hours, abstaining from caffeine and use of beta blockers to control the heart rate. And after that, an IV line is established, ECG leads are placed, and usual time of scan is 5 to 10 seconds. It is a less invasive approach, and high-end CT scans usually can help plaque characterization as well. However, these CT coronary angiograms are only possible with high-end machines which are 64 slice or above. But in our current scenario in India, a lot of machines are only 16 to 32 slice. The limitation is high operator dependency and high coronary calcium score. So the negative predictive value for this is 93 to 100%. However, the positive predictive value is only 50 to 88%. So if it is positive, further investigations are usually required. Invasive coronary angiography is gold standard. It is a luminogram. However, limitations are that it is more invasive, does not require, and cannot do plaque characterization, which requires additionally OCT and IVUS, as well as does not reveal us the physiology, which requires functional testing by FFR and IFR. So, is there really a debate? Is it really a battle of opinions, battle of modalities or specialities? The answer is no. So, our vision and mission regarding to the patient is supreme. Vision being the well-being of the patient and mission being that treatment of aforementioned condition, that is coronary artery disease, safely and effectively. So, both modalities need to be utilized in an integrated manner for synergistic diagnostic pathway rather than choosing one over the other. So CT coronary angiogram basically is a gatekeeper which for low risk patients with high negative predictive value, which rules out coronary artery disease and prevents unnecessary interventional procedures. Whereas invasive coronary angiogram is definitive, can be performed for immediate therapeutic interventions and in patients with high-risk individuals or in acute presentations. So a tailor-made approach can be there. However, both the modalities give only anatomy, but is it enough? The answer is no, because physiological parameters and plaque characterization really matter. Coming to the second question of the presentation about are we overstenting? So in patients with acute ST elevation MI, there is a proven benefit of percutaneous coronary intervention and it is deemed life-saving. Similarly, in patients with non-ST elevation MI who are unstable, immediate invasive interventional strategies are recommended. However, the patients with non-ST elevation MI, non-ST elevation ACS I would like to correct, who are not unstable, we need to characterize them, classify them according to troponins. There are two other methods after troponins, that is TIMI score, Gray score, and patients who have a high TIMI and Gray score, invasive strategy is the rule. However, the patients who have low risk, the non-invasive testing like CCTA, CT coronary angiogram is to be done to rule out the patients. There is no role of viability in patients with acute MI. Most of the patients which come to us basically present to us after the window period, the so-called window period. So there is a definite benefit in percutaneous coronary interventions, even if we receive the patients after the window period. However, when we come to the other part of the scenario, other spectrum, that is the chronic coronary syndromes, these are the presentations of coronary artery disease that are stable over time. These includes patients with stable angina, ischemia without any symptoms, or patients with acute coronary syndromes who have suffered ACS previously but now are stable. So when 5,179 such patients of chronic coronary syndromes were subjected to either optimal medical therapy or stenting, we saw that there was no reduction in cardiovascular death or MI, and when they were followed up to the period of 5 years. This was the ischemia trial. So it suggested that if you choose a percutaneous coronary intervention as the choice of therapy or optimal medical therapy, there was no definite difference between the two. However, only symptomatic benefit was seen. Similar results were seen in Courage trial. However, in FAME-2 trial, where FFR guided PCI was done, revascularization reduced spontaneous MI in selected patients. A lot of chronic coronary syndrome patients have low ejection fraction, and a lot of times we advise myocardial viability. However, with the current evidence, the revised BCIS-2 trial, patients with LVF less than 35%, independent of their myocardium being viable or non-viable, did not show improve in heart failure hospitalization, or improve in ejection fraction even after they went percutaneous coronary intervention. So basically, coronary intervention has only improved symptoms in patients with chronic coronary syndromes and not given any prognostic benefits like reducing deaths or MI. So if with this knowledge we develop an algorithm in all patients with acute MI, unstable patients with NST elevation MI or high risk NST elevation MI, percutaneous coronary intervention is the rule. However, with low risk NST ACS, they can be risk stratified. If TIMI score and Gray score are high, then they can be subjected to routine invasive approach. If it is low, then CT coronary angiogram is considered. In patients who are suffering from chronic coronary syndrome, optimal medical therapy is the rule, and only PCI is considered in patients who have refractory angina or their symptoms are not getting improved even after the maximum therapy. In these patients, percutaneous coronary intervention does not have a prognostic benefit. It is more indicated in patients with high-risk scenarios, that is, patients who have LVF more than 35% and a significant disease. There is no role of viability as of yet, and patients who have complex coronary artery disease and LV ejection fraction less than 35% with a multivessel disease heart team approach that is required, which involves a cardiologist and a cardiac surgeon to determine which type of revascularization is recommended. So that is the conclusion of this presentation. However, is it the end? I would like to highlight a latest trial, the PREVENT trial. So in this trial, it was a multicentric prospective trial in which patients with vulnerable plaque and no flow limitations were preemptively stented, and the results at the end of 2 years showed reduction in death, target vessel revascularization, hospitalization for unstable and progressive angina. So we are really at the tip of iceberg, and this situation is very dynamic. We are just getting to understand everything in much more detail after plaque characterization and with OCT, IVUS, as well as the high-end CT scans, and after physiologic testing. So that is all for this presentation. Thank you.
Thank you, sir, for a wonderful performance. I would like to request, sir and chairpersons, please move forward for felicitation.
Thank you, sir, for the presentation.
Thank you, sir. Speaker, I call upon Dr. Rajesh Agrawal, sir, to please come up on the dais. For chairpersons, I call Dr. Rajkumar Jain, sir, to please come up on the stage. Dr. Brijesh Pandey, sir, to please come up on the stage. नहीं है क्या ब्रिजेश पांडे सर? एक सेकंड सर बस. You can start.
So Jai Hind everyone. I am speaking without my chairpersons. So today I am talking about the practical tips, very simple tips and very simple problems we come across while initiating insulin. So with this is the roadmap for my talk in next 10 minutes, and it is case-based learning, very simple, and we will discuss in between the guidelines. We all know that almost 60% of the patient or more than that could not achieve the optimum A1C level of 7 or less. And this is the global scenario, and even after 20 years of diabetes, more than 50% of the patients remain on oral anti-diabetic drugs without insulin. So this is the scenario we understand. And most common reason for starting the insulin are OAD failure, are glucotoxicity, inadequate control, and then surgical interventions. It is not by willingness or to achieve the targets. So this is real world story of 45-year male, 10 years diabetes, optimum doses of sulfonylurea, sitagliptin, dapagliflozin, metformin, and A1C is 9.8. He needs initiation, but patient is not ready. Why? Because we never talk about insulin right from day one. We must talk to the patient, prime the patient for insulinization in future. So if we talk about, then he will be primed. This is again another study which says that usually insulin initiation takes place after A1C of 9 or more than 10. This is another story of 45-year male, 10 years diabetes, optimum doses of all oral drugs, but he is also on basal insulin and fasting blood glucose is well controlled, 98 milligram only. He needs change of insulinization. He needs prendial addition or switch over to premix or co-formulations like Rhizodac. Third story is 52-year male, 10 years diabetes, hypertension, dyslipidemia. Again, all the parameters are not, glycemic parameters are not controlled. Optimum doses of almost 5 oral anti-diabetic drugs. After counseling, he was ready to accept insulinization and started premix twice daily. And on the next day of starting, he got hypoglycemia. And patient is scared of and never accepting the insulin. He was so afraid of hypoglycemia. And this is real story because of the residual effects of the sulfonylurea. So you have to go slow and tell the patient that you will require higher doses in future. So avoid hypoglycemia at initiation, that is very important. Fourth story is, again, 54-year male, 16 years diabetes, all oral anti-diabetic drugs and not ready for insulin. Patient went to another pathy alternative and pathies he enjoyed for 1 year, came back with the came back to the same doctor for insulin, and the lesson is patient accepts insulin only when he wants to accept insulin. So you have to prime. Don't leave the patient. Always prime the patient. At least you are more educated, more scientific, so you will take care of better than alternative medicine treating doctors. Another story of 54 years, same patient, but he is getting in between hypoglycemia, midnight hypoglycemia, and he is on premix daily. So in this case, change of insulin regime from 30-70 premix to 50-50 is required, because fasting is well controlled in between hypoglycemia, and mealtime hyperglycemia is there. Another story, very interesting story. These are all real world stories. 70-year female, well controlled on insulin. She was prescribed insulin and her daughter was injecting. But one day she went into hypoglycemia. The reason was her daughter-in-law, who doesn't know what dose he was taking, and she injected the full dose of prescribed insulin. Really, the patient was taking 6 units twice daily, and she was prescribed 20 units and 12 units. So always ask the patient how much insulin you are taking, because they always take less dose than you prescribe. And because of the cost, again insulin is reduced in lesser doses. Another interesting case is patient was well controlled, he was on insulin, but one day he went into hypoglycemia because his pen was broken. So he injected from the cartridge, from the syringe, that is 40 IU. So he has injected 2.5 times the doses of whatever was prescribed with the pen. Another very interesting story, he is a patient with erratic glycemic behavior. You can see blood glucose is going up and down, large glycemic variability. The reason was patient was injecting in the lipoatrophic and lipodystrophic areas, and from where insulin absorption is very erratic, and so glycemic variability is there. We all know that glycemic diabetes progresses. It is progressive disease and requires insulin in future, and insulin is the only molecule which can produce maximum A1C reduction. Early insulin benefits, we all know that it delays the beta cell apoptosis, might cause remission, reversal of glucose and lipotoxicity. Then what guidelines says? Most of the guidelines says if A1C is more than 1.5% of the target you have set, are not controlled with 3 or more OADs, then you should start with whether basal or premix insulin or basal bolus according to your shared decision with the patient. Then what are the barriers? Complicated regimes, fear of needle phobia, hypoglycemia, weight gain, these are the real, and poor communication, that is not priming the patient, not understanding the disease. This is a study of 148 patients in which 74% patients refused to initiate insulin because of the financial reason, needle phobia, dependency to inject, that is also very important reason, psychological resistance and perception of failure. Then insulin action profile, this you should know that this is the normal action profile, green is normal action profile, and red and blue are late diabetic action profiles, insulin release in the body, this is endogenous release, and then you should know the action profile of various insulin. And if you have self-monitoring blood glucose parameters of the patient or CGM parameters, and if these both the graphs matches, then there will not be any hypoglycemia and you will choose the right insulin. These are the various action profiles of basal insulin. I will go quickly through premix insulins. These are various insulin regimes. We have insulin available, rapid acting, fast acting and short acting, then premix, various combinations and co-formulations. Even then, this Impact India survey says that most commonly prescribed insulin is premix, twice daily insulin in our country. Various barriers we have already discussed, patient related, doctor related and resource related. weight gain, hypoglycemia, and needle phobia are the most common constraints. Otherwise, cost and non-understanding of the disease, these are various other factors. This is another study. Again, this study shows that there is a strong faith in alternative medicine and mythical ideologies, and then fear of addiction of insulin. Non-acceptance is also due to difference of opinion on insulin initiation. Like in type 1 diabetes and in pregnancy, there is no difference of opinion. You have to take insulin. But in type 2, there is difference. No, you may not. Yes, you may. So these difference of opinion makes the patient confused, and patient does not accept his insulin. This lack of time, lack of educators, these constraints can be removed with the help of educators, which we have in scarcity. Then diabetes education, very important part. Elliot P. Jocelyn said education was not just a part of treatment, but it is and it will remain the treatment. And you know that 1% reduction reduces A1C by 12 to 43%. And 24 hours of diabetes education reduces A1C by 1%. So you can understand the impact of 24 hours of diabetes education. Dose calculation, very easy. There are so many formula and complicated regimes. But 0.1 to 2 unit per kilogram of body weight is required, 50% in the basal form and 50% in the prandial insulin. And this can be vary according to the patient profile. And as the duration of diabetes increases, the dose requirement will increase. Take home message, prime the patient, let the patient experience the insulin. Once patient is initiated, then intensification is very easy. Reward the patient who are accepting and achieving the targets. Accessibility to prescribed insulin is also very important. Go slow, avoid hypoglycemia. De-intensification is also very important. SMBG and diabetic education are key to success. The only thing is CGM is equally important, but it is temporary measure. And SGLT2 and DPP4 inhibitors can reduce weight gain by insulin. AI and various apps can help us in educating and the dose adjustment of the diabetic patients. Thank you very much.
Thank you so much, sir, for an enlightful session. I would request sir and chairperson to please move forward for felicitation. Now, I call upon Dr. Harsh Atul Hirani as a speaker. He is actually an AI expert in healthcare sector.
Things where AI is helping enhance the diabetes care. So with this backdrop, let me share some interesting facts. So by the time we have the technical team help us out. Yeah. So AI as a market in healthcare is expanding up to $1.6 billion as we speak now. And despite this much adoption and evolution of AI technology over the last 1 to 2 years, what we are seeing, 70 to 80% of doctors, diabetologists across the globe are now adopting these technology and AI tools. But keeping all these numbers in mind, in India, only 20 to 22% of hospitals or centers in urban settings have actually adopted AI to the level it can be. So this is the opportunity to grasp and to grow with technology in our practice. So with this backdrop, if we start looking at AI utility in diabetes care, primary level at the initial stage, if we see, there are 3 sections in which the whole topic can be divided. Starting with first aspect, which is on prediction part. So now AI has entered into diabetes space in the risk prediction aspect, because now we have certain tools which are getting developed and which already exist, which can predict a complication even before the symptoms manifest. So that's one development, and 85% above accuracy has been achieved by these tools. Looking at the cost reduction, last year, 1 year alone, 30% of IP care cost reduction has been observed by integration of AI in diabetes care. So that's again a huge number. Looking at other aspect which is focus specific in terms of, if we look at the patient outcomes, 20% of improvement in glycemic control has been seen by integration of AI when we look at data processing, whether we look at SMBG data, whether we look at CGM data, which is getting processed with AI, that's the impact. So very recently in Swiss Economic Forum on June 2nd itself, June 2nd, 2025, IBM and Roche, one of the oldest glucometer manufacturers, they collaborated with an algorithm where they were able to actually have IBM and Roche collaborated sensor data processing, where the glucometer readings were first studied by the AI system, and then it could give prediction outcomes for that person in terms of hypoglycemic events or abruptly rise in sugars. So that's the prediction aspect which we have been seeing in live. Looking at the next latest development, what we have seen, that is one with University of Virginia, just on March 13th, 2025, they built one of the world's first fully automated AI-enabled insulin pump, and the trial is on with type 1 diabetics as we speak right now. So they created something called bolus priming system, and this system, this bolus priming system, was designed to automate the bolus also. So we have heard of automated basal in newer pumps, newer insulin pumps have automated basal systems. This was the first attempt where automated bolus dosing also was attempted using AI. And this was based on reinforcement learning of the AI system. So retinopathy screening, we have seen it all around, like India has been one of the best adopters of AI in retina screening. And even now in our expo also, we have a company which is called Forus. They have been working around on AI-based solutions where the retina scan, which is done in non-metastatic state, actually gets enhanced by AI, and then you get a predictive differential diagnosis. All the ophthalmologists need to do is review it, approve it once, and give us a confirmation. So that remote thing has also been quite the norm. But recently in May 2025, FDA approved multiple set of devices and algorithms which help in doing this. Now, the latest development has been something very interesting, which just came in on 30th May, just a few weeks back. A very interesting publishing happened in AJMC, where AI was able to match a physician's accuracy in insulin dosing in type 2 diabetes patients. So the entire estimation of prediction was compared hand to hand. One was with a physical physician and one was with the AI. And close to 10,000 patients were tested on this, and the results were verified. And they were surprising. 76%, I repeat, 76% of patients achieved time in range of above 75 with AI-based dose calculation, and with human dose calculation was not even 69%. So that's the impact what AI is now making as we speak right now. It's a very interesting paper. You can see it on AJMC. So primarily, if we divide in AI using diabetes care, it falls under 3 major brackets. So starting with first is in predicting diabetes onset complications. The second is aspect which is on enhancing diagnostic accuracy. And the third one, which falls one of the most important ones, is falling on personalizing diabetes management. Just 1 second. There's a technical glitch here. Okay, so unfortunately there's a technological glitch in a technology session, which is perfectly fine. So we'll manage without it. Acha, so we were at the AI use in diabetes care right now. I think it's showing there in display. It's coming. It's not coming here. Are you sure this is the same HDMI? Huh? What I'm saying is this the same HDMI?
Yes.
Okay. Anyways, we'll continue the session. So looking at how AI works in diabetes care is, there are multiple sensors we have come across, right? Whether it's the SMBG reading or CGM reading or anything. So primarily what happens is, AI gets first trained on data sets. So once it's trained on data sets, it creates its own mathematical algorithms at backend. And then we actually see the prediction part, where it is giving recommendations on hypoglycemia events, and so on and so forth. So looking at scenarios, let's look at one of the most interesting scenarios of AI where it could be used. So first and foremost aspect is insulin initiation. So when we initiate someone on insulin, I think Dr. Rajesh's session previously was very nice concluded, where we need to reward people who we initiate insulin on. So to reward this, there is a certain process which AI can help you build, which is on patient interaction at the time of starting insulin. So AI can be used to create automated insulin initiation forms in any language of your choice. Across the country we can use it. So there is certain prompt which I've created with the permission of conference team, Dr. Abhishek. I'll share these prompts across separately as a PDF file, so all of you can start practicing it on ChatGPT and other AI tools. So basically this prompt will help you create an insulin initiation form in your language of choice. Along with that, you'll also get a reward option in terms of, how do we reward a patient who has been on insulin. So both these things will be sending it across to you. The second case scenario where we could possibly use AI is managing hypoglycemic episodes. So creating hypoglycemia education content, and specifically where we can have AI work as a virtual assistant to facilitate you create content or different types of communication guidelines for your teams to educate them on hypoglycemia in the language of your choice. The third scenario is scientific conventions like this one. Like if you're seeing two graphs, there are AI tools such as Claude, where you just need to take a picture of the entire graph, and it gives you a complete biostatistical outcome based on that graph, giving you a comparative analysis. You don't even have to Google search any slide or information on any slide. This kind of AI tools are helping there. So again, apart from this, there are multiple places where AI now has been used. So starting with one of the first scenarios on clinical workflow. So today if a patient comes to your clinic, right from the time of patient intake to the documentation management to the treatment optimization, and the most interesting one which is on improving the complication outcomes of diabetes. So all these four strata, AI is now available, accessible. So looking at one of the first scenarios where AI is getting used specifically in the diagnostics is pathology. So there's a tool which is developed called Indra, AINDRA. It is available in India. This specific tool actually helps to do histopathologic analysis in an automated manner. We have a tool which is called Doctor Assist AI. This tool again makes sure that it helps you in CGM data understanding. We have one more tool which is called CGM Maestro, which also helps in figuring out CGM graphs automatically. It gives differential diagnosis. And the last one is drug interaction tools, which is again a tool which is designed to figure out drug interaction from any image or any medicine prescription you take. So these are some of the clinical tools which are readily accessible, usable right now. So with this, a quick run through on what AI is, how it's doing, I'll end my session here, and thank you again to the organizers for this opportunity to engage and discuss with you. Thank you.
ESC versus ADA guideline, and what's new in cardiovascular risk management in diabetes in 2025 update. So we are looking forward for recent update. Go ahead, Dr. Pushparaj.
So, till the slides come, I'll be discussing about the current guidelines of ADA and ESC with the special emphasis on cardiovascular risk. Pertaining to the risk stratification, between the age of 20 to 39, we should consider they advocate to consider statin therapy if there are additional risk factors for atherosclerotic coronary vascular disease. In mid-age people between 40 to 75, use of moderate intensity statin is indicated in patients who do not have any atherosclerotic risk factor, and in high intensity statin is indicated in patients who are having higher risk. So recently both AD and ESC, they have updated their guidelines incorporating evidence-based recommendation for screening, diagnosis and treatment, and they have given a special emphasis on SGLT2 inhibitor and GLP-1 receptor agonist for both glycemic and cardiovascular benefit, and they have advocated for personalized risk. The key recommendation from ADA in patients, in adults with diabetes, to assess cardiovascular disease, and if the patient is having associated heart failure, they should be started on SGLT2 inhibitors or GLP-1 receptor agonist with proven CV benefit. In patients with cardiovascular disease, routine screening is not indicated, and they should be subjected for natriuretic peptide measurement. If this natriuretic peptide is high, they should undergo echocardiography also. In patient with CKD, they should undergo UACR and EGFR monitoring 4 times every year, with depending on the stage of CKD, and use of Finneron is indicated to reduce the risk of progression of CKD. With SGLT2 inhibitor, the guideline reinforce the use of SGLT2 inhibitor for renal and cardiovascular risk protection, regardless of the glycemic control. And non-steroidal mineralocorticoid receptor antagonist, the guidelines recommend to use Finneron for patients with persistent albuminuria despite the use of optimal medical therapy. For targeted screening for heart failure, they recommend screening for heart failure in individuals with diabetes with symptoms like fatigue or dyspnea, and they also recommend using continuous glucose monitoring for individuals with diabetes who are not on any insulin therapy also. There is a special emphasis on glycemic control. The highlights being the importance of glycemic control with HbA1c below 7% to prevent microvascular complications, and physical activity of 150 minutes, at least 150 minutes moderate to vigorous aerobic activity per week is indicated, with individualized goals of HbA1c and glucose measurement, with the HbA1c goal between 6.5 to 7. For lifestyle modification, ADA advocate intensive lifestyle changes and for overall overweight and obese individual for at least 3 to 7% weight reduction, and routine screening of atherosclerosis. They recommend a screening for heart failure in diabetic patients who present with symptoms but who do not, they do not recommend routine screening for atherosclerotic disease in asymptomatic individuals. In critically ill patients, the recommended blood glucose level is between 140 to 180 milligram per deciliter in most critically ill individuals, but they also suggest more stringent individualized goal are appropriate without significant hypoglycemia. So the reduction in diabetic complications, we should look for glycemic management, blood pressure management, lipid management, and you should use the agents with cardiovascular and kidney benefit, along with the lifestyle modification and diabetic education. So the key recommendations from ADA are to consider antibody-based screening for pre-symptomatic type 1 diabetics In pharmacological therapy, GLP-1 receptor agonist and dual GLP-1 GIP receptor agonist are recommended for multifaceted benefit in diabetes management. In dietary guidance, the importance of adequate water is highlighted, and recommended high quality sustainable eating patterns are indicated, and regular sugar with non-nutritive sweeteners are indicated. And in digital, they strongly recommend continuous glucose monitoring for patients who are not on insulin also. In ESC, they advocate for using score to diabetes risk stratification. Depending on the score to score, they further update like use of SGLT2 or GLP-1 receptor agonist use is indicated independent of the HbA1c level. GLP-1 receptor agonist for atherosclerosis is recommended for patients with diabetes and atherosclerotic risk higher atherosclerosis risk. And SGLT2 inhibitors, they are recommended for patients with heart failure or concomitant renal dysfunction also. They will likely emphasize the importance of annual assessment of GFR and urine albumin creatinine ratio in all patients with diabetes, along with the lifestyle modification and sodium restriction. The specific LDL targets are 2.5 millimole per liter, 1.8 millimole per meter, less than 1.4 millimole for patients medium high or very high risk of cardiovascular disease. PCSK9 inhibitors are indicated in patients who are at very high risk of cardiovascular events, and antiplatelet therapy are indicated in patients with diabetes, including a specific recommendation for aspirin, and P2Y12 receptor blockers are indicated. In diabetics with a specific cardiovascular risk factor, the guidelines likely continue to emphasize the importance of managing the established risk factors in patients like hypertension, dyslipidemia, and smoking cessation. HSCRP should be considered as a class 2 indication as a risk stratification score, and elevated HSCRP level in patients, it may indicate the residual inflammatory, vascular inflammatory risk level also. So GLP-1 receptor agonists with proven CV benefit, they are recommended in patients with diabetes and coronary artery disease to reduce CV event independent of baseline or target HbA1c and independent of the concomitant glucose lowering medications. The GLP-1 receptor analog like semaglutide, it should be considered in overweight patients, that is BMI more than 27, or in obese patients with cardiovascular disease without diabetes also, to reduce the CV mortality, MI and stroke. For the initial diagnostic management of with suspected CCS, high HSCRP level should be assessed. For medical management of patient with peripheral arterial disease, diabetes, and GLP-1 receptor agonist with proven CV benefit are recommended to reduce the risk of CV events. So both the guidelines, they emphasize the importance of early detection and intervention for cardiovascular disease in patients with diabetes. Both highlight the use of SGLT2 inhibitor and GLP-1 receptor analog for cardiovascular protection. And ESC, they advocate using the score to diabetes risk stratification. The ADA focuses on continuous blood glucose monitoring and medication shortage also. Overall, the ADA and ESC guidelines, they provide a comprehensive framework for managing cardiovascular risk in individuals with diabetes, emphasizing a personalized, multifaceted approach that considers both glycemic control and cardiovascular outcome.
Thank you, Dr. Pushparaj, and very timely finished program. So over to audience for any question.
For cardiac risk reduction, PCSK9 inhibitor are definitely indicated in patients who are not on lipid control despite of maximally tolerated statin dose. And if you are asking about my personal experience, so I have few patients on PCSK9 inhibitor, but long-term results I have to see. Patients, they are already on statin and they, other optimal medical therapy, they have been started on this PCSK9 inhibitor if their LDL is high. So, but I'm not using this drug since very long, so I cannot comment about the long-term effect of my personal experience. Yes, patients are being benefited.
Dr. Pushparaj, I want to ask one question. Since so many things and talk of or invasive and this test, that test, in high-risk cardiovascular patient, especially uncontrolled diabetic, where does this 6-minute walk test stand?
6-minute walk test is for like cardiorespiratory fitness of the patient, for like any pre-surgical workup, or in the patients where we cannot do treadmill test or this VO2 measurement cannot be done. In that category, 6-minute walk test can be done routinely. So if with interventions the 6-minute walk distance improves, the symptoms they decrease, then obviously the patient is getting benefited with the treatment. So it is like clinical marker of disease progression or improvement.
So how this 6-minute walk test, at what speed and what should be the pace, and do you recommend this test under the guidance of some specialist or doctor?
No, I also do this test, but like in presence of paramedical staff we do this, or usually in presence of like cardiac rehabilitation specialists they do this, and we ask to walk the patient with a pace maximally tolerated. At the pace he do not develop symptoms of like breathlessness or angina, in a measured length haul, and we calculate what is the total length covered in this 6 minutes. So if the distance is more than 350 meters, then it is adequate.
Okay, thank you. Thank you. Thank you, Dr. Pushparaj.
Thank you, sir.
Over to you.
Thank you, respected sir, for insightful.
Thank you. At the onset, I'd like to thank Dr. Abhishek Srivastava and Dr. Swami sir for giving me this opportunity. The task given to me is to speak on the MASLD and MASH, the gastroenterologist perspective. Now recently there has been a change in the classification and the nomenclature. Initially we used to call it NAFLD and NASH. Now they have been changed to MASLD and MASH. This is because many patients, they don't fall into one category. Many of the patients, they have metabolic risk factors along with some other etiology for fatty liver disease. Like some patients are having metabolic risk factors like diabetes. Along with that, they are taking alcohol. So at that time, it was very difficult to put patient in one category. Either we have to label them as NAFLD or as ALD. But now with this change in nomenclature, this has become much easier. Now, SLD is steatotic liver disease. Now, the new class, according to the new classification, if the patient is having metabolic risk factors, then they are labeled as MASLD. But if the patient is also consuming alcohol along with that he's having metabolic risk factors, then they are labeled as MET-ALD. And now, if the alcohol is predominant component, then we call it ALD predominant, and if the metabolic components are predominant, then we call them MESLD predominant. And those patients who do not have risk factor for metabolic dysfunction, they are along with alcoholism, they are labeled as alcoholic liver disease, and similarly there are other etiologies for steatotic liver disease which are also labeled. Now the classification of steatotic liver disease, now if the patient is having cardiometabolic risk factors like BMI more than 25 or fasting blood sugar more than 100 or blood pressure more than 130 by 85, triglyceride level more than 150 or HDL less than 40 in males and less than 15 females. These are metabolic risk factors. If the patient is having metabolic risk factors, then they can be labeled as MASLD or MET-ALD. And if the patient is not having metabolic risk factors, then they can be labeled as cryptogenic steatotic liver disease or depending on the etiology. If no etiology is found, then we label them as cryptogenic, and if other etiologies are found, then we label them as ALD, DILI, or some other, whatever reason is there. Now this MASH and MASH is really a prevalent disease. In fact, the estimate says that in the near future it will become the most common cause for liver cirrhosis. In a study from US, the approximate prevalence, the prevalence in general population was 25% for MASH. MASH is fatty liver with trivial or no inflammation and no hepatocyte ballooning. And those patients who have MASH, those who are having inflammation, that is fatty liver with significant inflammation and hepatocyte ballooning, the prevalence is around 3 to 5%. And these patients are at risk of developing cirrhosis. And the patient who develops cirrhosis are 1 to 2% of all at-risk patients. Now, these patients who have MASH are usually asymptomatic, and they are majority are discovered by chance. Fatigue is frequently present along with right upper quadrant discomfort. Most of the patients, they come when they get an ultrasound for unknown, for some other indication, when they are found to have fatty liver. Now, there are various steps for suspecting MASH. First is risk identification. Those patients who have metabolic risk factors, diabetes mellitus, obstructive sleep apnea, or primary polycystic ovarian disease, or those who have first degree relatives with non-alcoholic fatty liver disease or HCC, they are the at-risk patients. We should always take a history of alcohol intake, which should be less than 14 drinks in females and 21 drinks per week in males. And along with that, we should also do some investigations like liver function test. We should exclude viral etiologies. We should exclude autoimmune diseases. We should rule out celiac disease. We should rule out Wilson's disease. And liver ultrasound should reveal fatty liver. Now, those patients who have advanced fibrosis, they are at higher risk of death and adverse liver-related outcome. There was a prevalent study in which patients were stratified according to liver fibrosis, and it was found that those patients who have higher grades of fibrosis, they had higher chances of death and development of liver-related outcomes in comparison to those patients who had no fibrosis. They were stratified at the baseline, and in the study it was concluded only fibrosis stage was associated with overall mortality, liver transplantation, liver-related events. Presence of MASH or NAS, means NAFLD activity score, had no independent prognostic effect. Now, this was another study by Sanyal group, in which they have stratified patients according to the fibrosis stage in F3, F4, F5. So those patients who had advanced fibrosis like F3, the chances of developing developing higher grades of fibrosis was much higher in patients who have higher grades of fibrosis at baseline. Those patients who had F3 fibrosis, at 29 months, approximately 22% of them progressed to F4 fibrosis. And similarly, those patients who had F4 fibrosis, that is bridging cirrhosis, the chances of developing clinical events were 19% at 30.9 months. The clinical events were death, ascites, hepatic encephalopathy, esophageal varices, new varices, more than 2-point increase in child book score. Now, there was another study in which, again, they have found that the higher the grades of fibrosis, higher the chances of developing severe liver disease, and higher the chances of liver-related mortality. Another study which revealed that those patients who had regression of fibrosis, they had improved clinical outcome. In this study of 1,135 patients, those patients who had improvement in their liver fibrosis score did better than those patients who were not showing improvement in their liver fibrosis. Now, if fibrosis is such an important thing, then it is very important to identify patients who are at risk of developing bad outcomes. Therefore, the need to identify individuals at risk for progression before bad outcome occur, we need to identify patients who have advanced degree of liver fibrosis. Now, how to assess these patients, whether they are having advanced fibrosis or not? So first is strong clinical predictors of MASH and fibrosis, like age more than 50 years, then type 2 DM, first degree relatives with mast cell cirrhosis, then other risk factors like sedentary lifestyle, overweight and obese, then metabolic syndrome with more than 3 features, dyslipidemia, polycystic ovarian disease, endocrinopathies, and obstructive sleep apnea. These are, if we find some of these features in patients, the chances of developing advanced fibrosis are more in these patients. Now, all the guidelines, including ASLD, EASL, and ADA, call out patients with type 2 diabetes as warranting workup. all the diabetic patients, they are at risk of developing advanced fibrosis and they should be worked up. Now, liver biopsy is the standard method. It is the gold standard, which is very important, which can identify patients at fibrosis. But it is a very imperfect gold standard because it has got multiple limitations, like it is invasive, painful, it's expensive, it is associated morbidity and mortality. Although mortality is not very high, but it is still, some cases of mortality have occurred. Then there are sampling variability can occur, means the same biopsy, if the biopsy taken from the same liver, two different samples can show different grades of fibrosis. Then there can be inter-observer variability, then expertise to perform is needed, and it is impractical for general population screening. So now, non-invasive tests, which are easier, can be used. Now there are various non-invasive tests. Few are simple, few are proprietary, and there are other imaging methods. Now the simple scores are mast cell fibrosis score, FIB-4 score, or average score. They have good negative predictive value for ruling out fibrosis, and the calculators are available freely online. You can use simple parameters and use the online calculator, and you can find out whether the patient is having advanced fibrosis or not. They fail to differentiate, identify patients in between. Either there are no fibrosis or there are advanced fibrosis. In between, they are not able to identify patients well. Now this is the mast cell fibrosis score and FIB-4 online calculators. And they are based on age, platelet count, AST, ALT, and other simple lab values, which are available in the simple test. Now this ELF score is a proprietary score, which is done from the blood, comprising of 3 parameters like hyaluronic acid, procollagen 3, and TIMP3. This is, and this has been prospectively validated score. This was it was validated in the prospective study of adults with MASH and bridging fibrosis, comprising of 219 patients, and compensated patients, cirrhosis, 258 patients, which were enrolled in phase 2 simtuzumab clinical trial. In this, the liver biopsies staged according to Ishaq scale at baseline, week 48 and week 96 were done, and ELF score was calculated at baseline at every 12 weeks. Now this ELF score in MASH predicts progression to cirrhosis more accurately than biopsy. Those patients who have baseline ELF score more than 9.76 had more likelihood of progressing to liver cirrhosis as in comparison to patients who were having ELF score less than 9.76. 9.76 was the cutoff. Similarly, ELF score also predicted the liver-related clinical outcomes more accurately than biopsies. Those patients who have ELF score more than 11.27 developed more liver-related events in comparison to patients those who are having ELF score less than 11.27. Now imaging. Now fibroscan, this measures 1D velocity of a low frequency shear wave. Fibroscan is now very easily available, and is a point of care test, can be done in just 2 minutes. It is directly related to the tissue stiffness. The velocity of the wave which passes through the liver is directly related to the tissue stiffness. The stiffer the liver, the faster the wave propagates. It is quick bedside test, but is limited by obesity. Very obese patients who have very thicker abdominal wall, there is a limitation. Then abdominal ascites and operator experience. Now it is most reliable in ruling out advanced hepatic fibrosis. Fibrosis unlikely with low values, that is less than 7 kilopascals. Higher values increase the likelihood of more severe fibrosis, predicts the risk of decompensation and complications. Overestimation of fibrosis can occur in patients who have hepatitis, cholestasis, liver congestion, obesity, and if the mass lesions are present in the liver. Higher values correlates with portal pressure, that is if somebody is having fibroscan values more than 20 kilopascals, the chance of higher portal pressure are there. Now another modality is 2D shear wave elastography, which is an ultrasound based system. It requires a radiologist. Liver elasticity is measured, and it can be used even in obese patients, and the cutoff is 8.7 for F3 fibrosis. Similarly, MR elastography can be done. It is a very sensitive test, although not available in Jabalpur. And these various, now because all the non-invasive tests, they have certain limitations, so sequential testing can be done. 2 non-invasive tests can be combined, so it increases the accuracy. Now coming to the treatment, now the basic goal of the treatment should be the resolution of NASH and reversal of the hepatic fibrosis. Now, various treatment regimes can be used, but most important is lifestyle modification, that is dietary change and exercise. Exercise of more than 150 to 250 minutes per week, and resistance training of 45 minutes per day for 3 days a week should be done. And we should take low calorie diet, low in fructose and sweetened beverages. Weight loss is definitive advantage. Those patients who lose more than 10% of the weight tend to do better. They even reverse the fibrosis and inflammation. Now, those patients who are not able to lose weight, bariatric surgery can be used, and various studies have been done in which those patients who have underwent bariatric surgery have better led to mass resolution. Even fibrosis reversal has occurred. Histological improvement occurs. There was a study comparing vitamin E, placebo, and pioglitazone in a study done by Sanyal et al., in which vitamin E was found to be better than placebo in NASH resolution. Although pioglitazone was not superior to placebo, but in secondary endpoints, even pioglitazone was better, but none of them were useful in fibrosis reversal. Semaglutide, it resolves the MASH and improves the fibrosis. It is not approved for treatment of MASH. It is not approved for the treatment of MASH, although phase 2 trials have shown the improvement in the inflammation, but no improvement in the fibrosis. Still, phase 3 trials, the results are awaited. Similarly, tirzepatide, it is also being used for the treatment of NASH. Now, to summarize, ladies and gentlemen, MSLD is highly prevalent with variable rates of progression to MASH and advanced fibrosis. It is crucial to identify those with MASH, advanced hepatic fibrosis, because it can quickly progress to cirrhosis and HCC, liver transplant, and mortality. Patient with type 2 diabetes, warrant evaluation. Other risk factors include obesity, metabolic syndrome, first degree relatives with MASH cirrhosis. Non-invasive biomarkers can facilitate risk stratification. Lifestyle modification, weight loss remains the mainstay of the treatment. Thank you.
Thank you, sir, for the wonderful session. I request sir and chairperson, please move forward to side bys for felicitation. I request you all, sir. Now next, I invite Dr. Pankaj Ashati, sir, to please come up on the stage. Our chairpersons, Dr. Arun Iyer, sir, Dr. Deepak Behrani, sir, Dr. Brij Bihari Patel, sir, please come up on the stage.
Thank you, Dr. Behrani sir, for kind introduction. I want to say congratulate Dr. Parimal Swami sir, Dr. Abhishek Srivastava organizing for such wonderful conference. So, assignment for me this conference by Dr. Abhishek is diabetic gastroparesis. So it is basically it is a topic for gastroenterologist as well as diabetologist. So in this, because it's a very underdiagnosed clinical problem in the for physician as well as gastroenterologist and diabetologist. So I want to one case scenario. 30 years woman with 1 year history of type 2 diabetes mellitus with nausea and early satiety. Her blood sugar have been erratic and for last HbA1c was 9.2, endoscopy was normal, and gastric emptying test on scintigraphy was 20%. Retention of meal at 4 hours around at 20% and normal less than 10%. So which one of the following would you recommend it? Whether you want to give metoclopramide, rigorous control of blood sugar, you want to give injectable or injectable erythromycin or botulinum or pylorus. And these are different modality. So we will discuss next 12 minutes for this to answer this question. So gastroparesis is a condition, delayed gas emptying, absence of mechanical obstruction lasting for at least 3 months. Symptoms such as nausea, vomiting, bloating, early satiety, abdominal pain, post-pain abdominal fullness. So they are different mechanisms which lead to clinical present and pathophysiological for this diabetic gastroparesis. So gastroparesis is most frequently idiopathic, but other cause can be encountered in the clinical practice. So this could be because of diabetes, post-surgical, post-infectious, and various causes. So surgically, usually vagotomy in case of malignancy, fundoplication, esophageectomy, gastric infection, usually viral infection like Epstein-Barr, varicella, parvovirus, Clostridium botulinum infection, neurological disease like CNS, CBA, tumor, and seizure disorder, and other Parkinson, Guillain-Barré, GBS, multiple sclerosis. So these are various clinical, these are disease when patient lead to the gastroparesis. Neuropsychiatric disorder, rheumatic disorder, endocrine disorder, metabolic like diabetes, hypothyroidism, erectile disturbances, renal failure, pregnancies, and other causes like amyloidosis, chronic intestinal pseudo-obstruction, and myotonia dystrophy. So these are common causes of the gastroparesis. So what is the gastroparesis? Gastroparesis, diabetes is a type 1 diabetes and type 2 diabetes both lead to the gastroparesis. But type 1 diabetes usually more encounter with gastroparesis. But incidence and prevalence are more common of type 2 diabetes. So we are using having the both type 2 diabetes related gastroparesis. So why this is challenge? Because diabetic gastroparesis lead to the unpredicted symptom like patient symptom diagnosis and glucose control. So lead to the complication like dehydration, malnutrition, and bezoar formation in the stomach. Patient there is a persistent or long-standing gastric paresis. So now diabetes is the most common non-underlying cause of gastroparesis. Diabetes can change vagus nerve and specific cell in the like interstitial cells of causal, known as causalopathies in the stomach. So these lead to delayed completing that because of this incoordination of contraction of the antrum and pylorus and duodenum and poor accommodation power of the accommodation reservoir of fundus of the stomach. So lead to loss of muscles movement through the digestion, lead to damage of the vagus nerve, and food stay in the stomach long standing lead to the bezoar formation. So these are the lead to gastroparesis. So prevalence of diabetes as epidemiological in type 1 diabetes, almost 4.8% of individual type 1 diabetes having the gastroparesis, in 1% of those who are having the type 2 diabetes, and 0.1% of these are in normal population. So it is almost 10 times higher in case of type 2 diabetes and almost 48 times in case of type 2 diabetes in compared to normal public. So upper gastrointestinal symptoms are reported in diabetes almost 11 to 18% in the form, most of which associated with the delayed gastric emptying. So because incretin mimetics are used to treat patients with type 2 diabetes, this medication may pose an additional risk for this developing gastroparesis. It has been observed gastroparesis typically occurs in patients with diagnosis of diabetes at least 10 years and therefore seen more commonly in the older individual with type 2 diabetes. And serum glucose level in direct relationship with gastric emptying. Now pathophysiological mechanism of diabetic gastroparesis because of extensive denervation by vagus nerve, loss of nitric oxide synthesis in the enteric nervous system lead to the delayed gastric emptying, decreased gastric accommodation, and uncoordination enteral contractility and patient lead to pylorospasm. Altered function of immune cells in type 2 diabetes lead to the macrophage, lead to the causal ICC, damage to the interstitial cells of causal, known as causalopathies, and loss of ICC and smooth muscle atrophy. So these are how the gastroparesis develop because of sympathetic, parasympathetic, because of acetylcholine and dopamine, serotonin, and loss of nitric oxide in the stomach. So symptoms of as a diabetic, there are very vague symptoms in diabetes gastroparesis, but nausea is now the most common symptom in gastroparesis. Nausea, vomiting, early satiety, bloating, postprandial fullness, abdominal pain. In case of diabetic, patient may have both weight loss as well as weight gain, and constipation and maybe diarrhea. So there are wide glycemic fluctuations. So the diabetic gastroparesis, so for diabetologists, is the biggest challenge because there are erratic absorption and erratic movement of intestine. So it could be a glucose may be hypo and hyperglycemia can occur in the diabetic gastroparesis patient. So now will come this relationship with the symptoms is unclear. So now we'll come to diagnose how we will diagnose this patient on the diabetic gastroparesis, undergo upper gastrointestinal endoscopy. So we should rule out the other structure causes for this gastroparesis by the endoscopy, by CT scan, and by the gastric emptying testing by the scintigraphy is the gold standard for this gastroparesis. So solid phase emptying is for gastroparesis. Liquid phase emptying we can use measure for the dumping syndrome and other. So we should measure for up to the 4 hours post-ventrally for the this. So you can see this can be the normal less than 10% retention over the 4 hours in case of normal gastric emptying. But if it is more than 10%, then we can delayed gastric emptying. So another case scenario is also here. We want a 20-year woman develop viral illness associated with the fever, myalgia, nausea, vomiting, same. Here in case, although the most of the symptoms resolve over the 2 weeks, she continued to have nausea, occasional return to vomiting, and early satiety and 10 kg weight loss. Endoscopy show modest amount of retained food in the stomach, and the gastric retention relatively 4 hours was 35%. So we want to answer this question in the next slide. So on the basis of this, in last slide, there was a patient can classify in the 3 category: mild, moderate, and severe, on the basis of symptom, on the basis of gastric emptying study, and so if there are less than daily symptoms, no hospitalization, and gastric emptying is less than 20%. So these patients classify mild. If daily symptoms and not occasional patient require the hospitalization and gastric emptying test on 20 to 35% and on 4 hours study. So this can be classified moderate. And if patient patient require daily and continuous symptom and multiple emergency department visit and hospitalization, and this on gastric emptying more than 35% attention at 4 hours. So these patients considered as severe category. So this mild, moderate, they have different treatment modality. In case of mild, so we should measure with the non-pharmacological management and just a lifestyle modification by the liquid to soft diet. Patient should be keep low fat, low soluble fiber, and glucose control, and restoration of fluid and electrolyte in such patient. In case of moderate GE, patient should be keep on diet, as well as we should give the procarnate drug like metoclopramide, domperidone. Now we are recently available drug like laplozole, this and in for this. And severe category we should be diet daily and continuous motion. So this patient should be FDA by the this for severe category. So management, first line drug is a first line small frequent meal. In case of mild category, avoid high fat and high fiber diet, spicy food, alcohol and smoking, and nutrient support. Definitely patient who are not in case of tolerate this oral food, we can give the jejunal and oral feeding and by the jejunal feeding. Glycemic control, patient who are having the delayed gastric emptying cause erratic glucose absorption, risk of both hypo and we have discussed this side. So because of this, I want to show in case of because of if patient of the bell glucose in type 1 diabetes, there is a hyperglycemia, emptying almost in 40 gastric retention is almost 40%. But once the patient of the treatment, glucose is well controlled in normoglycemic patient. So almost this emptying test is almost attain 90%. So once patient have the attain the normoglycemia or euglycemia, this gastric emptying is become normal. Procarnated drugs we can use in the metoclopramide, domperidone, and erythromycin. Metoclopramide is only FDA drugs for the gastric emptying test, and for gastric emptying, domperidone is we can use but associated with this side effect, and erythromycin we can use for treatment. Antiemetic drugs like we can use prochlorperazine, promethazine for this emptying, and surgical method we now recent treatment available like gastric electrical stimulation. So we can put this refractory gastroparesis not responsive to diet, drug, and glucose control. So we should, this is FDA approved under the humanitarian device exemption for the gastroparesis. So this causes reduced nausea and vomiting, may improve gastric accommodation and vagal tone, and placement by the surgically implanted electromuscular ball of the stomach in the interim of the stomach. Another recent endoscopic treatment is endoflip. We can use evaluation mainly tool now, characterizing pyloric function, predicting treatment outcome after peroral pyloromyotomy, and this can be used for treatment of but intrapyloric injection botulinum is not recommended for nowadays. Another newer treatment modality is GPOM for gastroparesis based on the open label study. 12-month study showed 56% patient improvement at 1 year after the GPOM. So this is endoscopic pyloromyotomy compared with surgical myotomy. However, endoscopic myotomy has fewer additional advantage as compared to surgical because of shorter hospital stay, lesser complication with open myotomy. Another near modality jejunostomy, J-tube feed, gastrostomy tube we can use. Surgical intervention, we can do gastrojejunostomy by the surgeons can do this procedure, and subtotal and total gastrostomy because there is a resection of stomach by the base and different method for the gastroparesis with the loss of total patient who are refractory to normal treatment. Thank you. Yes, sir. I'm not audible, sir. Gastric lactic stimulation, sir. Gastric pacemaker. We have now.
Gastric pacemaker.
Gastric pacemaker, gastric lactic stimulation we can use, sir, in only those subject of patients who are refractory to this normal conservative management, medical management. We can use this gastric, but it is not available in Indian setup, sir.
Thank you so much, Professor Pankaj Sati. We close this session. Thank you so much.
Thank you, sir.
Please, sir, please initiate your talk, please.
Thank you, sir, for kind words of introduction. I am thankful to the organizers for giving this opportunity to interact with fellow colleagues. My topic is refractory hypothyroidism, diagnosis and management. You see, by definition, primary hypothyroidism is considered to be refractory to oral thyroxine replacement when there is biochemical or clinical evidence suggestive of inadequate control. Biochemically, TSH more than 4 or 4.5 after 6 weeks of last dose adjustment, or clinically unresolved symptoms of hypothyroidism, despite increasing dosage of levothyroxine beyond 1.9 microgram per kilogram per day. So that is the definition, biochemical definition and clinical definition. Coming to its prevalence, it ranges from 10 to 30% in various studies. A recent study from Brazil involving 2,200 plus hypothyroid patients found 28% of them to have elevated serum TSH levels with a background of optimized thyroid hormone therapy. It is not uncommon to discover symptoms of both hypo and hyper in patients treated with levothyroxine, and biochemical values in the desired reference range specified by current treatment guidelines. Coming to its causes, there are pathologic causes, there are non-pathologic causes. Amongst the non-pathological causes, which account for majority of cases, non-compliance is most important. It accounts for a large number of cases coming with suboptimally controlled TSH. And non-compliance is not only missing the dose, it is not taking the dose in an appropriate manner or in appropriate quantity. Sometimes you prescribe 112, they continue with 100. You prescribe them to take in the morning, empty stomach, they take it after morning tea. In the controlled surveillance project, 925 patients on levothyroxine, it was reported that many do not take thyroxine therapy as indicated. more than 21% reported taking thyroxine less than recommended 30 minutes before eating. The study was conducted by Macmillan. Then switching of the thyroxine formulation, the brand. The generics tend to have different bioavailability, and this is an important cause contributing to suboptimal control. Then there are certain drugs and dietary habits which have an impact on absorption of levothyroxine formulation given in tablet form. Levothyroxine is given in the form of sodium iodide. In the acidic medium, the iodide part is separated, and this iodide is absorbed at the level of jejunum and ileum. If there is achlorhydria or hypochlorhydria, then there would be suboptimal absorption of the drug. So medications like proton pump inhibitors, histamine receptor blockers, cholestyramine, motility modifying agents have an adverse effect on bioavailability. Nutritional supplements like vitamins, dietary factors like timing of injection, all these contribute to poor bioavailability. Again, in the control surveillance project, the comorbid conditions were identified. 33% had esophageal reflux, 9.7% had irritable bowel syndrome, 7.8% had lactose intolerance, and 34% were taking medicines, either OTC medications or prescription medicines which interfered with absorption. The dietary supplements, particularly iron and calcium, also interfere with the absorption of L-thyroxine. Pregnancy is a condition which is associated with 50% increase in the dose. It starts in early pregnancy, plateaus, peaks in the middle of the pregnancy, and thereafter remains stable. Then pathologic causes. There are conditions which lead to changes in functioning of the GI tract, like Helicobacter pylori infection, inflammatory bowel disease, celiac disease, lactose intolerance, atrophic body gastritis, gastric bypass, biliary pancreatic diversion, and gastroparesis. All of them interfere with optimum absorption. Then changes in the body weight. Those who put on weight or those who lose weight would have changes in their requirement of replacement therapy. In 100 consecutive cases of thyroidectomy prospectively evaluated, optimal dose of L-thyroxine was predicted by this simple formula: weight in kilograms minus age in years plus 125. That is the dose which a person would require after total thyroidectomy. But here it is more correlated with the lean body mass rather than total body weight. Conditions which lead to rapid weight loss like AIDS, malnutrition, bariatric surgery would have an impact on homeostasis of thyroxine replacement therapy. Then there are some people who are poor converters of T4 to T3. There is a deiodinase type 2 or 5' monodeiodinase which converts T4 into T3, and this conversion is suboptimal, and as a result monotherapy with T4 fails to control thyroid adequately. In 2011, Gulo et al. Concluded that while long-term effect of chronic tissue exposure to an abnormal T3-T4 ratio are not known, a sensitive marker of target organ response to thyroid hormones is needed, which evaluates the impact of T3 and T4. They said that it is an abnormality which is at the level of pituitary, and that necessitates a higher dose to be administered to attain sufficient suppression of TSH. Kim and Blanco postulated that some thyroid patients have less effective deiodinase. They found this suboptimal conversion in 16% of the studied population. They concluded that majority of hypothyroid patients do not have this problem and can achieve the desired therapeutic response with monotherapy. Others would require combination therapy of T4 and T3. There is a condition in which there is decrease in tissue level of thyroxine T3 much greater than the serum level of T3. So chronic emotional or physical stress, chronic illnesses, diabetes, insulin resistance, obesity, leptin resistance, chronic fatigue syndrome, myalgia, premenstrual syndrome, dieting and weight gain lead to decrease in tissue T3, which is much greater than serum T3. The serum T3 is decreased by 30%, and in spite of this 30% decrement in serum T3, it is within the normal range. The tissue decrement is 70 to 80%. So T3, T4, TSH are in the normal range or near normal range, but patient has tissue hypothyroidemia and patient is symptomatic. Less common causes are autoimmune thyroid disease. Patients have greater likelihood of anti-thyroxine antibody. In one study, 17.1% of patients with autoimmune thyroid disorder had anti-thyroxine antibody, and that contributes to suboptimal response. Suzuki and colleagues reported 10 to 20% of their patients did not have an identifiable cause. In another study, the proportion of such patients was 20%. Nowadays, it is postulated that gut microbiota also contributes to suboptimal regulation of thyroid status. When a patient comes with elevated TSH, with or without low T4, the normal tendency is to escalate the dose. But this approach is fraught with the danger of supratherapeutic doses exposure intermittently. And this intermittent exposure to supraphysiological dose has adverse effect on bone, cardiovascular, and other medical conditions. It requires frequent visits and leads to increase in the cost and loss of satisfaction on the part of the patient. So when a patient with suspected refractoriness comes, confirm the diagnosis and lab results, ask about compliance, check the bottles, review the thyroxine injection history, investigate for the thyroxine malabsorption, consider increased requirement or excretion, and consider alternative formulations. Evaluate the possible cause, manage the condition, reassess after correcting the identified abnormality. If patient has continued symptomatology suggestive of hypothyroidism, consider testing free T3. And if low, it can be a case for LT3 supplementation. Thank you.
Thank you, sir. Very precise presentation. And the session is open for questions.
So patient comes with subclinical hypothyroidism.
Hypothyroidism.
Subclinical hypothyroid or hypothyroidism.
Hypo or hyper, both, in both the cases.
A patient who has subclinical hypothyroidism in elderly age group, that is to be treated because such status is detrimental for cardiac and muscular and skeletal health in elderly population. So subclinical hyperthyroidism is treated in elderly population. Subclinical hypothyroidism is treated in pregnant ladies and those who are planning pregnancy. Subclinical hypothyroidism is not treated in younger age group other than ladies who are pregnant or those planning pregnancy. And subclinical hyperthyroidism is not treated in younger individuals. It is treated in elderly population with or without elevation of T3 and T4. Suppression of TSH alone is a sufficient evidence to start antithyroid medication in elderly people.
What is the significance of TPO antibodies and subclinical hypothyroid?
Positivity of anti-TPO antibody is about 20% in Indian studies. So it is a non-specific marker of autoimmunity. But presence of autoimmunity increases the chances of rise in TSH in subsequent months. So a person who has anti-TPO antibody positivity with T4 TSH greater than 4 is a candidate to be put on thyroxine replacement therapy. A lady who has difficulty in conceiving or has bad obstetric history, TSH as low as 2.5 needs to be treated. So antibody positivity with TSH between 2.5 to 4, which is the normal range of TSH, requires treatment in a lady who has primary infertility or bad obstetric history.
Sir, subclinical hypothyroid को decide करने के लिए, does the family history contribution, is there some contribution of
positive family history is usually indicative of autoimmune thyroid disease. So it has an inherited component. So they are more likely to require therapy in future. So positive family history increases the likelihood of worsening of the status from subclinical to overt hypothyroidism.
Thank you, sir. Thank you so much.
Thank you.
Sir, sir. Sir, in our day-to-day practice, whereas I am talking about the GP, can you elaborate the vitamin D can play a significant role in case of thyroid patient?
Vitamin D has immunomodulatory role.
Okay.
So vitamin D deficiency can have an impact on the progression of autoimmunity.
Okay.
Secondly, patients, particularly in the elderly age group, have rampant vitamin D deficiency with subclinical hyperparathyroidism contributing to osteoporosis, worsening of osteoporosis. Vitamin D supplementation could eliminate subclinical or overt secondary hyperparathyroidism, thereby would protect the bone health. So vitamin D deficiency should be managed aggressively in those who are taking thyroxine replacement therapy, and calcium supplementation also would be desirable in ladies who are in postmenopausal age group and elderly persons of both sex.
Thank you, sir.
Thank you, sir.
I request sir to start his presentation. I think he needs no introduction.
Thank you, sir. Thank you. So I assure our friends from JOGS that I will be very, very quick because this is the last session from the medical point of view. So I am basically discussing about the transitioning from legacy to leading edge, that is the new generation of basal insulin. We all know that the basal insulin is the first upgrade when a patient fails the treatment with oral hypoglycemic drug. Then usually it is the basal insulin which is the first tool in our armamentarium to control the diabetes. Now this is the disclosure from my side. And we all know that we have come a long way from the beginning of insulin, right from the day when the insulin was extracted from the animal origin, the usual insulin, the regular insulin, then the basal insulin, changes in the chemical structure of the insulin, and now we have got insulin which is second generation of the basal insulin, which has got a flatter profile, more safe and more predictable profile for the control of hyperglycemia. Why there is a need for new generation of insulin? Because till date the existing insulin have got several problems like variable absorption, slow onset, pronounced peak, high risk of hypoglycemia, less predictability in their action, high variability in the action, delayed action, no flexibility for the patient, because usually with the older insulin patient needs to take insulin at a fixed time, rigid dosing schedule and more dose requirement. So I am giving you a simple case, usual patient on multiple oral drug, but now failing the trial of the oral drug. Even with the older insulin, his blood sugars are not properly controlled. Now, according to the various guidelines, it is the basal insulin which is the most convenient initial insulin treatment. So it is more easy to implement and more acceptable to the patient. What should be the property of an ideal basal insulin? It should have a flat glucose lowering profile so that it will not cause hypoglycemia, specifically the nocturnal hypoglycemia, long duration of action, minimal variability, because variability is more problematic as compared to the absolute sugar control. More variable the blood sugar profile, more is the target organ damage. And also the low risk of hypoglycemia, which becomes very, very important in patients who are having multiple comorbidities, because a single episode of hypoglycemia may bring about serious complications or even death of the patient. Now, I am not going into the timeline of the progression of the insulin development. We all know that the newer insulins are better than the older insulin on all the accounts. So what are the unmet needs? Not truly once daily insulin till date, because most of the so-called basal insulin usually require 2 injections to have 24 hours coverage, high variability in the insulin action, fixed time of dosing, which I have already told you, and not a truly peakless insulin. So all the basal insulin so-called till date has a peak. This peak usually coincided with the nocturnal hypoglycemia. So through certain subtle molecular changes, we have got a new basal insulin, which is a second generation basal insulin, and through the novel protection mechanism, this insulin has got a more predictable, more flat and less variable profile. So this is the flat line action of the Tresiba, which is the newer or the second generation basal insulin, almost a steady state. You give the injection at one time of the day and you check 24 hours period, the insulin action would be totally predictable and flat. You give the injection at a different time of the day, again next for 24 hours, the insulin action would be totally predictable. So this is the breakup of the glucose lowering capability of the newer insulin. The green panel and the gray panel shows the glucose lowering capability throughout the day of the older insulin. You see, throughout the day, the glucose lowering is totally predictable and equal with the newer insulin. And this slide is very, very impactful. The lower day-to-day variability, you can see the smaller bar diagram, which basically are with the new basal insulin, that is degludec or Tresiba. Throughout the day, there is no difference in the insulin action. They are totally predictable without any variability. Now, the older insulin has got certain design flaws, and which rendered all the problems which we see with them today. And this is the switch study. When you switch the insulin from older to the newer one, the glucose lowering capabilities are improved. When you switch from the newer to the older one, the glucose control suffers. So again, in the switch study, which is the real head-to-head comparison between the two insulin, the newer insulin wins. Now, we all know that now there is a new index for the glucose control, that is called the time in range, that is TIR, and it should be for the most period of the day should be, the blood sugar should be between 70 to 180 milligram per day. And with the newer insulin, it is 20% better as compared to the older insulin. 20% may not appear very significant to you, but when you see the incidence of hypoglycemia, which is significantly less pronounced with the newer insulin, overall hypoglycemia less, 30% less, severe hypoglycemia 51% less, and the real problem, nocturnal hypoglycemia 53% less. So they are not only effective, but they are safe as well. And again, you can take the newer insulin, say 10 a.m. today and 10 p.m. tomorrow, 2 p.m. at third day, but in all the 3 days, all over the week at different time of the dosing, the effect would be totally equal and without any variability. And the newer insulin are now acceptable or sort of indicated and advised for almost all the conditions: pregnancy, elderly, pediatric of more than 1 year, renal hepatic impairment, adults, and hospitalized patient. How to shift from the older insulin to the newer insulin? The basal conversion is 1:1. Suppose you are taking 20 units of total basal old generation basal insulin, you will start with the 20 unit of the newer insulin. Suppose you want to change from the BID insulin, then you have to reduce the dose by 20%. So again, there is 20% reduction in the total dosage with the equal amount of blood sugar control with the better hypoglycemia profile. Now, how to upgrade, up titrate or down titrate the insulin? If above target, add 2 units of insulin every day at the given time. If the patient is maintaining the blood sugar, continue with the same dosage. If the targets are below, say patient is having hypoglycemia or slightly lower sugar, reduce the total dosage by 2 units. Now there are app which require only 2 things: the fasting blood glucose and the total insulin dosage, and they will calculate the dose for the patient. Patient can also use it, and doctors can also use it. The app is available by the name of Dose Check. So with this scenario, our patient, which we have described early, was given the insulin, that is the newer insulin, Tresiba or Degludec, 14 units once a day, calculated according to the weight of the patient, and patient achieved his A1C target without glycemic variability and is now have a control over his injection timing also. So these are the benefits: greater HbA1c reduction, lower risk of overall and nocturnal hypoglycemia, lesser glycemic variability, wider window of dosing flexibility, and improved quality of life. So with this, I complete my lecture, I think, within the given period. Thank you very much for patient hearing. So if there are any questions, then I would be happy.
Thank you, sir. Any question and comments?
With the newer insulin, sir. Sir, I have never seen the hypersensitivity or allergic reaction with this newer insulin. But with the existing insulin, basically the insulin which are the mixed insulin, 30-70 or 50-50 mix, I have seen the injection reaction, but not with the newer insulin. Sir, I am unable to hear it. मेरे ख्याल से सर को एक बार माइक दे दीजिए.
The hypersensitivity in the patient is there, but अब उसको इस insulin का benefit देना चाहते हैं, and should we try to find out the allergy cause concomitant with this drug also, and if at all it is due to the purely insulin, is anything can be done to make him palatable or to acceptance of the
Sir, actually the insulin allergy or rash is seen with the older generation of insulin, which had some amount of antigenicity. With the development of the newer analog and newer insulin, probably this problem is very less common. Even after that, suppose in a hypothetical condition, patient requires we are giving newer insulin to the patient and patient is still allergic, then we can do the hyposensitization. There is a particular protocol where you increase the dosage of insulin and at the same time you start some amount of oral corticosteroid and you taper down that oral corticosteroid. So more steroid, less insulin, and at the end of the, say, titration period, more insulin and less of the oral corticosteroid. Usually this is the technique described in the literature to reduce the antigenicity or the insulin rash in the patient who require insulin but who develop rash despite giving it.
Thank you so much.
Thank you.
Thank you, Parama sir.
Thank you. Thank you very much.
For felicitation. Now our next speaker, I would like to invite Dr. Aditya Parihar sir to please come up on the stage. Our chairperson, Dr. Ashok Kumar Jain sir, Dr. R.B. Patel sir, please come on dais. I request you all to please come up. Come up on the stage as a chairperson.
Thank you. Thank you, everyone. Thank you, Dr. Abhishek, sir, for allocating me such time when the hall is nearly full. First of all, it was a moderation session which with panel discussion to be made, but at the end it has to be changed to a demo only. So the topic is vitamin, minerals and antioxidants, should they be prescribed regularly? अगर इसको हिंदी में बोला जाए तो क्या डॉक्टर साहब ताकत की शीशी लिख देंगे इस चीज़ के टॉपिक को हमको आगे evidence based medicines, we have to deal with this evidence based medicine, and we will be discussing on vitamin, minerals and antioxidants, should they be prescribed regularly. I will be throwing the polls for the audience, for the chairpersons, so it can be an interactive one and we will gain something from this session. So the poll 1 to all out here: do you routinely prescribe multivitamins to your patients without documented deficiencies? When I asked Dr. Sushil sir, Kelly sir, the poll same to you: do you routinely prescribe vitamins to your patients without documented deficiencies? And the options are yes, often, occasionally based on lifestyle or diet, or rarely or never. Occasionally, yes sir. So the question arising is the average diet today deficient enough to justify the routine supplementation? The answer is a big no. The modern diets often lack essential nutrients. For example, vitamin D, fibers, omega-3 fatty acids, and many essential micronutrients. The processed food dominates, and should supplements be used as a safety note or a last resort is a big question also. The role of education is very dominant, and the access to whole foods is also a question concerned to this developing country like India. Then the question arises, which population do you believe benefits most from the routine micronutrient supplementation? Many gynec consultants are there. So pregnant women, elderly, vegans, or vegetarians, general adult population, or children. Then which population genuinely needs supplements, and does routine supplementation is required? So there has to be a genuine need. The routine supplementation for all adults is not supported by current evidence-based guidelines. There are no such guidelines which direct us to routinely supplement these micronutrients to the general population. The general population with access to a balanced and varied diet typically receives sufficient micronutrients through food. However, certain targeted populations such as pregnant females who are deficient to folic acid and required extra supplementations of iron and folic acids. There are elderly individuals who are requiring extra dosing of vitamin D, B12. There are people with malabsorption syndromes like celiac disease, Crohn's disease, and they require B12, irons. There are vegans who are deficient in B12 and iron and calcium. And also there are post-bariatric surgery patients which are at a higher risk of deficiencies of these micronutrients or vitamins or supplements. In these groups, target supplementation is both cost effective and clinically justified. So yes, in particular population or in particular groups of people, we have to use targeted supplementation, which proves to be very cost effective and clinically justified. The overprescription in the general population may not lack benefit, but can pose toxicity, risks, and contribute to pill burden without addressing the root dietary issues. So we have to address the root dietary issues also, and it has to be a clinical decision after consulting the patient that what all dietary contributory factors are there and whether the patient or the concerned people is under risk of depletion of such supplements. So how do we balance between preventing deficiencies and avoiding over supplementation? There is always a saying that more is always not better. This balance hinges on clinical judgment and individualized care. Preventing deficiency is critical, particularly for nutrients with long-term health impacts like calcium and bone health, iron and anemia. But supplementation must be evidence-based. Blanket prescriptions without proper dietary assessments or lab investigation may lead to hypervitinosis, and mainly the fat-soluble vitamins like vitamin A, D, E, and K are more prone to hypervitinosis. Also, the trace elements imbalance has to be taken into consideration. The excess zinc impairing copper absorption is well noted. Comprehensive dietary evaluations, medical history, and relevant biomarkers should guide supplementation. There also one factor which has to be taken into consideration and always is the patient education. This is the key one. Explaining the importance of food-based nutrition and the risk of self-medication, supplementation can reduce the unnecessary burden to the society. The next poll to you is how often do your patients ask for a take supplement in their own without your advice? There are many patients in our OPDs complaining that please write some supplements in the form of syrups, tonics, tablets or capsules. So yes, there are frequently. Some are occasionally, there are also rarely, and some OPDs never the patient come. But according to me, there are frequently, and in this current scenario, the patients are rising day by day who are more concerned to their health, and they are frequently involving some or the other form of supplementation in their diet apart from the daily food. So what are the dangers of self-prescribed or over-the-counter vitamin and mineral use? The OTC drugs. The unregulated use of supplements is a growing public health concern. Many patients believe that natural equals safe, which is not always the case. Fat-soluble vitamins like A, D, E, K accumulate in the body and can lead to toxicity when consumed in an excess. Vitamin A toxicity, for example, can lead to intracranial hypertension, liver damage, teratogenic effects in pregnancy. High dose of iron or calcium can cause gastrointestinal distress, interact with medications. There are in my OPD many patients who are consuming vitamin E, like Evion tablets by their own, and it is that vitamin E also leads to hypervitinosis and can lead to cardiac failure in some patients too. So megadosing antioxidants like vitamin E has shown no cardiovascular benefits and possible harm in trials like HOPE-2. So patients have to be encouraged to not self-consume these supplements, and there are hidden problems with such hypervitinosis also. So can routine supplementation reduce the overburden on healthcare system in the long term? So India is such country which is developing, and we have to look for the monetary funds also. We have to look for the pocket of the patient, and routine supplementation is such which can definitely increase the burden of the patient. What's your biggest concern about widespread supplement use in the general population? When the question rises, there are some risks of toxicity. Many are concerned about masking dietary issues. Many are concerned about drug interactions. Many are suggesting that it is economic waste. And many physicians or consultants are such that they have no concern and when benefits out risk ratio, they use them. So, yes, but only when the implementation is in the right construct, it may profit the patient or may function in good of the patient. In public health, preventive supplementation has historically shown clear benefits: iodine in salt to prevent goiter and mental retardation, folic acid fortification to prevent neural tube defects, and vitamin D for rickets prevention. However, routine supplementation without population level evidence of deficiencies may not reduce disease burden and can divert healthcare resources. For example, mass vitamin D testing and supplementation become widespread without solid evidence for non-bone related benefits, leading to unnecessary expenditure. A population level screening approach combined with targeted supplementation, especially in low strata, should be evaluated, and it is not such that widespread screening programs can be run in India, which is low in funds related to health concerns. So how strong is the evidence linking micronutrient supplementation to improved chronic disease outcomes? There are many trials which has been done and which are already ongoing and running. So the answer is a mixed bag. The evidence remains mixed and sometimes contradictory. While folic acid clearly reduces neural tube effects, trial on vitamin E, C and beta carotene for cardiovascular and cancer preventions have yielded negative or inconclusive results. The Suvimax, Hope and Select trials are the few of the trials which have failed to show significant benefits of antioxidant supplement for chronic disease prevention. Now coming to what role should diet play versus supplementation. So it is a backbone foundation. The diet should always be foundation of micronutrient intake. Whole food provide not just, I will take a 1 minute more. I will directly skip to my main slides. Is there a role for micronutrient panels in routine health checks? So the answer is, it is a costly affair, not for general population. The micronutrient panels are expensive, often yield incidental findings and may lead to overdiagnosis and overtreatment. So coming to the summary, after all these study on supplements, vitamins and minerals, the support for routine prescription, the prevention of deficiency disease, routine supplementation can help common deficiency like iron, vitamin D, iodine in form of anemia, rickets or goiter. Vulnerable population are children, elderly population, pregnant females. People with poor dietary intake may benefit from regular supplementation. Improved immunity and health, some believe regular use boosts overall health and immunity. Arguments are there for routine prescription. Risk of overuse has to be dealt with. Balanced diet is better always, and if balanced diet is ongoing with the patient, then it will be very helpful to him. The cost and the waste has also taken into consideration. The conclusion is routine prescription is not always necessary. Supplementation should be targeted based on age, diet, health status and medical advice. Thank you.
Nice deliberation, a very not frequently talk, they talk, very important talk. Whatever we can we assess with the lab, and we have got all measures and different labs, up-to-date labs are there. If at all we feel a deficiency at the level of doctor, if he recommends, that will be for a proper time and depending upon the deficiency of even trace elements and everything. So toxicity, we can have problem in diagnosing the different skin diseases, different systemic diseases, so many things which we don't have the vision for it until unless the patient tells us he is going or taking. And on the part of medical store people, it is exploited so much. So any question pertaining to this topic? You can go ahead.
Thank you, sir and chairpersons, for the insightful session. I request respected chairpersons and speaker, sir, to please move forward for felicitation. Now next, I would like to call upon Dr. Vishal Kastavar, sir, to please come up on the stage. And for chairpersons, I would like to call Dr. Anand Shukla, sir, Dr. Raj Kumar Jain sir to please come up on the stage. And after this session, we have panel discussion with gynecologist. Be ready for that. After 10 minutes.
So good afternoon, everybody. And I think this may be an important topic for future of all practitioners. So we'll be discussing. This is semaglutide, which you may have been reading, which you may have been hearing in various social media circles, that people are taking injections for weight loss. And I would just present you a preview on this. You all know that obesity not only comes from eating, it comes from various other factors: biological, genetic, psychological, social, medications, and environmental. Brain plays an important role in creation of obesity. It increases food intake through hunger, eating for pleasure, and deciding to eat. Various different hormones play in these three factors. Eating for hunger is basically homeostatic eating, which comes predominantly from GLP-1 receptors, but there are other receptors also, including amylin, ghrelin, and all. For pleasure, people tend to eat for pleasure in order to increase the pleasure, and this is mediated through dopamine and the release of various opioids and cannabinoid receptors. The decision to eat is basically a behavioral decision which is guided by hunger as well as pleasure. If you look at various lifestyle intervention studies, they have shown that whatever lifestyle interventions result in weight loss, whether it be dietary modifications, whether it be exercise, the usual sustainability is limited, and at the point of time when the doer stops doing it, the weight gain immediately restarts. And this may have been experienced by a lot of us also. We all know that in the time when we tend to lose weight through whatever we can do, we lose weight. But at the time we stop, we most of the times even surpass our previous weight where we had initially started. So the weight loss mechanism depends on several things. There is calorie and activity which tends to help us in weight loss, decreasing calorie, increasing activity, but metabolism, hunger hormones, fullness hormones all play the opposite role. Despite whatever efforts we can make, weight loss either is not sustainable or it is not achievable also. So we'll be presenting this Wegovy, which is probably due to launch in our country in next 2 to 3 months. This is semaglutide 2.4 milligram injection. This is a weekly injection. Semaglutide is a GLP-1 receptor analog which has 24% homology to the human GLP-1, and the T half is approximately 1 week. So weekly injection is being recommended all over the world. Currently we don't have it right now in India, but it will be available very soon. Semaglutide not only acts to the gut, it acts in the brain also by directly activating the hypothalamus and the hindbrain, the AP and the NTS. It will be available in this single shot injection, 2.4 milligrams. And what has been observed is people who have been taking Wegovy 2.54 milligrams, the satiety tends to increase. So the public or the patients start feeling less hungry, and through the hedonic regulation, you have reduction of food cravings and preferences. Various studies have been done. More than 26,000 participants have participated, and across the world, 80 lakh people have already been exposed to various forms of semaglutide. These are the various international studies, and in which Indian patients have also been participating. If you look at the weight loss semaglutide, which is 2.4 milligrams, apart from weight loss semaglutide, you have anti-diabetic semaglutide given up to a maximum dose of 1 milligrams, and oral semaglutide is also available these days. This is the step 1 trial in which Wegovy was given for overweight and obesity, and the results were compared with placebo. And what they found was, as compared to placebo, a 16.9% weight loss was achieved in around 68 weeks, which is around 1.3 years. So in just around 15 months, they could obtain a weight loss of 17% with 2.4 milligrams of weekly semaglutide injection. 92% patients achieved a weight loss of more than 5% over 68 weeks, and 1/3 of these patients achieved a weight loss of more than 20% in a 68 weeks period, which was 16 weeks. Apart from this, a mean 15.2 centimeter waist circumference drop was observed, 7.1 millimeters of mercury systolic blood pressure reduction was observed, and physical activity score tended to improve over a period of time, which cannot be achieved with just dietary control. After dietary control, you tend to lose the muscle mass also. But here, with Wegovy, the physical activity score also improved. HbA1c improved by 0.5%, diastolic blood pressure also improved somewhat, and C-reactive protein also improved. The effect of maintaining Wegovy over a 2.4 milligram continued versus withdrawal was also compared, and you can see over here, after 16 weeks, some patients withdrew Wegovy, resulting there was consequential increase in weight by 6.9% over the next around 50 weeks period. But those who continued taking Wegovy, the average weight reduction was 18%. If you look at long-term maintenance data, this is the long-term maintenance data. Patients who continued Wegovy for 2 years period, 16.7% reduction of weight loss was still achieved. Most importantly, more than 1/3 patients achieved a weight loss of 20%. This is data from step 1, step 4, and step 5 trials in which side effects were observed. Side effects were usually related to gastrointestinal events. Serious adverse effects were minimal. No fatal adverse events were observed. And events related to discontinuation were not significant. GI adverse effects were main, which were predominantly nausea, anorexia, and diarrhea. Summarizing my presentation, Wegovy 2.4 milligram will be available in our country in the next 2 to 3 months. It has been approved for use in diabetic as well as non-diabetic population. 2.4 milligram is predominantly for non-diabetic population with a BMI of more than 27. More than 20% weight loss in more than 1/3 patients. Sustained weight loss for a period of 4 years. And significant other health gains, including cardiovascular risk reduction, physical function improvement, and lifestyle improvement. Thank you.
It's a wonderful presentation, as usual. A small query, like the way you show this tug of war. So what about drug-induced weight gain and people who are diabetic? So we can go scot-free prescribing them semaglutide, or we have to take precautions?
Sir, semaglutide has been recommended for management of obesity in patients who have a BMI of more than 27, whether they are diabetics or non-diabetics or whatever. It has been found, it is actually an anti-diabetic agent, but because it does not cause hypoglycemia, so it has been tried in non-diabetics also with good results. There is cardiovascular improvement, there is physical activity function improvement, and sustained weight loss if the treatment is continued. If you stop the treatment, the weight return will again occur as it usually happens.
हेलो, सवाल मैं आपसे पूछना चाहता हूँ कि जैसे SGLT2 है उसमें यूग्लाइसेमिक कीटोएसिडोसिस होता है और the cause is relative insulin deficiency. In those patients may be on insulin, later on put on the SGLT2. But nowadays, as you are recommending for obese non-diabetic patients this drug, and now in some cases, I've got the case studies also. Some patients, they are complaining of euglycemic ketoacidosis has been seen. So what is the ultimate cause? Lack on the part of the insulin deficiency not diagnosed in those non-obese patients, or they had been the obese patient or pre-diabetic patient.
So with relation to SGLT2 inhibitors?
No, that is there, euglycemic ketoacidosis. But nowadays with the GLP-1, 2.4 जो आप बोल रहे हैं, the cases are seen non-obese, obese non-diabetic patients having this problem, euglycemic ketoacidosis?
Sir, as far as my information currently, I have not used because it is not available. I think GLP-1 receptor analogs do not cause euglycemic ketoacidosis, which is observed as SGLT2.
I've got studies, I
Okay.
WhatsApp.
I'll have to read over it.
This has been noticed and this has been seen. Patient is obese. They say non-diabetic. Put on this drug. Or maybe concomitantly with the SGLT2 might have been used.
Maybe, sir.
But,
Maybe.
But this is the, question to think over, and this is one of the cause. अब Indian patient में हो सकता है वो जो वहाँ recommend कर रहे हैं.
I'll, sir, definitely read through it. Yes. Before prescribing, before starting my prescription, definitely I'll go through everything.
ये जो डाटा बोलता है वो तो ठीक है, but कुछ cases reported हैं, ठीक है ना?
Yes, sir.
Thank you.
Thank you, sir, for an insightful session, and thank you, chairpersons. I would like to.
So, thank you all the JOGS doctors for patientfully bearing us. And now we move ahead with the very interactive and insightful sessions. The Jabalpur Obstetric and Gynae Society has agreed and honored us to be here and share their views, their insights in perspective of cardiology, diabetology and gynecology also. Thank you.
किसके वास्ते कौन है यहाँ तुम्हारा, कौन है यहाँ तुम्हारा, क्या तलाश है, क्या तलाश है, मुख पे एक सवाल है, मुख पे एक सवाल है, जवाब दो, जवाब दो, इशारा, इशारा, मिल ही जाएगा, मिल जाएगा, बात बात में यूं ही, बात बात में यूं ही, ढल गई उम्र, ढल रही उम्र, वक्त वो कहाँ से आए, वक्त वो कहाँ से आए, जो गया गुजर, जो गया गुजर, देर हो गई मगर, देर हो गई मगर, फिक्र ना करो, फिक्र ना करो, तुम्हारा, तुम्हारा, दर्द जाएगा, दर्द जाएगा, ओम जपा करो, ओम जपा जीव जीव में हरि को,
जीव जीव में हरि को,
देखते चलो,
देखते चलो,
प्रेम के बहाव में,
प्रेम के बहाव में,
बहते ही चलो,
बहते ही चलो,
सितारा,
सितारा
जगमगाएगा,
जगमगाएगा।
ओम प्रणाम, ओम शांति।
What a melodious voice, ma'am, and what a wonderful start. Now, I would like to call our first speaker, Dr. Ayushi Divakar, ma'am, to please come up on the stage. And chairperson for the first session, I would like to request Dr. Sharda Mishra ma'am, Dr. Anuradha Dang ma'am, and Dr. Sonal Sahani ma'am to please come up on the stage and join us. Thank you.
Hello. Good afternoon, everybody. At the outset, I would like to thank the organizers, Dr. Parimal Swami sir and Dr. Abhishek Srivastav, for such a successful conference and giving and making jogs a part of it. We are extremely thankful, and now may I welcome Dr. Ayushi for her talk on RH sensitizations during pregnancy. Please.
Good afternoon to respected chairpersons, seniors and each and everyone present here. I am Dr. Ayushi Divakar and I'll be talking about RH sensitization during pregnancy. We have three RH antigens, C, D and E. If the D is present, then we call the person RH positive, and if the D antigen is absent, we call the person as RH negative. RH antigen appears as early as 38 days of gestation on the RBCs. The prevalence of de-alloimmunization in pregnancy ranges from 0.5 to 0.9%. 2% will become sensitized by the time of delivery, 7% by 6 months postpartum, and remaining 7% will be sensible, producing detectable antibodies only in subsequent pregnancies. The C and E antigens have lower immunogenicity, but anti-E alloimmunization is the most common, but the need for fetal transfusion is greater in C alloimmunization. The prevalence in India shows that it is maximum in North India. Some of the minor antigens are KEL antigen, which is the most common for sensitization, KID and Duffy E antigen. There is no risk of sensitization seen in Lewis, I antigen, Duffy B. They are predominantly IgM which cannot cross the placenta. Rh negative pregnancy occurs when the mother is Rh negative and the father is Rh positive. So that the fetus will be Rh positive and there will be sensitization in the mother. Pathophysiology of Rh incompatibility. Rh negative mother carrying a Rh positive fetus, due to the placenta usually acts as a barrier. Any breach in that barrier may cause mixture of maternal and fetal RBCs, which causes sensitization in the mother. Fetal Rh positive RBCs can enter the maternal circulation through a break in the placental barrier, like in threatened miscarriage, abortions, antepartum hemorrhages, amniocentesis, chorionic villus sampling, external cephalic version, any abdominal trauma, or delivery or LACS. Maternal production of rhesus antibody following introduction of Rh positive fetal blood, which causes sensitization in the mother. These are the signs and symptoms of fetal-maternal hemorrhage that is more than 50 ml. That is neonatal anemia, decreased or absent fetal movements, stillbirths, hydrops fetalis, non-reassuring fetal tracing, intrauterine growth retardation, sinusoidal fetal tracing, fetal arterial fibrillation, maternal transfusion reaction. Indirect Coombs test. It is the most important test in Rh negative pregnancy. It should be ideally done in first visit for any Rh negative women who is pregnant. According to Foxy, all Rh negative should have an indirect Coombs test screening for Rh antibodies as first visit. If ICT is negative, then it should be repeated at 28 weeks, and in case of positive ICT, 4 weekly we should do the testing, and if ICT is also done after the delivery of the baby, and DCT is also done after delivery. If DCT is positive, then we'll give anti-D as a prophylaxis within 72 hours of the delivery. In subsequent pregnancy, if the mother is Rh sensitized, then as the D antigen is IgG, the IgG antigen will go to the fetus and will cause the fetal RBC destruction, which will cause fetal anemia. The reasons for risk of sensitization is non-compliance on prophylaxis drug, less than 100% penetration in ANC and PNC, silent fetal-maternal hemorrhages, medical termination of pregnancy. Causes we have already done. Then risk factors, maternal characteristics like race, ethnicity, socioeconomic status, trauma. Then fetal characteristic like fetal anomalies, malformations, twin-to-twin transfusion. Placental characteristics like abruption, umbilical cord anomalies, then chorioamnionitis and placental tumor. In USG, if there is fetal anemia, there will be the portal vein diameter will be more than 5 mm, and there will be increased cardiac output. That causes cardiomegaly. Cardiac circumference is to thoracic circumference will be more than 50%. Right atrial enlargement will be there, tricuspid regurgitation, and pericardial infusion. Then RCOG guideline says that administer Rh immunoglobulins to every Rh negative pregnant woman at 28 weeks, and postpartum has reduced the incidence of Rh hemolytic disease in UK in 1 into 1000 live birth. Mechanism of action of anti-D. The Rh positive fetal RBCs that enter the maternal circulation are destroyed by anti-D immunoglobulin. Thus, the anti-D antigen in the fetal RBC is not allowed to be presented to the maternal immune system. Prevention of Rh immunization is anti-D. Prophylactic anti-D in 28 to 30 weeks postpartum following any episode of antepartum hemorrhage, spontaneous threatened abortion or ectopic, external cephalic version, trauma, amniocentesis, delivery, molar pregnancy, or any kind of pregnancy. Management of Rh negative mother. Careful history is very important. In first visit itself, if the patient is known to be Rh negative, first we should know the blood group and Rh typing of the husband. Monoclonal anti-D. Studies showed that earlier we used to have polyclonal anti-D, but now monoclonal anti-D injections are there, which are readily available, and no human serums or donors are required for the preparation of anti-D. Precautions that should be taken during delivery. There should be no use of methogen after delivery, no manual removal of placenta, cord blood sample collected for hemoglobin direct Coombs test, blood groups, serum bilirubin, anti-D 300 microgram within 72 hours of the delivery if neonate is Rh positive with DCT negative. Some benefits even after 28 days is also seen. So if in any case if the mother has missed the dose in 72 hours, within 72 hours of delivery, it is ideal to give it till 28 days also. Should all Rh-D negative women be screened for excessive fetal maternal hemorrhage after delivery of Rh-D positive infant? It is risk factor based assessment of the fetal-maternal bleeding. Then Kleehor-Bethke test measure the fetal-maternal blood. It quantifies the ml of blood that has been mixed to the maternal side, and according to that, anti-D is to be administered. Threatened pregnancy loss and indication of anti-D, then yes, any threatened pregnancy, if there is threatened abortion, any kind of abortion in any week of the pregnancy, it is ideal to give anti-D prophylaxis. How many anti-D immunoglobulin should be given for first or second trimester events? So according to ACOG, if it is less than 12 weeks, it has recommended 50 micrograms in any case, and if it is more than 12 weeks, then ideally we should give 300 micrograms. But here in Indian scenario, all the time we use 300 micrograms only, we don't have 50 micrograms. Should anti-D immunoglobulin be given in case of molar pregnancy? So yes, ideally it should not be given in complete mole because there is no fetal structures present, but it is a cytopathological examination shows that it is complete or partial mole, so it takes time, so ideally we should give after evacuation. The effect of anti-D is 23 days. So if within 23 days of anti-D, the patient delivers, then we can skip the dose. Then in unsensitized Rh negative females, we should immunize the women delivered 39 to 40 weeks vaginally. Early cord clamping is important so that minimal fetal-maternal hemorrhage should be there. Then if there is sensitized women, then if the first we'll do the ICT, it will be positive, then we'll do the titer. Then if the titer is critical, that is more than 1:16, then we will do the titers 4 weekly. If it is in raising order, then we'll do it 2 weekly. And if it will go on increasing and it will reach up to 1:32, then we'll go to Doppler and PSV. We'll do the Doppler and look for fetal anemia signs. Then hydrops vitalis. It is a USG diagnosis. If more than or equal to 2 of these are present, that is pericardial effusion, ascites, pleural effusion, subcutaneous edema, there will be placentomegaly, polyhydramnios, and the skin thickness will be more than 5 mm. There are 2 types of hydrops vitalis, immune and non-immune. And neonatal management, general physical resuscitation should be done. Thank you. Thank you so much, ma'am.
चेयरपर्सन कौन नहीं वो तो मैम लोग डिसाइड कर लेंगे खुला ही हुआ है ना जी पैनल मैम किसका खुला है
डॉक्टर दीपांकर बनर्जी फॉर हिज टॉक टॉपिक क्या है His topic is genetic and molecular testing during pregnancy.
Thank you very much, madam. Thank you, chairpersons, and thank you, the organizers. Thank you, Abhishek. Thank you, Parimal, for giving me this opportunity. And till my laptop is getting connected, why I am here and what I want to say. I want to talk to you that what is actual the DNA and its use. Unfortunate incidents एक हुआ अभी थोड़े दिन पहले अहमदाबाद में. And every day you are reading in the newspaper that bodies are handed over to the relatives with the help of DNA identification. That means that DNA is specific to that person and it cannot be cloned. हमारा जो DNA fingerprint है walls हैं, if anybody does something nonsense with the silicone gloves और मैं आपका भी clone करके silicone का gloves पहन लूँ, then you might be trapped. That means the fingerprint which is present in my thumb or my fingers are not very specific, it can be cloned. ऐसे करके गवर्नमेंट ने एक हमारा आइडेंटिफिकेशन नंबर बनाया दैट इज कॉल्ड आधार. बट आधार इज ऑल्सो बीइंग क्लोन्ड. देन if somebody else do some nonsense or some problem, then I might be caught that he might or she might be having my Aadhaar card or my identification and police will come to me and catch me. This is the basic crux of pathology. This is the basic crux of disease diagnosis. When we go, I will finish my talk very fast because it is a difficult talk, but I will make it as far as possible applicable to our day-to-day practice. With us, our physicians are here, gynecologists are here, how and why we should do it. So if you go with the DNA is the basic core project. मैं ऐसे ही चलाऊंगा. उधर दिखेगा क्या? आ गया. Yes, I can write it. Our body and lot of tissues in our body. Each tissue have a cell and this cell is having a nucleus. बहुत ही basic चीज बता रहा हूँ, but if you go and follow this, you will very well understand what actually I want to speak. And with this nucleus, there is within this nucleus, this is one DNA thread. Half of is coming from my mother, half of is coming from my father. But we all are human beings, but we are different. I am a male gender, you are a female gender, but we are human beings. That means we are different, but we are human. That means something is common in between us, but something is different which makes me me and you. There will be very difficult until unless I have identical twins with me, I can make a clone of me. अभी तक human का clone नहीं बना. But if I have that specific feature with me, that means it is my identity, you cannot steal it. You cannot clone it, you cannot create any nonsense that I get be caught. So every nucleus is having a DNA. जैसे इंग्लिश के लेटर हिंदी के हम जो पढ़ते हैं इसमें अक्षर होते हैं, ऐसे ही डीएनए का लैंग्वेज में 4 अक्षर होते हैं. उन 4 अक्षर का परम्यूटेशन एंड कॉम्बिनेशन बना के लैंग्वेज बनती है. जैसे हम बात कर रहे हैं, हिंदी में बोल रहा हूँ, या आई एम टॉकिंग इन इंग्लिश, इफ यू राइट इट देन यू हैव टू राइट द लेटर्स, देन यू कैन कॉम्प्रिहेंड. इन द सेम वे द DNA has 4 letters and it has a permutation and combination, and when it is written it can be read by anybody in the world and we can make proteins. तो ये जो RH का बता रही थी, RH is a protein, must be having something written in the maternal DNA which gives the D antigen expression. So D antigen is a protein. Protein has a DNA, must be written in that lady's or that baby's DNA. That means in every DNA, there is something written which is very specific to me, very specific to you, but something common. And if I am able to read it, then I can make a fingerprint. Anything in the world which is live, having a life, जैसे life sciences पढ़ते हैं. Life sciences starts from virus, bacteria, from protozoa, spirochete, syphilis, whatever it is. Each and every live thing is having a DNA. Virus में nucleus नहीं होगा, free DNA होगा, but in bacteria there is a nucleus and there is a DNA inside. There is no nuclear wall, and in virus there is no cell wall, there is a capsid. But there is DNA specific to that virus or DNA specific to that. That means if I have a fingerprint of tuberculosis and if I can find a tuberculosis fingerprint in my circulation, that means that person is there, nobody else. That means for the diagnosis of any infective disorder, like baby को टॉक्सोप्लाज्मा हुआ कि नहीं, साइटोमेगलोवायरस हुआ कि नहीं, हम क्या करते हैं? हम मदर का ब्लड टेस्ट करते हैं. What we do? We do indirect test by doing immunoglobulins. That means already diseased, reaction is there, and we are identifying the after effect. Can we know whether baby is actually affected or not? You have to do a fingerprint of that bacteria or protozoa like toxoplasmosis, or a virus like cytomegalovirus or rubella, or any virus like in dengue, in chikungunya, whatever it is. If you can identify that fingerprint, then we can get the fingerprint, and it is 100%, near to 100% that that person or that bacteria, that life is there in my circulation. In the same way, my written DNA is here, which is being given by one of my father, one by my mother. And this written DNA gives me a different language to every enzyme, every protein. If my globin protein is abnormal, then I will not make a good globin protein, or beta chain or alpha chain I will have. अभी sickle cell का अभियान चल रहा था. That sickle is a misprint in beta globin gene. मेरे को नहीं है, पर किसी को है. यदि है, that means I can 100% identify whether the baby or the lady or the fetus inside is having DNA misprint at that place where the sickle writing is there. That means if I can do a blood sampling of the fetus or placental sampling of the fetus or from the amniotic fluid of the fetus, anyway I get the DNA of the fetus, I can read its DNA. In the same way, if there is a toxoplasma infection, there is a chikungunya infection, there is a typhoid infection, there is a malaria infection, whatever it is, if I have that counter fingerprint with me, then I can definitely identify that fingerprint in the circulation. So it is a very specific, sensitive diagnosis. So this is the simple thing which I teach to my patients, that these are all what I explained, and we all identified by our DNA structure, that is DNA fingerprint. Now, we have a different fingerprint, that's why we are different. But is that difference creates me a diseased person, you a diseased person? No. That means there are something which changes created in the DNA doesn't create any disease. So there are something benign changes, some problematic changes. And we are all human beings, but we are different, so we are called of different morphology. Different morphology, when happens in a very large way, it is called polymorphism. It doesn't cause any disease, but if it is a misprint in the globin gene, it may create a disease. If it is different in the Rh factor, it may create a disease. It's not a disease, but may create a problem for the baby if mother is immunized. So diagnosis, that particular disease becomes very specific, and when we get the DNA of any life, bacteria, virus, me, you, anybody, even the problems happened in that tragic plane accident. पूरी body चार हो गई थी. any amount sort of DNA, we proliferate it. That photocopying is called polymerase chain reaction. It is not very difficult, we do in our day-to-day practice. If we can copy it, then we can identify it easily. So it is one of the very important steps. So all the organisms have their particular DNA pattern. If any of them enters into your body, when we can track them, if we know their DNA pattern, thus bacteria or tuberculosis or parasite of malaria, virus, hepatitis B, HIV, whatever it is, we can go up to the 100% specific diagnosis. Thus DNA PCR is very helpful and novel technique for diagnosing various genetic disease and infectious. So it is so important for physicians, for gynecologists, for anybody who is practicing medicine. You have to be go to the specificity. Otherwise, aap andhere mein teer maroge. If we can go to that level, then we can do. So what we are doing next generation sequencing in Jabalpur, prenatal diagnosis of genetic disease, aneuploidy screening and definitive diagnosis by CVS and amnio. We do oncology misprint written in the cancer patients so that the specific treatment can be given. We are helping pediatricians to know the neurological disorders of the young boys, why it happened, whether the next baby will have the same fate. Ek minute, na? The precision medicine by DNA, our physician friends are here. What is the exact? Will this person will have a likelihood of having a diabetes mellitus, rheumatoid arthritis? There are some HLA markers. If you have that HLA markers, I am not going into that detail. If you can have that written, what is written in the DNA, in the HLA position, then you can make it out whether this person is going to have this type of disease or not. And obviously, the pathology. This is not a culture. Culture makes it very difficult to have tuberculosis or virus. Go for its DNA and get the diagnosis. And this is the way we do our, you can see a needle coming here, and this is, I am taking the sample from the chorion, and baby is there, no problem. And any amount of disease you can make. This is our infectious disease part, and this is, I'm going in fast, molecular pathology lab. I invite everyone, if you want to say how DNA practice is being done in world. We can infection, and we make a library preparation. I'm not going into that detail. This is our, this is my main sequencing machine, which reads the DNA print, individual letters, ATCG. कैसे सीक्वेंस में लिखा है, नॉर्मल लिखा है कि abnormal लिखा है, कैसे पता चलेगा? लाइब्रेरी के साथ उसको देखते हैं मिला के. And this is all DNA storage area, and this is my team. Thank you very much.
Hello. Sir, have we identified the DNA of tuberculosis very comfortably? I mean, why is there is always a, if this DNA is that a final printout of everything, then TB के लिए हमेशा diagnosis में
आप मैडम TB बोलिए, आप नॉन TB बोलिए, दूसरे जो माइकोबैक्टीरियम बोलिए, आपके पास में यदि उसका काउंटर वाला फिंगरप्रिंट है तो डेफिनेटली इट विल गो एंड टच. देयर इज अ लॉक एंड की, इफ इट फिट्स देयर इज देयर. और बहुत ईजी है, इट इज़ नॉट एट ऑल डिफिकल्ट, प्रोवाइडेड यू हैव द अप्रोच टू आइडेंटिफाई इट, यू हैव द फैसिलिटी टू आइडेंटिफाई.
So TB PCR should be a good investigation for tuberculosis?
It is one of the things which we do. It is very simple thing.
But sir, Abhi, recently there was a patient whose Montus was positive. Both the tubes were blocked and TB PCR was negative. But then the patient insisted on laparoscopy. And we could see the beaded tubes and we could see tubercles all over. So, I mean, had I stopped there with TB PCR negative,
देखिए क्या है कि जब भी टीबी पीसीआर नेगेटिव या कोई पीसीआर नेगेटिव है, आइदर मैं गलती कर रहा हूँ आइडेंटिफाई करने में या वो व्यक्ति वहाँ नहीं है, तो दोनों फैक्टर है। यदि मेरी प्रॉब्लम में कुछ, इसलिए हम हमेशा साथ में एक कंट्रोल लगाते हैं, उस कंट्रोल का भी यदि पीसीआर नहीं हुआ तो मैं गलती कर रहा हूँ, यदि उसका हुआ इसका नहीं हुआ मतलब वो व्यक्ति नहीं है। सिंपल। प्रेगनेंसी टेस्ट में 2 गाढ़ी लाइन आई मतलब प्रेगनेंसी, यदि कंट्रोल लाइन आई टेस्ट लाइन नहीं आई नॉन प्रेग्नेंट, टेस्ट लाइन आई कंट्रोल लाइन नहीं आई किट खराब है, दोनों नहीं आई नॉन प्रेग्नेंट। इसमें उसमें थोड़ा बहुत फिर भी गुंजाइश है, इसमें इसलिए नहीं है कि आपका पीसीआर होगा ही नहीं यदि नहीं है तो। अब आप यदि बोलते हैं कि आपने लेप्रोस्कोपी किया और आप एंटी ट्यूबरकुलर देना चाहते हैं, 85 to 90% वी गिव एंटी ट्यूबरकुलर ट्रीटमेंट बाय आवर कॉन्शियंस। अदरवाइज एट प्रेजेंट व्हेन पेशेंट वाज अफेक्टेड बाय ट्यूबरकुलोसिस, यदि आप उस समय किए होते तो हो सकता मिलता। आज उसको एक्टिव नहीं है, इट ऑलरेडी डैमेज द ऑर्गन और बॉडी की इम्यूनिटी ने उसको दबा दिया, बट इट हैज़ ऑलरेडी गिवन द प्रॉब्लम।
Thank you so much, sir, for very insightful talk on genetic and molecular testing. And we all know now we have many genetic tests and we are doing that, and thus we are reducing the burden of genetic diseases, various cancers, various neurological diseases from our society. Like thalassemia hai, and like sir said, many neurological diseases hai. Down syndrome is there. So thank you so much, sir. Thank you so much for your insightful talk. I would like to thank Dr. Parimal Swami sir, Dr. Abhishek Shrivastava for inviting us here, and I would like to extend thanks from Jabalpur Obstetric and Gynec Society. Thank you so much.
As we head towards our second session, I would like to call the chairpersons of the second session, Dr. Nirja Dubey ma'am, Dr. Neeta Parashar ma'am, and Dr. Nidhi Jain, please to come on the stage. And the chairpersons and the speakers of the first session, please go for the felicitation to us. The speaker for the second session is Dr. Meghna Khurana, who is a PG student of NSCB Medical College. Dr. Meghna Khurana.
Hello. I'll invite Dr. Megha to speak about the use of immunoglobulins in the pregnancy. Please continue.
Good afternoon, chairpersons, respected faculty present over here. So I'm going to talk about the use of immunoglobulins in pregnancy and about reproductive immunology. So some failures remain unexplained, like recurrent pregnancy loss, fetal growth restriction, intrauterine fetal demise, early neonatal loss, and recurrent implantation failure. We don't know the cause of these conditions in 50% of the cases, and we could only rule out the causes or treat the other 50%. So recurrent pregnancy loss means 3 or more than 3 consecutive miscarriage before the age of fetal viability, that is before achieving 500 grams, or before 22 weeks as per WHO, and before 24 weeks as per RCOG. Primary RPL means there has been no previous successful obstetric outcome. However, secondary RPL means there has been more than one successful pregnancy previously, followed by recurrent pregnancy losses. So 2 or 3. So earlier we used to say it is 3 or more than 3 recurrent miscarriages, but we often start the investigations, evaluation and management after 2 recurrent pregnancy losses as per Rssearch 2017. So what are the causes of RPL? we know that genetic causes are involved. It is only about 5%, and anatomical causes around 12 to 16%, where Mullerian anomalies often septate uterus followed by bicorporeal uterus, submucous fibroids, intrauterine adhesions, cervical insufficiency leading to second trimester losses. Endocrine causes 17 to 20% of RPL, luteal phase defect, polycystic ovarian syndrome causing mid-trimester losses, primary ovarian failure, overt hypothyroidism, or overt uncontrolled diabetes mellitus, or hyperprolactinemia. Immune causes 20 to 50% of RPL, which can be alloimmune, autoimmune, inherited thrombophilias, in which factor V laden mutation is the most common primary coagulation defect, followed by prothrombin G20-210A mutation, which causes deficient prothrombin, increase in clotting tendencies. Then there is antithrombins deficiency like protein C, protein S, and antithrombin 3. Antiphospholipid syndrome can cause 15% of RPL. Of course, lifestyle factors, which is very common nowadays, that is obesity, stress, smoking, caffeine, drugs, and environmental factors. And of course, there is 50% RPL are unexplained, that is we can only treat the other 50%, and it is forms a lot of emotional and burden to the patient and the couple, and we often have to counsel the patient, counsel the couple that, you know, half of the time we don't know the cause, so it is a very stressful condition. Immunological factors in RPL. Antiphospholipid antibodies are heterogeneous group of autoantibodies that bind to the phospholipid or phospholipid binding proteins. There have been more than 20 antiphospholipid antibodies that have been described. So how do they cause these recurrent pregnancy losses? They interfere with the function of coagulation. So they cause increase in the procoagulants and decrease in anticoagulants. They bind to beta-2 glycoprotein, which itself is an anticoagulant. They bind to phospholipids on the trophoblast and inhibit successful implantation of embryo in the endometrium. And they also cause placental thrombosis and also the complement-mediated damage to the placentus villus cells. So how do we diagnose it? We all know that we need at least one clinical and one laboratory criteria. That is, there should be vascular thrombosis, there should be recurrent pregnancy losses, 3 or more than 3 at less than 10 weeks with other causes excluded, or 1 or more than 1 deaths of a morphologically normal fetus at more than 10 weeks of gestational age, or 1 or more than 1 preterm birth at less than 34 weeks of gestational age due to severe preeclampsia or placental insufficiency. And of course, laboratory criteria, one laboratory criteria has to be present, which includes 2 moderate to high titers on 12 weeks apart, that is either of lupus anticoagulant, anticardiolipin, or beta-2 glycoprotein. So when we treat antiphospholipid antibody syndrome with antithrombotics, we get a live birth rate of more than 70% with regard to no intervention. We can use low-dose aspirin after UPT positive status. Actually, low-dose aspirin can be started preconceptionally, 3 months preconceptionally, which gives very good outputs. And LMWH, low molecular weight heparin, earlier was started after confirmation of fetal cardiac activity, but now can be given only after UPT positive status. So there's no need to wait for the fetal cardiac activity. And also we can try IVIG or corticosteroids, but they don't have much benefit. So Rssearch 2017 says that when the laboratory criteria of APS has been fulfilled and there has been 3 or more than 3 pregnancy losses, we have to give low-dose aspirin before conception and prophylactic heparin at the time of positive pregnancy test, which is beneficial over no treatment. Heparin may decrease the miscarriage rate and improve live birth rate in unexplained recurrent pregnancy losses. So other therapies, steroids have not been really of any benefit, and intravenous immunoglobulins was superior to at least steroids with regard to live birth rate, number of miscarriages, and preterm delivery in antiphospholipid antibody syndrome. So in overall, we have to show some empathy to the patient. We have to start empirical therapy in recurrent pregnancy losses. That is, we have to rule out diabetes, thyroid, hyperprolactinemia, start low-dose aspirin or low molecular weight heparin, rule out immunological factors, and rule out other thrombophilias inherited or acquired. So other antibodies, there can be anti-sperm antibodies also causing recurrent pregnancy losses, or celiac disease sperm markers like tissue transglutaminase or endomycin antibodies. Natural killer cells, there has not been sufficient evidence to say that natural killer cells are involved in recurrent pregnancy losses when we check in the peripheral blood smear or in the endometrium or the uterine natural killer cells. Lymphocyte immunization therapy should not be used as a treatment for unexplained RPL as it does not have any significant effect. Prednisolone, as I already told, also does not have sufficient evidence. Intralipids, the live birth rate in women with recurrent pregnancy losses after intralipid treatment was similar to that after IV immunoglobulins. Granulocyte colony stimulating factors, the difference between the groups was not statistically significant, but there is still insufficient evidence. The role of IVIG, so live birth rate was significantly improved in women with recurrent pregnancy losses if treatment was started before conception. So like in antiphospholipid, we give low dose aspirin before conception. Here also we can give IV immunoglobulin before conception. So the benefits of IM immunoglobulins, so intramuscular immunoglobulins, the plasma levels are attained within 2 days, the half-life is long, 23 days, there's no interference with normal immune mechanism, there is no risk of anaphylaxis, provides immediate passive immunity. So we can give it for prophylaxis in case of following exposure to infectious agents or substitution in case of deficiency or for therapy in cases of generalized infections. It is given as IM injection only. We have to give 16.5 solution in vials of 2 ml, that is 330 milligram every 21 days. And these IM immunoglobulins are negative for HBsAg, HIV and HCV antibodies. So effect of treatment on case testing. There was a study done which analyzed the effect of treatment on cases testing positive for antiphospholipid, which is a prospective study. They included recurrent abortions, recurrent stillbirths, preeclampsia remote from term, unexplained abruption, and unexplained IUGR. And there were 2 groups. The first group was those who had a bad obstetric outcome, but they were now having an early pregnancy. And the second group was those who had a bad obstetric outcome, but they were still in the preconception phase. So for the group A, we gave HCG 5000 international unit every week till 12 weeks. We gave 16.5 ml of IV immunoglobulins IM, 2 ml every 21 days till 36 weeks. And we gave aspirin 75 milligram from 12th week till 36 weeks. And for group B, which came preconceptionally, we added aspirin and then followed the protocol, or we could add, in highly positive group, we added prednisolone 10 milligram per day and then same as protocol A. So we found out that the post-conception treatment, that is a group A, also had a lot of decrease in missed abortions, stillbirth rate, IUGRs, increase in the full-term delivery rates, and preeclampsia remote from term also decreased. However, in the group B, the efficacy of these drugs, they were more magnified, the effect was more magnified, so it told us that we have to start all these things preconceptionally. So unexplained RPL, scientific evidence, there are 2 independent risks of further miscarriages, that is increasing age and number of miscarriages are independent factors for unexplained RPL. There nothing much can be done about it. We cannot give false reassurance to the couple. We have to discuss about the empirical medical treatments, rule out other endocrine factors. We have to listen to the patient's wishes, counsel them, and respect their decision even if they are against the medical evidences. And now I'm going to talk about recurrent implantation failure, where another place where IV immunoglobulins have been used. So what is recurrent implantation failure? It is 3 or more unsuccessful IVF cycles or the failure of conception after the replacement of 10 or more good quality embryos. The factors are similar to recurrent pregnancy losses, however, more on the endometrium if there has been fibroid, polyp, inflammation, foreign bodies, thin endometrium, immunological factors, thrombophilias, or even genetic abnormalities, endometriosis, hydrosalpinx. All these might cause recurrent implantation failure. So the same drugs have been also advised in recurrent implantation failure with anti-TNF alpha adalimumab, intralipids, IV immunoglobulin, heparin, glucocorticoids, and aspirin. But the evidence supporting the use of immunosuppressive treatment in recurrent implantation failure is weak and difficult to apply in real practice. So take home message, reproductive immunology is poorly understood. Unexplained event is an enigma for the gynecologist. We need properly and adequately powered controlled, randomized controlled trials, and IMIG shows some promises. Thank you.
Thank you, Megha. It was a nice presentation. And moving ahead, we have now panel discussion on advanced maternal age pregnancy. As we all know, advanced maternal age pregnancy is defined as pregnancy occurring after 35 years of age. Nowadays, it's becoming increasingly common. And for this panel discussion, I would like to invite Dr. Manik Panse Madam and Dr. Komal Jain, who are the moderator of panel. And our panelists are, I would like to invite Dr. Rashmi Kuraria, Dr. Namita Tiwari, Dr. Falak Raza, Dr. Nimisha Sharma, Dr. Anjali Shah, and Dr. Meghna Tiwari. Over to you, ma'am.
स्टार्ट करें? 2 चेयर और चाहिए होंगी.
Well, as the panelists are getting ready, their chairs are coming. I just want to thank Dr. Abhishek, Dr. Parimal Swami, and Dr. Bharadwaj for dedicating one whole time of 1.5 hours on obstetrics and gynae. You all have discussed lot of obesity, lot of diabetes, thyroid, everything. And hypertension, and we are facing these things in elderly gravida. So you can imagine that our work has increased, and we always take your help. And here the panelists will tell us when to call for physicians, endocrinologists, and everyone. See, we are not here to discuss about why the girls are getting married late, but they are concentrating on their studies, and therefore the age of marriage is late. They're getting married after 35, and they are also planning this. Planning for family is least on their agenda, I should say. It's career, career, and career. By the time they think that they will have a baby, they are already elderly. And elderly are again divided into 3 groups. One beyond 35, that is advanced maternal age, then up to 40, that is again advanced maternal age, and 4th is very advanced maternal age. अब कुछ भी बोलिए, 35 के बाद में हम लोग के ऐसे जलने लगते हैं जब भी पेशेंट आती है, because she is a package of obesity, hypertension, some medical disorder. So we have to think about them, we have to explain them, we have to counsel them, and we have to treat them accordingly. So I welcome all the girls. We have 2, I always call my obstetricians girls because it sounds good. We have 2 senior people, Namita and Rashmi Kuraria, and rest of the girls are really very young, Falak and Nimisha, Anjali and Meghna. So now the thing starts. I'll hand over this to Komal. Just to start with the questions.
जैसे कि मैम ने कहा कि आजकल बहुत ही कॉमन है एल्डरली ग्रेविडा को ओपीडी में देखना. हो सकता है बिकॉज आजकल वुमेन करियर ओरिएंटेड हो गई हैं, उन्हें सेल्फ डिपेंडेंट होना है, फाइनेंशियल स्टेबिलिटी चाहती हैं, कई बार राइट मैच नहीं मिलता है, इमोशनल सपोर्ट नहीं मिलता है. तो आजकल मैरिज की एज ही बहुत डिफ़र हो गई है, बहुत लेट हो गई है. ऑब्वियसली तो प्रेगनेंसी होते होते बहुत एडवांस एज हो जाती है. तो जैसा कि मैम ने बताया कि इन द ओपीडी जब भी हम ऐसा एक पेशेंट रिसीव करते हैं जो कि हायर साइड ऑफ एज है, तो हम सभी जानते हैं कि हाउ मच कॉम्प्लिकेशंस वी आर गोइंग टू फेस. सो आज हमें ये पैनल करने का ज़रूरत महसूस हुआ कि इस बात को डिस्कस किया जाए ऑन अ बिग स्टेज, ताकि सभी आपस में हम इस बात को डिस्कस कर सकें कि हम क्या क्या फेस कर रहे हैं और हमें क्या क्या ट्रीटमेंट एंड इन्वेस्टिगेशंस और केयर ऐसे एंटीनेटल पेशेंट्स को देनी चाहिए. सो वी आर हेडिंग अवर फर्स्ट क्वेश्चन. I'm going towards Rashmi Kuraria ma'am for this question. What baseline investigations and risk assessment should be mandatory for all elderly gravid patients in the first trimester?
Thank you, Kumal. Elderly gravida patients are patients above the age of 35 years, and they are very much prone to maternal and fetal complications. So we have to be very keen on examining those patients. So the baseline investigations, first we have to take the full maternal history, personal history of the patient, any medical disorders previously the patient is having, like hypertension, hypothyroidism, or known case of diabetes. Previous surgical histories also we have to take, whether undergone any surgeries like myomectomy, and then personal history also, taking any medications for some mental disorders, for any epilepsy or these things. Plus, we have to focus on lifestyle also these days, because alcoholism and cigarette smoking is increasing day by day, and in higher societies we are seeing these patients. So the baseline investigations are full CBC count. We have to see for the CBC, we have to go for urine analysis, proteinuria, urine infections, thyroids, and HbA1c to rule out diabetes. We have to rule out GDM, renal profile, LFT we have to go because liver cirrhosis and alcoholism is increasing. Thyroid profile, we have to go for vitamin D also, because vitamin D in lower causes maternal and fetal bad outcomes also. So these are the investigations. Then we have to go for maternal screening, like HIV, hepatitis B, and then viral markers के अलावा अपने को maternal serum examinations also करने होते हैं. Thus, when we confirm the pregnancy, then we have to go for early initial pregnancy. To confirm the pregnancy, we have to go for ultrasound examination. And then for the continuation of the pregnancy, then 11 to 12 weeks pe we have to go for scans, NT-NB scan, and then maternal serum markers. And then in second trimester also we have to do the same thing. And for the follow-up, we have to go for scans so that the outcome of the baby is very good. And then the risk assessment when we have to do, then we have to again see that the patient age, if it is not her first pregnancy, if it's second, तो parity भी increase होती है, and why late pregnancies, and according to lifestyle. We have to see all these things, we have to judge, and then we have to go for a multidisciplinary approach basically. We need a gynecologist, we need a pediatrician, plus sometimes we need dietitians also, and follow-up scans like in 11 to 14 weeks we have to go for NT scan, and then maternal serum markers, and then we have to rule out Down syndrome. Plus, the last thing we have to go is the counseling of the patient should be very nicely done, because uska pura obstetric outcome depends upon the counseling of the patient. Whether she'll deliver normally, we deliver by LSCS, and plus what complications she can face about herself and for the baby. Like the baby can be preterm, baby can be macrosomic, she can go into non-progress of labor, she can go into obstructed labor, she can have LSCS.
Only first trimester we are talking about. Yeah, very rightly said. All the
counseling part should be done.
Yeah, the counseling part is very much important, as we have to explain the patient that as she is elderly gravida, she can have recurrent miscarriages also, as they are very prone for RPL. So we have to
SB also.
SB also. So we have to explain all the risks.
The important thing, whether she has conceived spontaneously or it's due to ART. That is also very important. Now, I think everyone is happy with whatever answers we received. The second question is, how do you tailor antenatal care protocols for a 40-year-old first-time mother compared to a younger low-risk gravida?
Because
Namita?
yes, ma'am. Because she is 40 plus, we are mainly concerned about the hypertension, diabetes, cardiac abnormalities, and uterine fibroids. And mainly we will do a medical checkup, proper medical checkup, because at 40 years there are more risk of lipid disorders, hypertension and diabetes, and she is more prone for the congenital anomalies as compared to young gravida. And multiple pregnancy, we will rule out multiple pregnancy, and mainly we are concerned about the cardiac problem and diabetes, hypertension, ECG we will do, and cardiomegaly.
Here I would like to add that all 35 plus patients should be given low dose aspirin, which is very important, and dual marker is important. And as Dr. Dipankar enlightened us that after dual marker, if needed, chorionvillus biopsy.
Ma'am,
and
nowadays we are
IPT.
doing dual marker and quadruple even
But
younger.
still, we should be very
gravida.
liberal as far as these invasive procedures are concerned in elderly gravida.
A fetal echo.
Yes, that is in second trimester.
Yes.
Okay.
Even an early scan is needed to know the multifetal pregnancy, because these elderly gravidas are more prone for twins or triplet, because they have higher FSH levels, so there is more oocyte formation and they can have a multifetal pregnancy. So there must be a scan also in the first trimester also, early scan.
Then their antihypertensive drugs should be changed with the help
We
of
will refer to physician.
And if she's already on metformin or anything, we can continue with it. And if she's taking some other drug, we can switch over to insulin as early as possible.
And the folic acid supplementation,
Folic acid
antioxidants,
deficient,
they are needed in antioxidants, and if they are obese, they should optimize their weight also. For
Exercise, moderate, mild walk we will advise.
Or if the pregnancy is through ART, then they can go for PGTA, pre-implantation genetic testing, where we can diagnose the anomaly or genetic anomaly in the fetus also. Yeah. For the next question.
What are the current best practices to mitigate the risk of hypertensive disorders and gestational diabetes in this population? Well, we are again and again telling the same thing, but this is important.
Yes, ma'am. To mitigate the risk of hypertensive and gestational diabetes, first we should evaluate that whether she is having these conditions beforehand, before pregnancy started, or she has developed these conditions in pregnancy. So, ma'am, in first case, in hypertensive disorders, we should call her for regular antenatal visits. In first trimester only, we should divide her into two groups, that if she is having essential hypertension or pregnancy-induced hypertension. And we should treat her accordingly then. So, ma'am, first we have to guide her, like what precautions, diet according to this salt-restricted diet, regular exercise. In each trimester, we should advise her regular exercises. And we all know the treatment of all antihypertensive drugs. Labetalol is the choice of drug. And then we should treat her accordingly, checking her BP in each antenatal visits. Then we should definitely tell her warn her about the signs of eclampsia. Because if she develops these signs, she should immediately come to us. That are, as we all know, nausea, giddiness, vomiting, epigastric pain, blurring of vision, headache. She should come to us. She should also monitor her fetal movements also, because risk of IUGR, oligo, abruptio is more in this group. So in hypertensive cases, we should accordingly treat her. Then in diabetes, again, if she has diabetes beforehand or she has developed it in pregnancy, we should get her first trimester, we should get her all HbA1c, fasting PP, everything. We should tell her to buy her glucometer, and she should regularly check her glucose values and make a chart and come to us with that chart, so that we can guide her much better regarding her medications. And if it is controlled, are able to control with the medicines, then it's okay. Otherwise, switch on to insulin. We should counsel her and tell her about regarding the risk of hypoglycemia, because when we give these drugs, they are very prone to hypoglycemia, which is more dangerous for the fetus. So we should tell her about the signs if she has frequent fainting attacks, or she has sweatness or giddiness. So she should come. And if there are signs of just ketoacidosis, that also excessive nausea, vomiting, then she should also come back to us. Regular diabetic diet, you can consult a endocrinologist, or we can give her a dietitian which she can consult her regular diet with. And exercise is also very important for her. Fetal kick count is important for her, and we should control her diabetes and hypertension with that.
Nicely explained, Palak. Could you please explain the drug of choice?
Ma'am, in case of hypertensive disorders, labetalol is the drug of choice, and then nifedipine, second line. If best is labetalol. And if she develops preeclampsia, eclampsia, then we have to go for Maxelf and all. Otherwise, we can control it very good with labetalol.
Very well explained. As there is decrease in beta cell, pancreatic beta cell activity, so these elderly patients are more prone for diabetes. And as there is a decrease in vascular compliance, so they are very prone for PIH. So very well explained these both the diseases. Now for the next topic, for the next question, what are the most common intrapartum challenges you face with elderly gravid patients, and how do you address them? Nimisha.
Hello ma'am, good afternoon. Most common intrapartum challenges that we can see in elderly gravida patient depends upon what comorbidity she is having beforehand, and has she landed up into labor spontaneously, or was it an induced labor. If she was hypertensive before and she goes into spontaneous labor, then we most commonly see abruptio placenta in such patients. We have to explain to the patient beforehand only that while she reaches her due date or while she goes into labor, she can in any time land up into abruptio placenta if she's already hypertensive. And if her BP increases during her labor, we can give her prophylactic Maxelf also to prevent eclampsia in such patients. And we can also face prolonged labor in elderly patients because of the anxiety they face, because of the exhaustion. If she is already obese, then we will have to counsel her regarding the PPH in which she can go. We have to counsel her regarding she might land up into cesarean section also. If she is already GDM, then also during intrapartum we have to continuously monitor her glucose, that she doesn't, due to dehydration, due to hypoglycemia, she may land up into decay also, leading to fetal distress and leading to cesarean sections. So intrapartum, other challenges that we can face is prolonged labor, loss of inertia, uterine atony.
And very important is stillbirth. They are very prone for stillbirth.
Yes.
So,
so we have to continuously do CTG of such patients and see for the decelerations or the variability changes in her NST.
They have less oxytocin receptor sensitivity, so there is less uterine contraction.
Yes.
So they are prolonged labor. They are prone for prolonged labor. Okay.
Though we should tell them that normal delivery or the vaginal birth is very easy, but we should not stretch it too long, because if they are diabetic, they might have big babies, silent IUDs. Hypertensive disorder, they will have fetal growth restriction, and of course their anxiety is there. So we should not stretch it too long. Now the next question is, yes, there is one more thing, that is lactation failure can be there. So we should encourage them from the antenatal period. The fifth question. Do you favor elective cesarean section over trial of labor in elderly primary? Why or why not?
Hello.
Thank you, ma'am. Actually, a normal vaginal delivery is not a contraindication in such patients. But these patients are elderly, more educated, more understandable, and they are having more comorbidities. Depending upon the comorbidities and patient condition, and depending upon the institute where she is delivering, where 24 hours anesthetist available or not, 24 hours obstetrician blood bank available or not, we can individualize the case. We cannot 100% offer elective LSCS, we cannot 100% offer trial of labor. Everything should be individualized, but before patient reaching into term, we should counsel the risk factor and the complication she can land up during the labor. Whether if patient wants elective LSCS, we can go, but everything should be written and informed. Patient wants trial of labor, we can go for trial of labor depending upon the patient's condition and complication, and also the depending upon the her bishop's score. If the patient is conceived through assisted reproductive technology, a patient is more than 40 years old, it's very less. So we should offer elective LSCS in such patients. But if patient is multigravida with previous normal vaginal delivery and without any comorbidities, then trial of labor can be given.
वेरी गुड. यानी कुल मिलाकर हमें उन्हें समझा देना चाहिए कि यू हैव सच रिस्क. अगर फिर भी वो चाहती है तो यू कैन गो फॉर नॉर्मल डिलीवरी ट्रायल, बट अगर हम उन्हें काउंसिल करें, उनकी पोजीशन सारी कंडीशन समझाते हुए, तो दे कैन गो फॉर इलेक्टिव एलएससीएस आल्सो. इट्स ऑन देयर चॉइस. As they can have labor dystocia if there is a big baby. There is more chances of placental abruption. जैसे हमारी बात हुई, placenta previa is very common in those. Multifetal pregnancy is very common in elderly gravida. There is less uterine contraction. If the first baby was through LSCS, then there can be uterine rupture also. So we can explain them. The pros and cons, we should explain them, and it's on her and her family decision what the process they want to do.
One more thing, a good neonatologist should be around.
Yes, ma'am.
That is very important.
Yes, ma'am.
And if she opts for it, then epidural anesthesia can be given.
Yes.
Okay?
Yes.
Now the next and last question. How does maternal age influence your threshold for intervention during labor, especially in cases of borderline CTG or slow progress? Meghna.
Very good afternoon, ma'am. Ma'am, actually these elderly gravidas already have pre-existing conditions like diabetes, hypertension, thyroid. So we should not force them to be undergoing this normal delivery. As the patient reaches term, we should do her pelvic assessment. And in labor, we should do electronic fetal monitoring, as they are high-risk patients for stillbirth and adverse neonatal outcomes. And if there is borderline CTG or no acceleration, we can repeat the CTG for next 40 minutes. If then also there is abnormal pattern of CTG or non-reassuring, we can go for the biophysical profile. And according to the biophysical profile score, we can proceed further. If it is 10, then we can continue our line of treatment. If it is 8, and if there is no oligo, we can continue. But if it is oligo less than 2 centimeter vertical pockets, then we should not, we should expedite the delivery. And when it is 6 or less than 6, we can go for the expedition of the delivery. And if the bishops is poor, then we can go for the elective cesarean.
Yes, very well explained. Other measures like hydrate the patient, give her oxygen, left lateral position, try all the measures. If it's still there is CTs is not assuring, then go for elective LSCS. बहुत ज़्यादा हाइपर स्टिमुलेशन ऑफ दीज पेशेंट्स नहीं करना चाहिए. लाइक मीज़ो पे मीज़ो दे रहे हैं, CP जेल दे रहे हैं, बहुत ज़्यादा हाइपर स्टिमुलेशन इनके यूट्रस का नहीं करना चाहिए.
Well, to conclude, we should. Can anyone tell us about how the postpartum period should be tackled in such cases? Because they usually land up with decreased lactation or no lactation at all.
Ma'am, it's most of the emotional support to the patient which we need to give and their families need to give, ma'am. And if it is after that emotional support also there is cracked nipples or anything we can cure, or otherwise, ma'am, we can prescribe her galactogranules and other things.
Thanks a lot, all the girls. And to sum up, I would say the maternal care should be inverted pyramid. पहली बार में ही उनको सारे प्रॉब्लम्स बता दीजिए. टू बिगिन विथ, एल्डरली ग्रेविडा है, आपको ये हो सकता है, आपको ये हो सकता है, आपको वो हो सकता है. सारा कुछ पहले 3 महीने में ही बताइए. सो ड्यूअल मार्कर, कोरियनविलस बायोप्सी, whatever we want to do, we should do. And after that we should call them. हो सकता है ज़्यादा फ्रीक्वेंटली बुलाना पड़े. उनके साथ काउंसलिंग, उनके हस्बैंड को भी बताना पड़ेगा, बिकॉज दीज गर्ल्स आर यूजुअली वर्किंग गर्ल्स, तो उनका घर में सपोर्ट कैसा है ये भी देखना पड़ेगा. और क्या बोलना चाहिए, एल्डरली ग्रेविडा आते हैं तो हमारे सारे एंटेना खुल जाने चाहिए और हमको उनको थोड़ा ध्यान से देखना चाहिए. दिस में बी द ओनली टाइम दैट शी हैज़ कंसीव्ड, तो थोड़ा ज़्यादा ध्यान देना चाहिए. Thanks a lot. I would ask senior physicians are sitting there if they can add कुछ एक चीज़ें मैं हम लोग जो करते हैं, that is OGTT, we do it routinely, वो करते ही हैं. और कुछ आप अगर हमको बताना चाहेंगे कि हमने और कुछ ऐड करना पड़ेगा, आपकी मदद हम लेंगे. अभिषेक डेंगरा, दीपक बहरानी, ये तो हमारे पुराने लोग हैं, लेकिन और कुछ अगर आप हमको सुझाना चाहेंगे that we have not included in our panel discussion. So you all are most welcome.
वैसे भी जब हमसे GDM नहीं संभलता है तो हम आप ही लोगों के पास भेजते हैं.
नहीं मैम, एक पॉइंट है कि ओल्ड एज ग्रेविडा हैज अ हायर डिग्री ऑफ एंडोथेलियल डिसफंक्शन एंड chronic inflammation. Aspirin is the drug where it has proved to be decreasing the inflammatory profiles and endothelial dysfunction. How do you see calcium supplements in reducing the higher degree of oxidative stress or dysfunction? How do you see? How much do you rate aspirin and calcium together? Whether aspirin is there, but how would you rate calcium supplements also in
Calcium supplementation is very much important in pregnancy, and we always give to all patients to calcium supplement.
So it should be, right? Is it mandatory to give calcium?
Yes,
or yes, we should.
It is mandatory to give calcium to all pregnant women up to 9 months. It started from 4th month. We give all patients calcium.
All, since we start the treatment of infertility, so the role of calcium is very important.
Even in the
and in our IVF patient, we give from periconceptional period, during conception, and all the trimesters. We give calcium, plays very important role,
Then
especially in PCOD patients.
Yeah, the finally.
In first trimester also we can give?
No, generally first trimester.
In our IVF patient, we continue calcium also.
In IVF
during
patients, they continue. But in
especially
the
PCO
practice,
patients.
In the general practice, we give after first trimester calcium we start. Yeah, to sum up, finally, there are some recommendations for the elderly gravida. First, the counseling is must. Second, the low dose aspirin is compulsory to give all patients. Number 3, there should be an early dating scan and an early scan to know the multifetal pregnancy. Number 4, there must be an anomaly scan at the age at the fifth month at the 20 weeks. And number 6, the detailed fetal surveillance should be done in all these patients. And the 3rd trimester, there must be a growth scan to know, because they are very much common to stillbirth, they are very much prone for stillbirth. So in 3rd trimester, there must be a growth scan. And lastly, the uterus must not be very much hyperstimulated in these patients. There must be, elective LSCS करने में ज़्यादा डरना नहीं है. We must explain all the conditions to these patients. And in the postpartum
postpartum period, as they are very much prone for decreased lactation, there must be an emotional support to all these patients. Okay, thank you all.
Thanks a lot. Thanks a lot all the organizers. Because we get one patient and हम दो को वापस भेजते हैं.
Yes.
तो हमको ज़्यादा ध्यान देना पड़ता है.
Definitely. इमोशनल सपोर्ट जो कोमल ने बोला, जो आप लोग पूछ रहे थे कि जीडीएम में क्या सबसे इम्पोर्टेंट है, तो दैट इज़ वेरी वेरी मच रिक्वायर्ड, क्योंकि वो डर जाते हैं कि हमको इंसुलिन लगाना पड़ेगा, खाना बंद हो जाएगा, हमारे बच्चे की ग्रोथ नहीं होगी.
मैम, आप लोगों से एक और रिक्वेस्ट है, दिस इज द लास्ट सेशन, लास्ट 5 to 7 minutes डॉक्टर आशीष डेंगरा विल स्पीक ऑन इस.
नई दवाई आई है, डायबिटीज की नई दवाई है, तो वो बस सुन लीजिए 5 मिनट.
ड्यूअल नोवल ड्रग इमिग्लिमिन, जस्ट 5 minutes, एंड फिर उनका डांस भी देखना है हमें.
Welcome, sir. I would like to call our chairpersons, Dr. Ankit Seth, sir, Dr. K.C. Chopra, sir, and Dr. Sushil Kelly, sir. Please come up on the stage.
Thank you Abhishek and RR team and CCDSI for inviting me here to deliver a very important talk on the imiglamin, that is the mitochondrial saver. Because in diabetes we know that there is decrease in the insulin secretion and there is insulin resistance, and there is now the newer theories are coming that there is mitochondrial dysfunction also. So imiglamin is a powerhouse approach. So over to respected chairpersons. Yeah, thank you. So it is a powerhouse to type 2 diabetes approach. As we all know that it is having the increased incidence of diabetes day by day in India. In Southeast Asia, there is 73% increase will be there from 24 to 2050. So still a lot of patients have to be dealt in the future. So we require a drug which takes care of all the pathophysiological parameters. We know that 1 in 10 adults have diabetes, and India accounts for 1 in 7 of all adults living with diabetes worldwide. So diabetes metabolism is beta cell dysfunction, resistance, and gluconeogenesis is more from the liver. So limitations with current therapies are, some are taking care of insulin resistance, some are taking care for the insulin secretion or incretin pathway, or the GI absorption of glucose is hampered, and the TZDs, they improve the insulin resistance and SGLT2 through the renal glucose excretion. But none is taking care of all the things together. So a treatment option is the need of hour, which takes care of the insulin secretion and resistance, decreases the hepatic glucose production, increase the peripheral glucose uptake, and decreases the beta cell apoptosis. Favorable should be their safety and tolerability, and the new thing that is correcting the mitochondrial dysfunction. What happens in the diabetic patient that there are 3 major functions of mitochondria relevant to diabetes. While you can see the cytochrome 1, 2, 3, in normal population, the pathway goes towards the right side and they causes the decrease in insulin resistance and proper insulin secretion is there. But when the diabetes develops, there is the more production of reactive oxygen species, apoptosis is more, and ATP generation is hampered. So this TCA cycle disturbed due to the mitochondrial dysfunction. Why? Because of the glucotoxicity, lipotoxicity, or the environmental factors. It leads to the increased reactive oxygen species, lipid accumulation, and ETC leakage, which leads to the cellular injury, decreased insulin action, and cardiovascular dysfunction. Ultimately, there is insulin secretion is decreased and resistance is increased, and diabetes is seen in the population, those who are having these pathophysiological parameters. So what this drug does, it combats the mitochondrial dysfunction. It is the first drug of the group of oral tetrahydrotriazine compound which is having the action on mitochondria. So it is a novel drug with a differentiated mechanism of action. It targets the mitochondrial dysfunction, approved in Japan in 2021, and it is approved by DCGI in India, and clinical trials have been managed by Poxel and Sumitomo. So how it works? Imiglamin leads to increased fatty acid oxidation, it leads to production of acetyl coenzyme A which enters the TCA cycle. This increases the flux through complex 2 and complex 3, and the reverse electron transport from 2 to 3 is hampered, which result in decrease in the ROS production. So this is the basic feature, that it prevents the back pathway from 2 to 1 and it promotes the forward pathway from 2 to 3, which produces the better acetyl coenzyme A profile, and the ATP generation is in the positive direction and reactive oxygen is reduced. You can see here it works on the, when the pathway is there nicotinamide to NMN, NAMPT, it works on that and causes the positive ATP generation, and insulin secretion is improved. So the molecular mechanism by which immunoglobulin it works, it improves the glucose homeostasis by decreasing the oxidative stress, insulin sensitivity is improved, gluconeogenesis is decreased, and mitochondrial dysfunction is improved, along with beta cell apoptosis is reduced. Immunoglobulin positive pathway towards the C2 to C3, it causes the increased glucose utilization in muscles and in liver, and it increases the glucose utilization in liver but decreases the gluconeogenesis, which is the culprit in diabetic population. Increase the pancreatic beta cell function and reactive oxygen species is decreased, so beta cell apoptosis is decreased. So it provides novel approach to treatment of type 2 diabetes due to its unique mode of action and having the insulinotropic and insulin sensitizing effect. So this is a novel agent which is working on the mitochondrial pathway and causes the positive direction towards the decreasing the insulin resistance, improving the insulin secretion, and decreasing the beta cell apoptosis. What are the side effects? All OHAs have some or other side effect, this we all know. The immunoglobulin is having mild GI bloating or acidity problem, as we see with the metformin, because it mimics the metformin group also, like this. So immunoglobulin versus metformin, immunoglobulin contains a biguanide substrate bearing similarity and cyclopentan ring differences with metformin. So there are little similarities and little differences. That's why it promotes the mitochondrial respiration, which is hampered by metformin, and that's why we say there is lactic acidosis possibility with metformin. So C1 non-competitive inhibition is there, but with immunoglobulin there is C1 competitive or partial inhibition, and that's why it restores C3 function. And reactive oxygen species is decreased. When they have studied with the 500 milligram, 1000 milligram and 1500 milligram, they have seen the reduction of HbA1c was 1%, 0.94% and 0.52% respectively. But with the 1500 milligram, there were more GI side effects, but the difference of A1C control was not much between the 1500 and 1000 milligram. That's why the recommended dose is 1000 milligram BD, which is showing good HbA1c reduction. This is the CGM before and after the immunoglobulin. You can see before it was going up, then the snakes have been settled to the normal profile. In the CGM also they have proved. This is times 1 study as a monotherapy. It has shown the reduction of HbA1c by 0.87%. As an add-on, it has shown the reduction of 0.56 to 0.92. And as a insulin, if the patient is already on insulin, if you require a good sensitizer along with the reduction in HbA1c, when added to insulin after 52 weeks, it was 0.64% reduction, and after 36 weeks, it was 0.54% reduction. In Indian patients, there has been done a trial, because previously it was done only in the Japanese patients. It is the Indy Times which has been launched, and latest largest study on immunoglobulin on 8,000 patients, 190 centers, published in Diabetes Therapy. It is the largest Indian study on immunoglobulin in the 191 Indian sites. Duration was 3 months and HbA1c was 7 to 9%. They have seen as a monotherapy, as a dual drug therapy, and in combination with 2 or more drugs. All the patients have been selected. Sorry. So the primary endpoint was fasting, PP and HbA1c reduction, and secondary endpoint was what were the other medications prescribed. What they have shown, the HbA1c reduction was 1.12%, fasting reduced by 29, and postprandial reduced by 62.41. This you can see. So comparison between the mean HbA1c of across the overall study population, when they have shown as a monotherapy, double drug therapy or triple drug therapy, it ranges between 0.81 to 1.43%. This is the HbA1c reduction as per the treatment group. Monotherapy 1.12%, 1.11 with dual drug, and triple drug was 1.13%. So it is having a good HbA1c reduction property with fasting PP reduction of near about 28 to 67 postprandial. Then HbA1c most common dual drug therapy, when sulfonylurea was used along with this, it was 1.15, then 1.12 with bigonides and 1.06 with DPP4, and similarly with SGLT2 and insulin 1.11. This is again the pictorial representation of the same thing. The mean fasting PP reduction was better, ranging from 34 milligram to 47 milligram of postprandial. The safety profile, when they have seen the liver, lipids and renal, they have all shown in the positive direction. That is, there was improvement in SGPTOT, there was improvement in the lipid profile, and even the serum creatinine reduced in this study from 1.19 to 0.9, and p-value was significant. Adverse events, mild GI side effects are there. Abdominal pain, nausea, vomiting can be seen in very small number of patients. This was the SR 1000 milligram imiglamin in the patients when used in inadequately controlled diabetes. The 24 weeks trial, in the patients have received imiglamin, and on the another arm they have received metformin. So what was the result? When they have compared as a monotherapy, imiglamin monotherapy, once daily 1000 milligram proved non-inferior to metformin in improving the glycemic control with better safety and tolerability. They have shown the HbA1c fasting PP reduction in the good amount by 0.7%. This is the Japanese Society Diabetes Consensus Statement. They are now including in the obese and non-obese patients the imiglamin after the use of all the common agents. If the patient is not willing for insulin, you can add this agent and get the good results. Safety and efficacy, a case control study by Prabhat Agrawal et al. They have shown the better efficacy, and in patients with metformin intolerance, if we use as a monotherapy as a first line agent, again it has shown the positive benefits. In the cardiovascular part, with cardiovascular benefits, superior GI tolerability and a potentially lower risk of lactic acidosis, it emerges as an alternative in individuals with metformin intolerance, and it suggests imiglamin to be used at various stages of diabetes and safely. CV efficacy by Hiroki Kitakata, they have proven heart failure preserved ejection fraction, it is safe, so it is used, it has shown to improve the systemic glucose metabolism and visceral obesity, but reduce the systemic inflammatory condition and prevented the development of heart failure in the mouse with preserved ejection fraction heart failure model. Lactic acidosis is very rare, as I have told you in the initial slide, that it is cytochrome moving from the 2 to 3, not from the 2 to 1, which causes the more chances of reactive oxygen species. So it is reduced the risk of lactic acidosis compared with metformin. And what is the dose in renal patients? Because it is excreted through kidneys, but it is unchanged. So 500 milligram twice daily if the GFR is between 15 to 45, and if it is below, then we have to use it in the single dose of 500 milligram. With the QT prolongation is again a question which was raised by the gliptins, tenaligliptin, but in this they have proven that to be safe, they have used 6000 milligram supraphysiological dose, but still the QT prolongation was not there. After the supratherapeutic doses, there was no QTC prolongation. So single solution managing type 2 diabetes and two concerns, that is the insulin resistance and secretion. This drug causes the improvement in the insulin secretion, resistance is decreased, gluconeogenesis is decreased. So take home message is mitochondrial dysfunction is the common thread linking beta cell failure and insulin resistance and increased gluconeogenesis, which is taken care by this unique drug imiglamin, which restores the metabolic health to correct both the facts of the type 2 diabetes. It acts simultaneously on pancreas, liver and muscle, and it marks a paradigm shift targeting a root cause of diabetes, and it has shown good efficacy either as a monotherapy, double drug therapy or a triple drug therapy by reduction of HbA1c by 1.12% after 3 months of immunoglobulin therapy in the real world evidence. So thank you, thanks a lot for patient hearing. Mic do sir ko.
Metformin in pregnancy, is there any recommendation for that?
In pregnancy it is not studied yet, but in future we may have some studies. That is a very good question, that in pregnancy like metformin is safe, whether it is safe or not. You can write to the company, Ansari ji, that in pregnancy they can do the studies.
अगर metformin के साथ use करें तो कितना HbA1c नीचे लाता है?
It causes reduction by 0.9%. Very good reduction.
Yes. Along with concomitant with insulin.
Insulin also it is very. In all ranges we have seen it is having near about 0.8 to 1% reduction.
Thank you so much.
Thank you.
सर यहीं पे आ जाइए, यहीं पे फेलिसिटेट करते हैं सर, आप लोग यहीं पे आ जाइए। और स्पेशल अवार्ड केली सर के लिए, मतलब सबसे ज्यादा जो इंटरेक्टिव है
बेस्ट क्वेश्चन अवार्ड सर को। थैंक यू, थैंक यू, थैंक यू।
लाने वाला मुझे डेंगरा, मैंने पहला एग्जाम दिया था, इसने किताब बताई थी और मैंने 96%
लेजेंड नहीं
2 दिन में जितने पेपर्स थे, एक साथ।
थैंक यू।
I request everyone, please
ये
clap
सर को
for
देना है।
sir. Please clap for sir.
थैंक यू। सर का थैंक यू।
So this is the end, not the end, it's a beginning, but इस साल का
पार्ट 4
पार्ट 4 the end। और डॉक्टर ढींगरा से बेहतर कौन इसको एंड कर सकता है? नहीं।
थैंक यू।
तो आई वुड रिक्वेस्ट all the doctors, faculties, those who are available here to please come to the dais. Dr. Komal, ma'am, yes, please.
ये भी देना सर का।
वाजपेयी मैम, यस, आप लोग एक बार स्टेज पे आ जाइए प्लीज। हाँ हाँ, चाय पी लीजिए, चाय पी। कोमल, कुसुम मैम, प्लीज स्टेज पे आ जाइएगा।
सर,
वोट ऑफ थैंक्स एंड ग्रेटिट्यूड, आप लोग आए,
यू
हैव मेड दिस इवेंट अ ग्रैंड सक्सेस। ये तो है,
हम लोग साथ एग्जाम दिए हैं, पढ़े हैं, 2008 की बात है।
8 नहीं, ये तो है सर।
इस लहर को लाने वाले
डांस करवा दो, ये कहो ना सीधे। केली सर इसलिए तारीफ कर रहे हैं कि एक डांस हो जाए ना डॉक्टर ढींगरा का, भैया एक डांस सब लोग देख ले, हम लोग भी। आज जो यहाँ पे वो लोग भी ढींगरा सर का डांस देख ही लें। मेरे ख्याल से जॉग्स में कभी हुआ है क्या डांस? नहीं ना, बस अभी आप लोगों के लिए देखें।
फोटो सेशन,
फोटो सेशन नहीं, डांस होगा। हाँ देखा, अभी देखो आप, मैं अभी आपके लिए। हाँ, अब देखो आप कैसे डांस होगा।
लगवाओ आपके आ जाने से। नहीं आई, आइए। अंसारी फोटो लो। ये रख दो, तुम्हारे झोले खत्म हो गए इस बार। नहीं, हमने तो ऐसे ही दे दिया उसको। तुम सही में लगा दिए क्या? फोटो हो जाना, आजा तू इधर आ.
So with a heartfelt gratitude to all estimated speakers, delegates and guests, now we are concluding today's conference. Thank you all of you for active participation and valuable presence. Let us carry forward the knowledge shared today and yesterday into impactful practice. We hope today's and yesterday's session inspired new perspectives and strengthened our commitment to patient care. Wishing you all safe and a happy journey. Thank you all.
Thank you.
Now it's time for sir performance.